able to speak to you today for a variety of reasons, and I have permission not to use my mask, which is really the best. I'll be putting it on right afterwards. But good morning. My name is Dan Sterman, and I am a pulmonary and critical care physician at NYU Lang Health in New York City, and a member of the Foundation's Board of Directors at the Mesothelioma Applied Research Foundation. And actually, I have a long-standing history with the foundation dating back almost to its inception. So it's been an organization that I have incredible fondness for, and it's one of my favorite symposiums that I'll ever be at because of the connections between patients, families, physicians, and scientists that's so incredibly unique. I wanted to welcome you to this year's symposium. I believe it's the first symposium since the pandemic, and so it's extra special for all of us and for what we've all been through as a global community. To be able to be together, support each other, and learn together is incredibly impressive and exciting for me. So on behalf of the board, our scientific advisory board, our community advisory board, the staff, the volunteers, the people who run the summit, we're thrilled that they're helping make this event happen today, and welcome. We're glad that you're either here with us at home or virtually, and we really hope that you'll enjoy the entire experience today. It's also my pleasure and honor and privilege to turn over the mic to our new executive director, Julie Powers. Julie.
Thank you, Dr. Sterman. Okay, mask off and glasses on. Middle age is hard. Good morning and welcome everyone to the 2022 International Symposium on Malignant Mesothelioma. Again, my name is Julie Powers. I'm almost a year into being the executive director of this incredible organization and community, and I am so grateful for the opportunity to serve. You guys have probably seen emails about who I am and what I do, but I'm a dog parent and I dragon boat. There you go. That's all you need to know about me. I also bring you greetings on behalf of our board chair, Marjorie Zotterer. She's an oncologist at Memorial Sloan Kettering. Marjorie had hoped to be here in person today to welcome all of you. Unfortunately, she had a family emergency. She will be joining us virtually in the scientific meeting, and she is facilitating that meeting along with Dr. Pikert. I also want to say thank you to Dr. Hedy Kindler. Dr. Kindler, there you go. Dr. Hedy Kindler, as many of you know, is one of the foremost experts in mesothelioma. She's based here at the University of Chicago, and she has graciously agreed to serve as our faculty director, also known as wrangling the team at the foundation, to make sure that the sessions meet the needs of our patient community. I also want to say good morning, and I want to acknowledge many of our board members who traveled here today to be with us in person. Jessica Blackford-Cleeton, Cheryl Brunner, Keith Cengel, Dr. Keith Cengel, Darcy Cristal, Dr. Jason Foster, Berkeley Opalaki, Dr. Dan Sterman, who you just met, and Bill Ziegler. I also want to say hi to, or introduce our team. Most of you who've been with the foundation for any period of time are familiar with Muaiad Bellameric. Her title has operations and communications in it, but it's she who gets it done is her real job, and my right hand. Many of you have had the opportunity recently to meet our new patient services director, Shannon Sinclair. Shannon, you want to wave? And at the front desk, checking in, you probably met Megan Butler. She's in the back of the room. If you have any questions or concerns about the facility, you talk to Megan. She'll take care of you. And her sidekick is our intern, Nikki Yost, who is probably at the front desk. And then we also have Katie Jameson, who is a patient and works for us part-time to help us plan things. I wouldn't be here today, and many of us wouldn't be here today if it weren't for Mary Hasdorfer. And I know that she's watching. Hi, Mary. But she wanted me to give her best to all of you and how grateful she was for the opportunity to be part of this foundation for so many years. And she is loving retirement. So, again, thank you so much to all of the board members who are here with us and our incredible crew of volunteers and vendors who have stepped up to help us. Our AV crew is Uno Deuce Media. They're based out of Michigan and owned and operated by one of my best friends. Paul, you want to wave your hand? He's the guy who makes the magic happen along with his team. I do want to also make sure that we thank Dr. Pikert, who came in. He will be leading the scientific meeting with us, he and Dr. Zotterer. Events like this don't happen out of thin air, and we do need resources to make that happen. And we are here today and having a really neat event because of our sponsors, the fine folks from MRHFM, Bristol Myers Squibb, Novacure, Merck, the Gori Law Firm, TCR Squared, AstraZeneca, the Early Firm, and Vogel Zhang Law. At the breaks, we invite you to go out and check out their tables. Many of the folks from from our wonderful partners are here, and they'd love to talk to you about what they do and how they're part of the meso community. So you all know this was a challenging conference to put on, from QR codes to crazy weather to masks and testing and vaccines. And so we made this a hybrid event to keep everyone safe. So we appreciate that you all have taken the steps that we ask you to do upon the advice of our medical community. That means that unless you are actively eating or drinking, we ask you to wear your mask. Those people who are at the podium and at a distance will be unmasked in order to make sure that our folks at home are able to understand everything that we're saying. But we do ask that you do that in order to keep everyone safe. Folks in the mesothelioma community are medically fragile, and so this is to just keep everyone safe. We care about you, and we want to keep you here as long as possible. We made some compromises as well. We kind of thought, oh, we were going to get a couple hundred people in person, but instead we flipped it on its ear. Obviously, you guys can see who's here in person. This is a great size of a room. This room normally accommodates twice as many people, so we made some choices. We also have well over 100 people who are watching live right now via our website. And all of the sessions here in our community conference will be recorded and available on our website within the month. The scientific meeting will be taking place here at the same time, so the leading experts in mesothelioma will be down the hall. They are going to be discussing frontline therapy, second-line therapy, third-line therapy, clinical trials. They will be talking about prioritizing research into mesothelioma and creating centers of excellence for mesothelioma treatment. They have a robust agenda, and then they will come back and report out at the end on where we're going. We've positioned it as the Great Debates, and we know that will hopefully advance the science and find more better treatments and cures. I also want to say that our bereaved community will be meeting separately, and I want to take a moment. Maria and Anna, where are you guys? Where did they go? Oh, they're out in the hallway. Maria and Anna are leading our bereaved sessions, and they will escort you out at the end of this session because this is the room for our community. This is the big room. This will be Mesothelioma 101 and a variety of wonderful sessions that you can see in your program. But our bereaved community is meeting separately, and scientific meeting will be meeting separately. And now time for some housekeeping announcements. This is the fun part. Now, I mentioned the QR codes. Did everyone get a QR code to get in the building? If you want to eat outside for lunch or go outside, you need your QR code. Turn your brightness up full blast. It's the only way to get through that. But be sure to have that QR code. It's the only way to get in and out of the building. Our staff will be available to make sure that you can get in and out just in case. I also, in this room, we will be doing Mesothelioma 101 featuring Shannon Sinclair from the Foundation, but I'll introduce Shannon in just a moment. The most important thing is the restrooms. When you came off the elevator, ladies' room is to the right, gentlemen's is to the left. So that's where the bathrooms are. And I think everyone found the food, but in the event that you are feeling hungry, there is basically continuous food and snacks. Breakfast is out there right now. Coffee and tea and other drinks will be available the entire duration of the conference. At lunch, we invite you to grab your lunch. You're welcome to come back in here. You're welcome to go outside. You're welcome to sit out there in that cafeteria area. So we want people to spread out in order to promote good practices and safety. We want you to do that. Finally, again, with the masks, the only time we ask that you remove your mask is if you're actively eating, drinking, or if you are a person who is speaking at a conference, at the conference. That's pretty important to all of us. So I know it's frustrating. I know it's hard. We all get hot and sweaty, and it kind of ruins our makeup, which is, that's an issue for me. But we want to make sure that we keep everyone safe. So at this point, I want to invite everyone to, for those folks who are staying in this room, stay put. For all of you who have an MD or PhD or RN after your name, or me, we are going to go down the hallway and we're going to go to the scientific meeting. So I'd like to excuse our illustrious doctors to head over into the scientific meeting. Unless you want to stay here into the community conference, it's entirely your choice. For those of you who identify as members of our bereaved community, I'm going to invite you to head on out with it's actually right there. I can almost see the door. But our bereaved sessions will be starting there. They're also having a celebration of life. And then everyone else here, I'm going to introduce our speaker in just a moment. Does anyone have any questions? All right. let's have a great conference, friends. We'll be back together in this room at noon for awards, and then we'll come back together at the end of the day. So thank you for being here, and have a great day. Shannon, you want to come up here so I can introduce you? Okay, great. All right. All right, I got to introduce you then, Matt. All right, everybody settled? Feel free to get up and down to go get yourself, a coffee or whatever you need. Use the restroom. This isn't, super formal. We want to make sure that you're comfortable here and at the venue. It is my privilege to introduce you today to our Patient Services Director. This is Shannon Sinclair. Shannon joined the foundation in October last year, so she and I have kind of grown up together in the foundation. It's been great fun. Shannon leads all of our direct patient services. She works with patients, families, and caregivers to help them navigate the diagnosis and treatment process. She helps refer patients over to mesothelioma experts because, as we all know, there aren't that many mesothelioma experts. Most of them are here, either virtually or in person. It's kind of the who's who of meso. But Shannon has really taken to all of this. She's got more than 20 years as an oncology nurse, has experience in pharmaceutical companies and in direct patient service, and has worked on clinical trials. So she is your partner in care. We hope that if you haven't yet reached out to her, if you have questions, she's here to support you. And she's developed a network of really great mesothelioma experts who can also help you as well. So without further ado, Shannon, it is your show. Have a great conference, everybody, and I'll be back shortly.
Good morning, everybody. So thank you all for coming here, and for everybody that's on the live stream, thank you as well. We're so happy that we got to put this conference on. It's been a long time in the planning, as all of you know. So today, for this session, I just wanted to touch on some topics that you may hear throughout the different sessions that are going to happen today. So some of you who have been with the foundation for a long time, hopefully this is a good refresher for you. And for some of you that are new to us or newly diagnosed, new caretakers, hopefully this will help you pick out some things that you may not have heard or that may not have made sense to you, so that as you listen to these sessions, you'll get a little bit more knowledge as we go. So we'll start with our first slide. Oh, that one doesn't move, sorry. So the basics are that there's 3 different cell types to know in the mesothelioma world. The first one is epithelioid. This is the majority of mesothelioma that we see. Approximately 50 to 70% of all cases. This does tend to respond better to treatment options that we have available. The second one is sarcomatoid. This tends to be only about 7 to 20%, very, very low numbers. It's aggressive. It does tend to be resistant to treatment, and that's due to the spindle shape of the cells. And then we have biphasic. Sometimes you may hear this called mixed. This is a combination of both epithelioid and sarcomatoid cells, and it makes up approximately 20 to 30% of all malignant mesothelioma. Looking at that. So I wanted to talk a little bit about staging and what staging is, because I get a lot of questions on this, and it's kind of difficult in the mesothelioma world. Simply put, staging is how to classify the advancement of a cancer. It can be a little tricky in mesothelioma. It's often referred to as TNM, and those are kind of the key letters when you're looking at, what your staging is. This stands for tumor, node, and metastasis. Each letter is assigned a value. So T is from 0 to 4. This looks at size and depth of your tumor. N is 0 to 2. This describes whether there's regional nodes or distant nodes involved. And M is metastasis. This has it spread outside of the primary region of disease. Also, does it involve any distant organs? Staging of disease is important because it is what drives much of the treatment plan. It helps decide things such as, are you a surgical candidate? Would systemic therapy be better? Will it be combination therapy? And are you eligible for clinical trials? So let's talk a little bit about systemic therapy and what is meant by that. So systemic therapy is a treatment that treats the whole system. It travels throughout the bloodstream, reaching cells throughout the entire body. There's a number of different systemic therapies that we see within the cancer world and within mesothelioma. So chemotherapy is probably the one that everybody has heard of the most. This is designed to stop cell growth, is cytotoxic in nature. Chemotherapy cannot differentiate between healthy cells and bad cells. Examples of chemotherapy are like carboplatin, cisplatin, and Alimta. The next one is the immune checkpoint inhibitors. This has been a big topic recently in mesothelioma, and we're happy for that because we now have approved drugs in this space, which we didn't have for about 16 years. So this is sometimes referred to as IO. You may hear IO. These actually use the body's own immune system to fight the cancer cells. They are a little bit more specific in nature. And you may have heard of ipilimumab, nivolumab, or they can be called Opdivo and Yervoy. We also have precision medicine. So this is personalized medicine. It's based on the tumor morphology. This is a lot of where our research is headed. And this is a lot of where our clinical trials are going as well. And then we have targeted therapies. Again, a lot of research in this space in mesothelioma. Targeted therapies attack specific targets on cancer cells. So one of the ones that you may have heard of is Avastin or bevacizumab. This is what's called a VEGF inhibitor. It's vascular endothelial growth factor. And so it's looking for that specific receptor site on these cancer cells, and it's targeting those so that we can hopefully get less healthy cells that are being destroyed, and we're looking for more of just the tumor cells. So what is the what's meant by multi-modality treatment? And you probably have heard this a lot. And this is basically combination therapy. It's very big in the world now. So we don't look to use just one treatment. We look to use several different ways of going after that tumor. So you may have chemotherapy followed by surgery, followed by radiation. So we're looking at using an entire team to treat somebody, not just one specific way. There's also two terms that can be very confusing, adjuvant and neoadjuvant, and it's probably something that you've heard or that will be coming up. We're looking at a lot of this as well in research, but when thinking about these words, it helps if you know the goals of each of them. So the goal of adjuvant therapy is to reduce the risk of recurrence of disease. So it's given after the primary treatment. So this would be such as having surgery first, and then we're following it up by adjuvant chemotherapy. And that would be to rid the body of any microscopic cancer cells that may be hanging around. Neoadjuvant has the goal of helping that main treatment be more successful. So when we give neoadjuvant chemotherapy, the goal is to shrink that tumor down so that then when surgery happens, it can be a more successful surgery and hopefully less stressful on the patient as well. So I'm sure that you've heard the term first-line therapy. First-line therapy is the first treatment method that is being used. This is thought to be the most successful based upon what the guidelines have shown, what past research has shown. And then obviously after first line, we get into second line, third line, and sometimes even fourth line. I find that radiation is a very confusing topic for patients and caregivers as well. And it can be confusing for myself too because it changes. It's an ever-evolving field. But what you want to know is that basically what we're doing in radiation right now for mesothelioma is external beam radiation. It's a non-invasive form of radiation that treats a specific part of the body. Within external beam are several different categories. So many people have heard the term proton beam therapy, image-guided radiation therapy, intensity modulated radiation therapy. All of those fall underneath external beam, but they use a different machine. They use different techniques to go after those tumors or those cancer cells. The other one that you may have heard of, and that I'm sure that a lot of you who have done your own research have heard of, is what's called TTF. These are tumor treating fields. It's different from radiation, so sometimes people get confused and they think that they're the same thing. But TTF actually uses an external device that delivers low-intensity electrical fields that disrupt cell division. So many of you have heard of like Novacure or Optune, and they are kind of coming into the picture for mesothelioma. So I wanted to go over a few surgical terms as well. So if you hear the word PD, that's pleurectomy and decortication. This is a lung-sparing surgery, so that's a big thing to know about this surgery. It removes the affected pleural, all visible cancer from the surface of the lung and the chest, but it leaves that lung intact. EPP is extrapleural pneumonectomy. This removes that impacted lung. It also removes part of the pericardium, the diaphragm, and the parietal pleural. It's not used as much anymore, but you may hear of survivor stories where people have had EPP, and there are some physicians who still feel like it is an acceptable treatment. Cytoreductive or debulking surgery. This is something that you'll hear in peritoneal mesothelioma. It's the surgical procedure of choice. So this aims to remove much of the diseased tissue. So it's removing everything as possible that they can visualize. Two of the chemotherapies, ways of chemotherapies that you may hear as far as peritoneal goes, the first one is called EPIC. It's early postoperative intraperitoneal. Sometimes people refer to this just as IP chemotherapy. This is started shortly after surgery. It's usually instilled in several different spaced out treatments. So it may be given once a week. It may be given every couple weeks. They instill it, and then they drain it off through a port that they put inside your belly when they are done doing the surgery. The other one that probably most people have heard of is HIPEC, hyperthermic intraperitoneal chemotherapy. So this is actually given within the surgical suite after they're done with the cytoreductive surgery. They place chemotherapy into the abdomen, they circulate it through, they drain it off, and then they actually close up the patient. I wanted to dive into a little bit about clinical trials. I'm sure that you'll be hearing much of this today, and it does get a bit confusing, and especially for people who are new to mesothelioma. So clinical trials, you will sometimes hear them be called research protocols. They are to evaluate an intervention for an effect on a health outcome. It might be a new medication. It might be approved treatments for another tumor type. It might actually be looking at a treatment versus a placebo. It's designed around a protocol, and these protocols lay out what's going to be done in this clinical trial. So we have the objective. So if you're ever reading a clinical trial and you see the objective, it's the why. It establishes the question that the clinical trial is trying to answer. The methodology is how they plan to execute that trial. And then the outcomes is probably what you are primarily looking for on these. These are the endpoints. These are the results. This is what they're looking to obtain. So you may hear things such as like OS, which is overall survival, PFS, which is progression-free survival, ORR is objective response rate. We have CR, which is complete response, and PR, which is partial response. The reason why I bring those up is because I think they're really important to people when they're looking at quality of life, because sometimes you want to look at where did people fall into these categories in these clinical trials. Most trials also have arms, and I know that I tend to speak sometimes about the arms of a trial, and then I have a patient or a caregiver say, I'm not really sure what that is. What are you talking about? Arms. And this refers to the different groups within that trial. So this would be looking at somebody who was getting standard chemotherapy, that may be one arm, and then the other arm would maybe be looking at somebody that was getting immunotherapy and chemotherapy. And then you may have a third arm that looks at a placebo plus the chemotherapy. So some of them can have many arms. Some trials only have one or two arms. Just depends on what, again, the objective is looking for. So the majority of trials that we see are considered randomized. This is when participants in the trial are placed into a database, and they're selected at random for the different arms. This is sometimes what determines eligibility. So, you may see where there's chemotherapy or chemotherapy and immunotherapy. And sometimes if you've already failed one of those, you may be just ineligible because of how the randomization takes place. Non-randomized clinical trials, these are participants that are placed into different arms using controlled methods. There's 4 phases of clinical trials. This is really big to know as well, especially when you're researching clinical trials for a loved one or for yourself. Phase 1 evaluates whether the intervention is safe. This is usually the first testing in humans. Phase 2 evaluates the effectiveness on certain types of cancer and the safety. Phase 3 often compares that effectiveness against what the standard of care is today. And stage 4 usually looks at long-term follow-up. So what are we seeing after the approval? What are we seeing years down the road? Many trials are approved under an accelerated approval, and that's because the outcomes have been significant that they've seen in the beginning. So a few presentations today are going to focus on genetics and mutations, and this is really the future of cancer research as well as mesothelioma. So I wanted to touch base on these because I find them to be kind of confusing. So germline mutations, this is a mutation that is inherited from both or one of your parents. It is there at conception. It can also be passed on to your offspring. This is sort of where we look at prevention and what we can do to screen people for things in the future. So examples of this are like BRCA1 and 2, Lynch syndrome, cystic fibrosis as well. Then we have somatic mutations. These are genomic alterations that occur after conception. They're not inherited. You do not pass these on to offspring. They often happen in the process of cancer actually forming. So many of you have probably heard of ALK, EGFR, BRAF mutation, HER2. This is where much of the targeted research is going. And so you'll probably be hearing a lot of some of the somatic mutations. NGS is the next generation sequencing. You will hear about this today. This is Foundation 1, Guardant 360 are just 2 of the examples of those that some physicians may use. So this uses tissue, blood, saliva samples, and it's looking at what those gene mutations are. And it's very, very important into the emerging treatment options in the clinical trials that are happening right now. So novel therapies. This is personalized medicine. This is looking at those specific mutations that a person has. So this is not lumping everybody into one category. This is actually saying we're looking at you specifically and what variants do you have, what mutations do you possibly have, and then we're going to drive our treatment plan around that. So personalized medicine. Gene therapy is a treatment approach that alters a gene. These are very emerging approaches. So immunotherapy, virotherapy, gene transfer, some of the vaccinations that you've seen in the cancer spaces. And another research focus is TME. This is tumor microenvironment. This is important because we're looking at what's surrounding those tumor cells. What are the blood vessels around it? What's feeding these tumors, and how can we stop them from doing that? We want to see what the immune cells are doing around those. And it's important when understanding the initiation of those tumor cells as well as the progression. That's it. I just wanted to thank everybody for attending. It's wonderful to have everybody here. It was great to meet some faces that I've seen and known and that I've talked to on the phone. And it's really a pleasure working for this foundation. I've really loved coming into this. I know I have big shoes to fill with Mary, but I think that hopefully working together with this team has been great. So thank you so much for attending.
Thanks, Shannon. That was great. I really appreciate the overview of sort of the basics, and this, I hope, it sets the stage for the rest of the sessions today. Most of these sessions will include a little bit of an opportunity to ask some questions. And just as a reminder, we're not going to give you specific medical advice related to your care. Our doctors are here to educate and inform in a broad way, but they're not here to give you a second opinion on the fly. So, but anyway, it is my distinct privilege to introduce, I already introduced her, but Dr. Hedy Kindler, who is one of the global experts and a rock star in mesothelioma. She's been an incredible resource for me. She and her team have been there for all of us as we've put this conference together. They've brought in their people to lead sessions. It's, Dr. Kindler has been amazing. I'm going to let her introduce her session, Systemic Therapies for Pleural and Peritoneal Mesothelioma. This is a deep dive, really fast. So without any further ado, please join me in welcoming Dr. Hedy Kindler.
Good morning, everybody, and welcome to my adopted hometown of Chicago. It's really a pleasure to speak at this conference and to teach you a bit about systemic therapies for pleural and peritoneal meso. Now, Shannon's already given you a wonderful overview of the basics. I didn't realize she was going to do it that thoroughly, so I'm going to review it a little bit more as well. All right. And if I want to move this forward, I am aiming it. Oops. Oh, so this one is not moving with that one.
Oh, here.
So can I have, yeah.
I'll just adjust this. Oh. Now it will be.
Beautiful. All right, so I'll go from here. Again, I'm going to speak with you about systemic therapies for pleural and peritoneal meso. So, what the heck is systemic therapy? Well, the principal approaches to treating a cancer are observation, you watch it; surgery, you cut it out; radiation, you zap it with a beam aimed at the site of the disease. Pretty self-explanatory. Well, systemic therapy, you treat it with a drug to attack the cancer cells wherever they may be. Systemic means throughout the body. This can either be intravenous, by vein, which is most drugs for mesothelioma, or oral, a pill, a few drugs in clinical trials, and the occasional drug you can get outside. A few more definitions: first line or front line. The first type of systemic treatment you receive. Maintenance, what you take to keep the cancer under control after the initial therapy. Second line, the next type of treatment you receive when the cancer worsens. Neoadjuvant, treatment to shrink the cancer before surgery, and adjuvant, treatment given after the surgery to prevent the cancer from coming back. So how does the doctor help you decide which systemic treatment is best for you? Well, they look at the clinical trial data, which drugs are most likely to work in your situation. They look at some key characteristics about your cancer that might make one treatment more likely to help you. They look at your overall health, other medical conditions that could be made worse with certain drugs, or that could affect how some drugs are processed in your body. Now, before I talk about the trials, you might be wondering that I'm not going to be mentioning much about peritoneal. And that's because most of what we believe about systemic therapy in peritoneal meso is extrapolated from trials performed only in pleural patients. Unfortunately, most meso trials exclude peritoneal patients. There were no peritoneal patients in the randomized trials that led to the FDA approvals of pemetrexed and of immunotherapy. It's actually challenging to convince pharma to support trials in this less profitable, uncommon disease. And trials that permit peritoneal meso patients often don't enroll many. It's an uncommon cancer, and peritoneal disease is often very vaguely shaped on a CAT scan. You need to know the size of something to see how much it shrinks with drugs being tested. If you can't measure it, you can't go on a trial. So there are only a few small trials exclusively for peritoneal meso, and none are randomized. We don't really know if all of the drugs studied in pleural meso have the same activity and side effects in peritoneal meso. So those of you with peritoneal meso, don't feel excluded when I don't mention your trials today. So what are the types of systemic therapy for meso? Chemotherapy, immunotherapy, targeted therapy, and I put in parentheses clinical trials, which will be the focus of other talks. So what is chemotherapy? Chemotherapy is cytotoxic. Chemotherapy kills cancer cells indiscriminately, usually by interfering with their DNA, the building blocks of life. Chemotherapy exploits the fact that cancer cells usually grow faster than normal cells. Here are some of the commonly used chemotherapy drugs for mesothelioma. Now, as doctors, we have to use the trade name, but as patients, you usually know the brand name. So there's pemetrexed, or Alimta, there's cisplatin, carboplatin, gemcitabine, or Gemzar, and vinorelbine, or navalbine. The brand names are always easier to say. What is immunotherapy? Well, logically, immunotherapy drugs target the immune system. The immune checkpoint PD-1, or programmed death receptor 1, allows cancer cells to be hidden from the immune system. Immune checkpoint blockade drugs turn off the brakes in the immune system, so now the body can attack the tumor. They unmask the tumor, and your body can attack it. Some immunotherapy drugs used for mesothelioma are shown here, including pembrolizumab, or Keytruda, nivolumab, or Opdivo, and ipilimumab, or Yervoy. Do immunotherapy drugs have fewer side effects than chemotherapy? It's a common fallacy. Not really. They just have different side effects. They can activate immune responses almost anywhere in the body. Now, the most common side effects are going to be fatigue, mild itching, rash, and decreased thyroid activity, but they can cause inflammation wherever they darn well want to, whether it's causing joint aches, or diarrhea and colitis, or inflammation of the lungs called pneumonitis. It's just a little less predictable than chemotherapy. What is a PD-L1 test, and does it matter in mesothelioma? So this is a test on a tumor sample that measures the amount of the PD-L1 protein on cancer cells. PD-L1 testing can be used to find out if your cancer might benefit from immunotherapy. If your cancer cells have a high amount of PD-L1, you may benefit from immunotherapy. If your cancer cells have a low or no PD-L1, you may still benefit from immunotherapy. In some cancers, it's a bit more clear-cut than it is in meso, and I'll show you some of the data. Now, what is histology and why does it matter? Histology is what the cancer cells look like under the microscope, and you can see the epithelial in purple and the sarcomatoid in pink. There are three main histologic subtypes: epithelial, mixed, and sarcomatoid, or as I like to tell my patients, vanilla, swirl, and chocolate. Why does histology matter? Because chemotherapy and immunotherapy may work better in some histologic subtypes than others. So you always want to know the histologic subtype of your meso when choosing your treatment. What is targeted therapy? Targeted therapy targets the biology of the cancer. In some cancers, certain signaling pathways or molecular on-off switches that promote cell growth are abnormally switched on. Targeted therapy aims to turn off cell growth by blocking these signaling pathways. And in this little schema, I've shown you several of the common ones in meso, such as BAP1, NF2, CDKN2A, mesothelin, VEGF, etc. Here are some targeted therapies available for mesothelioma. There are the vascular endothelial growth factor inhibitors, or VEGF inhibitors, including bevacizumab, known as Avastin, which is given with pemetrexed and platinum, or ramucirumab, otherwise known as Cyramza, given with gemcitabine. Then, in some young patients with peritoneal meso, who have something called an ALK translocation, where part of one gene sits on top of another, there are drugs that are approved specifically for that translocation, regardless of what type of cancer you have. And these are oral agents, including crizotinib, alectinib, brigitinib, and lorlatinib, ALK, anaplastic lymphoma kinase inhibitors. And then there are many other drugs that target the pathways such as BAP1, NF2, mesothelin, and others, and these are currently in clinical trials. Several of them are quite exciting, and hopefully soon some will be available commercially. So this is a table showing some key milestones in the development of systemic therapy for mesothelioma. And pay attention to those years. In 2003, we had cisplatin and pemetrexed. It took until 2016 before we then had a positive trial of pemetrexed, cisplatin, and bevacizumab. 4 years later, we had 2 positive trials in 2020 with RAMES and Checkmate 743, and then in 2021, 3 more positive trials. The pace of research is really moving fast. Things are changing. So these 5 positive randomized trials since 2020 have transformed our treatment paradigm and will affect the design of all future mesothelioma studies. Let's talk about first-line chemotherapy options. These include pemetrexed cisplatin, pemetrexed carboplatin, pemetrexed cisplatin and bevacizumab, and pemetrexed carboplatin and bevacizumab. So this study, the EMPhASIS study, compared pemetrexed cisplatin to placebo in cisplatin. And it was the study that led to the FDA approval of pemetrexed for meso. For almost 2 decades, pemetrexed was the only FDA-approved drug for meso. The study was led by my former mentor, and I believe he was a co-founder of the foundation, Dr. Nick Vogelsang. And so for many years, this was all that we had. And if you're looking at, this is called a Kaplan-Meier curve. And so you have 2 arms of the curve, and if something is above something else, then that shows that people did better. And so here we can see a difference between the arms in the curve, and so that patients who did get the pemetrexed or Alimta with the cisplatin did better than those who just got cisplatin alone. Now, cisplatin is the FDA regulatory standard, and it is a tough drug. Makes you feel like you got run over by a Mack truck. Carboplatin is much better tolerated, with less fatigue, nausea, vomiting, kidney damage, and hearing loss. So the combination of carboplatin and pemetrexed is commonly used in older patients, and honestly, it's much more widely used because it is much better tolerated with equivalent activity. What about maintenance options after pemetrexed and platinum? So a few of them have been evaluated, including pemetrexed, gemcitabine, and bevacizumab. So here in this study, CALGB 30901, patients who had received 4 to 6 cycles, that is every 3 weeks, of pemetrexed and cis or carboplatin, were randomized to either just continue the pemetrexed, it's a little easier than taking the double drug, or go to observation. And what you can see here is that there is no difference between these lines. In other words, continuing the pemetrexed probably isn't necessary. It's a small trial, so we can't say definitively, but for most patients, you take the chemotherapy for 4 to 6 doses, then you go into an observation period. The ENVOLT 19 study was a Dutch study that tried a different approach called switch maintenance. After patients received pemetrexed and platinum, they either got observation or they switched over to the drug Gemzar. And here it looks like patients might have had longer disease control if they got Gemzar, but it didn't actually affect how long they lived. Again, a small study, provocative. I don't know that it's being used in the United States, but it's an interesting concept. Now, the first randomized study since pemetrexed was approved was the MAPS trial, and this study looked at pemetrexed cisplatin with or without the VEGF inhibitor bevacizumab, followed by maintenance with bevacizumab versus surveillance. And here you can see a nice discrimination between the arms of the study, such that the progression-free survival or the delay of the tumor growth was greater in those patients who received the bevacizumab. Similarly, patients lived longer if they got pemetrexed, cisplatin, and bevacizumab than if they just got the old combination of pemetrexed and cisplatin. So we learned from this study that adding bevacizumab improved that progression-free and overall survival. It wasn't too toxic, and it didn't make people feel worse. And so this combination is in the NCCN and ASCO guidelines, the guidelines that doctors use to tell us about treatment, but it isn't FDA approved for mesothelioma, so it's not always available via insurance. And being a French study, it was done only in patients under the age of 75, and for the most part, we will not give this drug to older patients because it does increase the risk of stroke and blood clots and nasty things like that. Now, what about first-line immunotherapy? I'll talk about the drugs ipilimumab and nivolumab. On October 2nd of 2020, the FDA approved the combination of nivolumab plus ipilimumab as first-line treatment for patients with unresectable malignant pleural meso. This was a wonderful day because it was when the first new drug approval for mesothelioma occurred after 17 years. Many, many negative studies happened in between, but this was a real red-letter day. All right, so Checkmate 743 was the trial that transformed our first-line treatment for meso. In this study, of over 600 patients received either nivolumab and ipilimumab, this is Opdivo and Yervoy, or they got pemetrexed with cis or carboplatin. The study was actually stopped early because the results were so dramatic. That is considered a very large distance between these lines, and patients who got the immunotherapy lived a lot longer than those patients who got standard chemotherapy. Now remember, we talked about histology, the chocolate, vanilla, and swirl. So in the epithelioid, you kind of have to squint a little bit to see the difference between the arms. Indeed, there is an improvement even in epithelioid when patients got immunotherapy. But the epithelioids were kind of starting over here, and they went over here. The sarcomatoids were starting way down here, and they also moved up to here. So you can see that huge difference in the non-epithelioid patients, more than doubling of survival. And that's partly because chemo just doesn't work well in those patients, but also because immunotherapy works so much better. Now, what about PD-L1 expression? So that's that immune marker on the surface of the tumor. In those patients who had no or very low PD-L1 expression, the lines kind of crossed. It probably didn't matter which you chose. But in those patients who had PD-L1 expression greater than 1%, in other words, it was positive, you can see a nice separation between those curves, showing that immunotherapy was superior in those patients. So this summarizes the results and shows you how now with immune therapy, epithelioid and non-epithelioid patients can have equivalent outcomes. Really exciting. The tumor shrinkage was about the same with both treatment options, but the responses lasted longer in those who got immune therapy. So the authors of this study were very excited because this study met its primary endpoint of statistically significantly improved survival with immunotherapy. And they felt that this should make the IPI and Nivo combination the new standard of care, which it is. Now, when we have studies like this, we always want to look at long-term data. And so a recent analysis at 3 years of follow-up showed that there were no new safety signals, patients weren't getting ill further out, no other new problems, but 3-year overall survival still favored immunotherapy, and epithelioid and non-epithelioid patients still had basically equivalent outcomes. And about almost 30% of patients still had their tumors responding at that 3-year point, which is pretty remarkable, versus none of those who had gotten chemotherapy. Now, there are patients who get immune therapy who get immune-related side effects. They get the pneumonitis that makes it difficult for them to breathe, and the doctor says, sorry, you can't get any more immune therapy because it could make this even worse. And the patient's like, but I have to take my immune therapy, I'm scared to stop it. This data shows that it is totally fine to stop it. In patients who continued immunotherapy because of immune-related side effects, there was no bad effect of discontinuing it on the long-term benefit. These patients had only a median of about 4 months of treatment, and yet their survival was even better than in those patients who didn't have those immune side effects, and their tumors shrank 2/3 of the time, which is remarkable in meso, and 1/3 of those patients still had tumors responding at 3 years. When you look at these curves, the dotted lines are those patients who had the immune side effects, and they did even better than the other patients on the study who had gotten immunotherapy. Their immune system was so revved up, causing those side effects, that it also is still controlling that tumor. Now, if you didn't get side effects, it doesn't mean it's not working, but it's just reassuring that if your doctor says it's really not safe, your joints are hurting too much, you're not able to walk, don't put yourself in a wheelchair, it's okay to stop. The study also looked at quality of life using a variety of symptom scales and showed that immunotherapy delayed the time to which you would then be feeling worse. And so what's called delayed time to definitive deterioration in health-related quality of life. You feel better for longer if you're getting immunotherapy. Pretty nice. So placing this study in context, we know that compared with chemotherapy, the pemetrexed and platinum, ipi/nivo yields superior survival at 1, 2, and 3 years, regardless of histology or PD-L1 expression. Now, Checkmate 743 clearly changed the standard of care for meso patients with the non-epithelioid histology. Those were the ones with the really dramatic improvement in survival. So now with doublet immunotherapy, epithelioid and non-epithelioid patients can achieve equivalent survival. But if you have epithelioid histology or a PD-L1 negative tumor, although ipi/nivo is still favorable, the choice between treatments is more nuanced. Chemo is still okay. And in fact, the survival from ipi/nivo is really similar to what we got with pemetrexed and platinum and bevacizumab in the MAPS trial. So we're looking to see what other treatments might be best in patients with this subset. And ongoing studies of chemotherapy plus immunotherapy may be identifying regimens that are even better suited to that epithelioid subset. And I'm showing you here, it's called a spider plot and a waterfall plot. And just look at things going in the down direction. That means things are shrinking. So this is a phase 2 study looking at the combination of durvalumab, a PD-L1, with chemotherapy, showing really dramatic responses. So just a teaser, only one clinical trial in this presentation, but the DREAMER trial is comparing immunotherapy plus chemotherapy to just chemotherapy. And it may indeed change the standard of care. It is an ongoing study, but hopefully for those patients with the PD-L1 low and epithelioid tumors, that may be our next treatment option. So how do we treat meso that is worsened on or come back after first-line therapy? That used to be a much simpler question. Now that we have more frontline options, we also have more choices for second line and beyond. The choice of a second-line regimen depends on several variables. First of all, what you got beforehand. If you got chemo plus bevacizumab, or immunotherapy. And then what was your response to that regimen, and how long did it control your disease? If you got pemetrexed and carboplatin and the cancer didn't come back for 2 years, you might want to get retreated with the same thing rather than trying something new. You want to also look at the histology, because that's going to come into play with immunotherapy as well as with GEM-RAM that I'll tell you about in a moment. And then what are some medical contraindications? Do you have autoimmune disease, lupus, or myasthenia gravis, or something that's going to mean that immunotherapy isn't safe for you? Do you have decreased kidney function and pemetrexed isn't a good idea? Are you older and might have an increased risk of clotting or bleeding, so a VEGF inhibitor might not be a good idea? So in patients who have not received prior pemetrexed, we know that single-agent pemetrexed can delay the worsening of the cancer. And we also know that pemetrexed or pemetrexed platinum retreatment will achieve durable disease control in patients who are pemetrexed sensitive. So if you responded the first time, you had a reasonable time off of therapy, you can get retreated again. But what is the activity of pemetrexed platinum in patients who just got immunotherapy? Well, those studies haven't occurred yet. We assume that it's similar to frontline chemotherapy, but we really don't know. An interesting trial was the RAMES trial that came out of Italy. It's a rather unexpected result. Here, patients received a old standard in previous treatment, gemcitabine or Gemzar, with or without the VEGF inhibitor ramucirumab. And here we can see a very significant improvement in overall survival with the combination therapy. And interestingly, that survival improvement extended not only in epithelioid, who tend to respond better to chemos, but also to the non-epithelioid patients, offering yet another treatment option in the second or third line setting. VIM was a recent study looking at oral vinorelbine in patients with previously treated meso. Now, this is not available in the U.S. We have only the intravenous kind, which is a little more toxic. And here they compared it to best supportive care, which is a difficult thing to do in the United States, but in the UK, patients tend to be more accepting of this. And we can see a small improvement in the delay of the cancer worsening, so progression-free survival, but no survival change. Whether this is worth it or not is really unclear. Now, what about giving immune therapy? So the ETOP PROMISE study looked at either giving pembrolizumab, also known as Keytruda, versus doctor's choice of vinorelbine or gemcitabine. And then those patients who got chemo could cross over to the immunotherapy. And here we actually surprisingly saw no difference between chemotherapy and single-agent immunotherapy, and that was a little puzzling. The CONFIRM trial recently came out, and that compared immunotherapy to placebo or a dummy pill, a dummy IV, and that did show an improvement in median survival in those patients who got Nivo versus those who got nothing, suggesting, that at least there is some benefit from single-agent immune therapy. But maybe you need the double drugs. So this was actually a non-randomized parallel study that looked at either giving single-agent Nivo or giving the combination of Ipi and Nivo. So not evenly balanced, a little hard to draw conclusions between the arms, but we can see that there does seem to be a longer progression-free and overall survival, as well as a higher toxicity rate when we gave the doublet versus the singlet. So whether we should be giving Ipi-Nivo in the second line or just Nivo, I think most of us would give the combination unless the patient was very frail or had very high PD-L1. So over the past few years, I'd say we have finally begun to make real progress in systemic therapy for meso. Combination immunotherapy has clearly changed the standard of care. There are many new treatment options for patients with this disease. Of course, far more needs to be done. Research into the biology of the disease continues to uncover new targets, and the Meso Foundation is at the forefront of funding that research, and many of our investigators are very involved in doing so. Many clinical trials of novel agents and approaches are ongoing, and I hope within a few years we'll be able to talk about many new breakthroughs that are going on in this disease. I thank you for your attention.
Do we have any questions? I think we have time for one question. And we have a couple of mics here. I can bring you the mic over. Anybody? No. I have a question, if you don't mind. Sure. Forgive me if you've addressed it. You said in first-line, sarcomatoid patients benefited greatly from immunotherapy. What about second-line therapy? How is that for sarcomatoid patients?
So the problem in sarcomatoid patients is that chemotherapy is just not very active. And so if a sarcomatoid patient has failed immunotherapy, there is a problem. We're not certain what the best treatment is. The data from the gemcitabine and ramucirumab studies suggests that patients who received that combination, who had non-epithelioid, so sarcomatoid tumors, did just as well as epithelioids. So I would think that addition of a VEGF inhibitor to chemotherapy would likely be the best approach as long as a patient could tolerate it.
Thank you so much, Dr. Kindler. Isn't she amazing? Yeah, it's our favorite. We love to have her. My favorite is when we do Meso TV episodes with Dr. Kindler, because there's nothing she doesn't know, and has such a great way of explaining it. it's helped me personally. So it is now my privilege to introduce our next session, which are treatment options specific to peritoneal mesothelioma. As Dr. Kindler pointed out, many studies really only focus on pleural. And so this next session is featuring the dynamic duo of Dr. Kieran Taraga and Dr. Travis Groats. Dr. Taraga is from here in town, University of Chicago Medicine, and his partner in crime here is from the Mayo Clinic. Flew in hot and heavy, got here just in the nick of time. So I'm going to let them start. Their bios are in the back. And take it away, guys.
Thank you.
Here's the masks are off. Okay, for presentation.
Thank you.
Thank you so much.
Hi, good morning, everyone. And thank you for being here for this session. I'm Kieran Taraga, and we're going to try to keep this somewhat interactive. Dr. Groats is going to go through some basics of peritoneal mesothelioma treatments. And then, feel free to stop us whenever you guys have any questions. We've kept lots of time for discussions. So I think this, we'd welcome the opportunity to interact with you as well. But with that, I'm going to introduce Dr. Groats. Dr. Groats and I have known each other for a very, very long time, over a decade, when we met back in Omaha, Nebraska. But Travis is one of the up-and-coming stars in peritoneal mesothelioma, and so Travis is going to go through a lot of the data and the slides, and I'll jump in once in a while. Thank you.
Thanks. Good morning. Thanks, everybody. Let's advance it right here. Okay, perfect. All right, good morning. So we have the privilege to talk a little bit about peritoneal mesothelioma specifically. I have nothing to disclose, and we will talk about some off-label stuff, which is HIPEC. Technically, HIPEC is intraperitoneal chemotherapy, and chemotherapy gets approved by the FDA and things for systemic use, but it's actually not approved for intraperitoneal use. But it's very common for physicians to use things that are approved and safe in different ways if there's safety data and things like that. And so that's what that disclosure means. It came off.
Okay, let me set it up. Close up some stuff.
Sure. There. Okay, perfect. All right. So want to talk a little bit about some of the backgrounds of peritoneal mesothelioma, kind of explain what is the peritoneum, then dive into a little bit more about the treatment options, about chemotherapy, and then about pressurized intraperitoneal chemotherapy, which is PIPEC, talk a little bit about surgery, and then hyperthermic intraperitoneal chemo, or HIPEC, and then also talk lastly a little about immunotherapy and the exciting advances that have been made. So I often get this question, what is the peritoneum? And I think it's hard sometimes when people to understand what exactly it is. And so it's basically the lining of your abdomen. And so, it's like a box, your abdomen, pictured here, and your organs are inside, and they're coated in a lining, which is a few cell layers thick, called mesothelial cells, called the peritoneum. So it covers the entire inside cavity of the abdomen. So the way I think about it is just like a balloon. So if you have a partially deflated balloon, you kind of punch your fist through it. That's kind of what the peritoneum is. So there's kind of two layers actually in your abdomen. There's the layer immediately on top of your fist, and we call that the visceral peritoneum because that's on the viscera or the organ. And then there's the outer layer of the balloon, which is on the kind of the abdominal wall, and then we call that the parietal peritoneum. Just means it's the peritoneum of the abdominal wall. But this kind of gives you an illustration of what, when people are talking about peritoneal mesothelioma, it's like basically a disease then of the balloon, and then those organs are covered in that balloon, and that's surgery, how we do surgery, and it kind of explains things in terms of that. And then I'll let Kieran touch briefly on the germline mutations.
Yeah, I think one of the things that is evolving in our understanding of peritoneal mesothelioma is, obviously we're always interested in why someone gets peritoneal mesothelioma, and I think that's the tricky part. And we certainly know environmental exposures like asbestos and other toxins can cause or be related to peritoneal mesothelioma. But one of the things that is also very interesting is that if you look at the second bar graph from the top, so if you look at that, it's kind of small. I don't know if all of you can see it. But what it's showing on the x-axis is the number of people with germline mutations, which means hereditary mutations. So this side is showing the number of people, so you can see the proportion of people there. And this one, if you look at pleural, peritoneal, and both, you can see that almost a fourth of the patients will have some version of germline mutations, which means something that's in your blood that predisposed you, not necessarily caused it, but either predisposed or made you more vulnerable to sort of environmental exposures that increases your risk of peritoneal mesothelioma. And many of you might have heard of these genes like BAP1. You can have BRCA2, which is also associated with like breast cancer, CHEK2 associated with other types of cancers. So it is something that's important, for us as a community, just to be aware of and make sure that, you're thinking about getting tested. It's something that has to be done carefully and in conversations with your oncologists. But I think just something to keep in mind as an advance of why people are, or at least some more information about why we, or what we know about peritoneal meso.
I'll go on to treatment. So I know you've had some talks previously, and so I'll briefly kind of talk about these areas, particularly how they pertain to peritoneal mesothelioma. And so you're aware systemic chemotherapy is typically anti-cancer cells that typically impair synthesis or cell division and growth, and so they kill typically rapidly dividing cells. When we talk about biologic therapy, that's usually some kind of target agent that blocks a particular step in a biological process. A common one in mesothelioma is the angiogenesis inhibitor, bevacizumab, which blocks the growth of blood vessels. And so as the cancer in the lining of the peritoneum grows, it needs a blood supply to help it grow. And so that drug actually blocks that ability for the cancer to develop more blood vessels and kind of, in a sense, kind of chokes it off and limits the blood flow to the tumor. And so, and you've heard these drugs before too. Essentially, most of the data we have for peritoneal mesothelioma comes from pleural mesothelioma studies. They are different tumors with different biologies, and we can get into that. But most studies, because the most common mesothelioma obviously is pleural, and so most studies involve mostly pleural patients, and even many of the studies actually exclude peritoneal patients. And so it's sometimes hard to extrapolate or know if the data or the trials in pleural pertain to peritoneum. But in peritoneal mesothelioma, these are kind of our standard drugs that we use. And so there are two kind of combination drugs. Prematrexate is an anti-metabolite, so it impairs the three of the enzymes necessary for DNA production, and so that's how it impairs cell or cancer growth. And then the platinum agents, cisplatin and carboplatinum, they're metal agents that then bind DNA and impair its ability to make proteins. So that's kind of how, scientifically they work, and they work together to treat the cancer. Typically, systemic therapy for peritoneal mesothelioma is given for patients who are either not surgical candidates and maybe the hopes of becoming surgical candidates so they can shrink the tumor, or in situations where surgery is not possible to treat the tumor and prolong survival as much as possible. Typically, chemotherapy so far alone is not typically effective in killing the entire cancer. Cells developed resistance, and so it's hard for systemic chemotherapies to completely kill cancer cells. So some combination of surgery or something else is usually necessary. And then we add these biologic agents. So the bevacizumab, as I mentioned before, that's that drug that blocks the blood vessel growth and kind of chokes it off. And so those, when you combine, those are kind of our top drugs for mesothelioma, for the peritoneum. And so the route of chemotherapy is important. And so typically when you give chemotherapy through the IV, it gets into your blood and it treats your whole body. So if there's cancer cells in other parts of the body, or potentially cancer cells in the blood floating around, this chemotherapy is very effective for that. One area we think maybe chemotherapy doesn't get to the greatest as far as like concentration amount is to the peritoneum actually. There's a little bit of a barrier there in the lining of the peritoneum, kind of a functional and physiological barrier. And so when you give chemo through the IV and then you try to measure that chemo in the peritoneum, it doesn't get there very well. It has to go through all these cells, and so the concentration kind of fades out. And then vice versa, when we give chemotherapy in the belly, the same thing is true. It tends to stay in the belly. Some of it gets absorbed, but not typically a lot, and so you can give higher concentrations, typically of chemotherapy in the abdomen. It has more of a local effect. And so that's kind of how intraperitoneal chemotherapy came about many decades ago. And so one of the newer methods of doing chemotherapy in the belly is pressurized. So it's like an aerosol. So I explained it's like a spray can. And the thought is that pressure may be able to kind of push this chemo into the cells. So the cells kind of have a little bit of osmotic pressure or pressure that keeps the chemo from coming in. And so if we can overcome that with that pressure, we might be able to drive the chemo into the cancer cells. And so that's kind of how PIPEC is thought to be more effective. And it's kind of interesting because we actually use much lower doses of chemotherapy in PIPEC, and it must be because it gets into the cells so well, because higher doses are too toxic. So it is a general anesthesia. It's a general surgical procedure. So patients can't be awake for this. It's uncomfortable because we do have to put pressure inside your abdomen. And so it's under general anesthesia. It's relatively brief, typically about 30 minutes. And then there's like a spray nozzle essentially that kind of sprays the chemotherapy into the abdomen. And then just kind of moves around by air and flow dynamics, and then it's evacuated, and then patients are woken up, and so there's a side effects, of course, of general anesthesia, incisions, and discomfort from that, but in general it's pretty well tolerated because the chemotherapy kind of stays in the peritoneum, and not a lot gets absorbed and causing toxicity. So this is relatively new application of chemotherapy. Mainly done in Europe. That's where really most of the data comes from. This is not FDA approved yet in the US, but there are several sites and clinical trials that are ongoing right now looking at this. And I think here's actually one of the studies. Many of the studies have included patients with all types of tumors and looking at it, but this one in particular was just for mesothelioma patients. And basically showed that, a nice thing about the PIPEC procedure is that the surgeon's in the operating room and looking at the peritoneum each time. And so rather than having to wait to get a CT scan or MRI and try to measure and see if you're responding, the surgeon can look at the tumor, the lining of the peritoneum there. We can biopsy it, and the pathologist can tell us if the cancer's dying or if it's still alive. And we can also see it. It tends to kind of flatten out with treatment and kind of go away and become a scar. And so that's kind of the goal. And so in this study, in over 50% or over half of patients, there was some degree of response and regression. And in as many as 20%, it was pretty significant response. And even some people had a complete response. The bar charts here just show this 4 is like a complete response. So you can see, this is the first pressure treatment. Most people had a minor response. But if you keep repeating it, you start getting more and more people who will have a really good response or a complete response. Oh, yeah. Thank you. That's okay. Sorry. So it is promising, and hopefully will be and I think it is going to be coming to the U.S. Many places are doing this, mostly on trial right now. And then we'll talk about surgery. So, I think everybody knows for the primary treatment or the best treatment, the most likely to be curative intent is surgery. And these are long operations. We call them cytoreductive surgeries. And it's really because it involves kind of two things. One is because of mesothelioma is a tumor of the lining, we really have to remove all the lining of the abdomen very carefully. And so that obviously takes time and tedious work as a surgeon to clean all that out. The other place, the mesothelioma is different than other cancers of the peritoneum, is again that all the surfaces we need to remove and are at risk of becoming or are cancer. And two, the way mesothelioma involves the intestine, so it tends not to get on the actual bowel itself, but it tends to get on the mesentery, which is the blood supply to the bowel. And so many times we can actually save and preserve the bowel, but we have to do pretty extensive stripping and burning or blading using surgical techniques to remove as much of the tumor on the peritoneum on the mesentery. And again, that's where blood vessels are. So just a very meticulous procedure. And obviously there's a lot of, you think about when you get like a road rash or something, you get a little bleeding. And so, there's a lot of small oozing like that because you're basically kind of stripping that top layer. So there's a lot of, careful getting blood to coagulate and stop bleeding. And so the surgery is very extensive. And I just have one surgical picture, I know, but just kind of shows, this is an intraoperative photograph, and you can just kind of see that pink white stuff is kind of lining. It's very thick. It shouldn't be that thick. It should be a very thin lining. And then what we do is we just kind of pull it off and strip it off, and then you get the nice, healthy underlying muscle. So the tumor typically doesn't go into the underlying structure like the muscle or other organs. It often can be right on the surface. And so it's just that process of kind of stripping, peeling that lining off the underlying, in this case, the diaphragm, the muscle, the breathing muscle. And so this is part of that when we talk about peritonectomies. That's what that is. And then once we're all done with that, our goal obviously is always to remove all the tumor. If that can be done, that has the best outcomes. But even if we can, if there's just minimal, very small millimeter disease, the chemotherapy is very effective, I believe, in HIPEC for mesothelioma. And so after surgery, typically at the same time, so people are still asleep, we then do HIPEC, which is the heated chemotherapy. The heat is believed to kind of push, cancer cells in general are susceptible to heat. They're more sensitive than normal cells. It also upregulates all their kind of, heat shock proteins, and they're kind of makes them more vulnerable to chemotherapy. And so, and also some drugs, it does improve the depth of penetration of the chemotherapy. So there's kind of three reasons why we heat it. We heat it fairly hot, so 108. I think a hot tub's like 104, so that's pretty warm. It's not burning or scalding, and so nobody gets burns or scalds inside their abdomen. It's a safe temperature, and we can regulate within like a tenth of a degree most of the time. So it's a safe heat. Obviously, we don't want you to be 108 degrees or a patient to be 108 degrees. So typically, we cool people, with cooling blankets and ice and such to keep people's regular temperature normal. And then typically we temporarily close the abdomen, and then, like I said, fill up with chemotherapy. And there's various protocols of how long and such, but it's typically anywhere from an hour to sometimes up to 2 hours time of chemotherapy. And there's also a minimally invasive version, which I'll let Dr. Cheryl.
Yeah, no, I think, you heard about the PIPAC, which is the minimally invasive version of putting aerosol. And you also heard the fact that it's not currently widely available. And so one of the other alternative approaches that some of us have tried is essentially just a very similar version of giving HIPEC, except that you're doing it through little poke holes. And it works remarkably well, especially when patients have a lot of fluid buildup in their belly. It's an outpatient procedure, so patients can go home the same day. It's still a surgical procedure. And we've actually also seen responses for patients with mesothelioma. So it's a very simple concept of putting the hot chemotherapy inside the belly, letting it circulate, but then taking it out so that then patients can go home. So kind of some advances in the way we're thinking about how to deliver chemotherapy in a less toxic, less morbid way.
I think another question I get a lot too is, can you do the surgery minimally invasively? And so it is true for some cancers, typically not mesothelioma, but others that have spread to the abdomen, and then we do, cytoreductive surgery in HIPEC. If they have really low volume, very small amount of tumor, there are studies and people who have done this minimally invasively, and it can be done. Typically, mesothelioma, like I said, though, you really have to peel the entire lining, and so I think that would be extremely difficult and time-consuming, because it's already a very long operation, and it would turn into an extremely long operation. So typically, I don't think mesothelioma is going to be a good, or I don't think that we're going to be able to do this minimally invasively for the foreseeable time. Unfortunately, it still needs to be done open. But what we have done, I think, and made significant progress is a whole research on enhanced recovery and understanding how to improve people's recovery and experience after surgery. And that can be measured in lots of things, from just the pain and time people are in the hospital, but like even recovery until they're back to work or back to functional activity. And so there's a lot of things that we've studied in how we give anesthesia and how we give fluids and medications that can improve people's recovery. And just to give an example, when I first was training to do this, it was not uncommon for people to be in the hospital for 3 weeks. And now our average, I'm sure yours is around a week from these, or even less. So it's been a dramatic difference. And it's not just getting people out of the hospital earlier, but the pain, the dysfunction, just that all that goes with recovery is better. It's not gone or easy, but it definitely is improved. So I think that's one area that we've made some advances in the surgery, but not yet with minimally invasive for the cytoreductive part. But for the HIPEC and the pressurized chemo, that can be done minimally invasively. 5 minutes. All right. We'll skip. That was the main thing I wanted to talk about, actually. And then you've already had to talk on immunotherapy, so I don't want to go over that. But I did want to talk about the 2 trials that we have specifically for peritoneal mesothelioma that we're a part of.
Yeah, so I think, it's important for all of us to understand, advocate. I think that's a big part of what MARF does, and I think that's why we're all gathered here a little bit. Some of it is information, but a lot of it is advocacy and research. That's really where we want to be. And I think, a lot of us are trying different ways of treating this disease, because no one really wants to do a big surgery. We're both surgeons. We enjoy operating, but we don't want to put our patients through big surgeries that are 6-8 hours and they take even a week in the hospital. We would love for our patients to either not have surgery and be cured of their mesothelioma. That's really where we're all pushing towards. And so, there's clinical trials, and I think it always feels a little bit scary to think about doing experimental treatments and how do you think about it. But I think in the right contexts, clinical trials are probably the best way of moving forwards, because that's what gives patients access to new types of treatments. So this is one of those clinical trials we have at the University of Chicago, where we give patients who are going to have surgery anyways 2 cycles of immunotherapy and then do surgery. And essentially, we're trying to see if the immunotherapy actually works on killing the mesothelioma, and what does it look like, and is this a good proposal for moving forwards. So this trial is open. Actually, we had to suspend it for a little bit, and then now we're reopening the trial again. And then the second trial, which is a big multi-institutional trial.
So yeah, this is a very similar trial. So you've heard information about how chemotherapy works, and you've heard information about how immunotherapy works. And so what we're trying to look at is, can we combine them together, and does that work even better? And so this has been tried in other cancers and has been effective. And so and this is open actually for a lot of people, because this is a trial people can enroll in whether or not they're a surgical candidate or not. And so we would give chemo in this trial. We'd give chemotherapy, which is the standard, which is what you would get, off the trial. And then we're adding. So there's a randomization to that immunotherapy component to see if that adds and improves outcomes. And then we're doing surgery. And then if you're not a surgical candidate, you can still be on the trial and get the treatment. And the hope is maybe more people will then become candidates or be able to undergo surgery, or may not even, like you said, may respond. The surgeries aren't always the end goal. I mean, sometimes it is, but if people have such a great response with immunotherapy, I mean, you've heard, that's your immune system attacking it. So if that can be sustained and long term, patients may not need surgery, and so that's kind of the hope. And so we're the primary site, but it's actually at a lot of institutions. We've opened it throughout the nation, and so this is another clinical trial that we're hoping they'll have some success, and specifically for peritoneal mesothelioma, which is hard to do trials.
No, I know we're running on time, but I hope you've gotten a flavor of sort of where the state of the science is, like what happens normally. But I think to also keep a finger on the pulse of what is coming and what is the future of peritoneal mesothelioma. And I think, we really request you, and it's not just the two of us. There's a group of us peritoneal mesothelioma specialists across the country who would really benefit from your help in advocacy, research, really trying to advocate for this disease, because quite often it sits in the shadow of pleural mesothelioma. And I think while in general mesothelioma needs more advocacy in general, so I don't want to take away from pleural, but I would certainly say, please make sure that you advocate for peritoneal also. So for all clinical trials, try to make sure that patients with peritoneal are treated differently, or certainly with a focus. And so that's where we request all your help as well. But I think it's an exciting space. I think there's an exciting time for all our patients. Hopefully we make more and more progress every day. So we'll take any questions if any of you have any questions or comments.
Hello. I don't really have a question, but I just want to thank you guys both for being here. And then just say, Dr. Groats, you were my surgeon in December 2020, peritoneal surgery, and so far stable and doing well. So thank you.
Thank you.
Thanks for sharing.
Hi, I was really curious about the PIPAC. I was treated many years ago and had intraperitoneal chemotherapy much differently than this is. So, there's a lot of questions about that. Has there been any notice of seed tumor spreading at the incision points? How large are the incisions? My husband wanted to know, is it dynamic or hydraulic? I don't know what that means.
CO2 or fluid?
Yeah, it's CO2.
Okay.
And you said it wasn't fully approved in the U.S., but is it being done anywhere in the U.S.?
I'm gonna let Travis answer some of that.
I'll try it. Yeah. So I'll be honest. Honest. I don't personally do PIPEC yet, but we do at our Jacksonville Mayo Clinic site are doing PIPEC. And so it is. It's laparoscopic, so it's small incisions, somewhere between 5 to 10 millimeter incisions, and that you just need essentially two, one for the port and one for the camera. And it's CO2, so it's aerosolized. It's pressure. It's about 15 millimeters of mercury is the pressure that they do, which is what we standard would do for laparoscopy. So, and then seed tumor. Oh, I would say both for the laparoscopic and the PIPEC. In our experience, I think it's very uncommon to get cancer growth into the port sites is I think what you're seeing, and so and you can you're coming. Usually these are repetitive procedures, so you do them multiple times, and so you're coming back each time and kind of spraying it.
Do you leave ports in for that, or do you make new incisions every time?
You can go back to the same incisions, but you don't leave anything in. So there is I think Sugar Baker, and that's probably the only person I know. There's a few other places that do like leave catheters in, and give chemo while people are awake. So that's another, I would say it's the least studied route, but it is another route of doing it. But so PIPEC, there's no drains or anything left in.
Okay, and they drain the chemo back out the same day because they left mine in to dissipate.
So usually when, like if we're doing high PEC, which is again fluid, so liquid, you're right, we usually drain it out after the surgery. But if you're doing high PEC, it's air. So we do evacuate the air. And obviously, we have to get rid of that. And so there's a lot of OSHA and safety standards. Obviously, you can imagine aerosolized chemo can be dangerous to the OR staff. So there's a lot of that's one of the barriers and steps to getting PIPEC approved in the U.S. and to getting it in any hospital is just exposure to the OR staff.
I think what you might be describing is, did you have a port placed in your belly and got chemo afterwards? So that is something that it's called bidirectional. It's been called long-term bidirectional chemotherapy by Dr. Sugarbaker and some of the other colleagues that are doing this, where they're giving intraperitoneal chemotherapy in addition to the cytoreductive surgery. And that's been done in Colombia. It's been done at other institutions. Also interesting. Just remember, right now we don't know which way is the best way of doing it. And right now PIPEC is being applied in the setting of unresectable disease, which means we're not really thinking of surgery for them, even internationally, even in Europe. So I think, the hope is, can we start applying these in different and more innovative ways?
And thank you. I just want to kind of echo what she said. Thank you so much for being here. Yeah. I was at the first MARF conference here in 2006. So I'm a big advocate for HIPEC. I'm at 16 years. Yeah. So.
Yeah, and we need people like you. You're the face that gives hope to all our patients around, and motivation for us to do what we're doing. Yeah.
Thank you. We have another question.
Yes, I had HIPEC last year in May of 2021, and I started immunotherapy in July of last year. So I'm now coming up on my 1 year of immunotherapy. My question is, I've had one clear scan. I'll have another scan in August coming up. What is the general feeling or direction about the continuance of immunotherapy after so many scans? If you're clear, what is the feeling now or the knowledge now that exists that would direct the decision of whether or not how long to continue immunotherapy? That's my question. Thank you.
So I think you're asking a tough question that, to be honest, we all don't know the answer to. So first and foremost, the role of adjuvant immunotherapy, like what you got, is something that's, again, not proven at all in peritoneal mesothelioma. We all believe it. We all think it may have some value, especially in more high grade or what we call the biphasic or sarcomatoid. You might have heard it this morning. In those types of histologies, but we don't typically operate on them. So it's a very complex space. So what you're getting right now is something that we don't even know if it works. That's the first thing. And so therefore, we don't have any answers for how long to give it. Most of the company trials that have been designed have included immunotherapy for 1 year after. And so what happens after that 1 year, we don't know. There's some very interesting reports that have found that for immunotherapy that works, maybe a couple of months of immunotherapy may be all that people need, and that you don't need that continual immunotherapy. And then there's some reports that find that there's immune cell resistance that happens over time. Actually, Dr. Hassan is here, and he might be able to speak to this more intelligently than either me or Travis. Here, Rafid.
He's actually our next speaker, so
perfect. Maybe you can start off with that. I don't know if you had any other comments, Travis.
No, I think you'll answer that better.
Yeah, but congratulations again. I think it's great that you're doing well.
we do have one more question for you.
If the peritoneal is hard to detect or identify well on CT scan, what is the threshold for repeat treatment? Is there criteria for that, or how do you decide what to do next?
Yeah, I mean, I'll take the first stab at it, and then I'll have Travis speak as well. So, you know, the biggest thing is that there have been protocols looking at systematic second looks In fact, the protocol at Columbia, for instance, was routinely doing surgery, go back 6 months later for a second surgery. And that's just assuming the fact that you cannot see the disease. And they've reported some very good survival and good outcomes from patients that have had that type of approach. So I do think the interest, and it sounds like you guys are a case in point of that. But it is a big deal, to have second surgery all the time. It's not easy to put little cameras once you've had a big CRS and HIPEC. And so we don't have a very good way of truly saying this is when we should do a second look or a second. Many times we tell patients with mesothelioma that even if we don't cure you of your disease, you're going to live a long time with the disease. And so the real question is, if there isn't anything visible on scans, there aren't any symptoms or signs, should we really put our patients through another surgery just to find something that we may not do anything about? And that's the tricky part of deciding. Now, what is changing is that both imaging is getting better, and that there is new technology called ctDNA or cfDNA, where we're able to detect cancers in the plasma better. We don't know if peritoneal mesothelioma is going to shed a lot of DNA in the plasma, but that's sort of the areas of investigation where then we can use that to guide treatments for our patients. But as of now, I wouldn't say there's any standard of saying, let's go back and do another surgery if your scans are clear.
Yeah, I would echo that, and I would say, I think what's important is looking at the scans over time, and so looking for changes, right? So after CRS and HIPEC, especially that first scan, there'll be lots of inflammation, lots of fluid, lots of post-operative changes, and so really it's the change over time that we really are looking for. So it's really critical that the radiologist or the team is looking at the old scans and the new scans every time to try to identify things that have changed, because usually scar and inflammation gets better over time, and obviously untreated tumor would get worse over time. And there are some tumor markers that are sometimes elevated, so it's not perfect, but we can use that in conjunction. And so if there's something on scan plus there's a rise in tumor marker, that is would be very suggestive. But yeah, the research would certainly be in cell-free DNA and looking at other ways to liquid biopsies, they call them, to try to find it earlier. Yeah, thank you. Thanks, everybody.
I just wanted to introduce the next speaker. It's Dr. Hassan from the National Cancer Institute. He's a medical oncologist there and a senior investigator. His research is focused on developing targeted immunotherapy and immunotoxins for patients with malignant mesothelioma. He's going to speak today about clinical trial considerations. So without further ado, Dr. Hassan.
Thank you so much, Shannon, and thanks the Mesothelioma Foundation for the kind invitation to be here. So I'm going to talk about clinical trial consideration, but maybe I'll try to answer the question from one of the patients regarding duration of immunotherapy after surgery. As was mentioned, we don't have a whole lot of data, but there are some cases where we do that. In the metastatic setting where patients have disease, we typically do immunotherapy for 2 years. But when there is no disease, but we think there may be microscopic disease, the duration is not clear. So it depends upon your local oncologist, what he thinks is the appropriate time, whether it's a year or 2 years, but it cannot be indefinite. So I think it's something that we just learn, and especially depending upon the tumor type. So what I'm going to talk about is clinical trial considerations. So I just will give a big overview of what clinical trials are, when they may be appropriate, and what is involved in a clinical trial. And I will leave a lot of time for questions after this. As you know, there are 2 FDA-approved therapies for patients with mesothelioma. These include the pemetrexed or Alimta plus cisplatin that was approved by the FDA in 2004. And despite multiple clinical trials, we did not have any new drug approved for this disease until about 2 years ago, when FDA approved the immunotherapy with 2 drugs, nivolumab plus ipilimumab for patients with pleural mesothelioma. So we, at this time, have 2 drug regimens which are approved for patients with mesothelioma. In patients who have received these treatments and have evidence of disease progression, we often use other chemotherapy drugs, for example, gemcitabine or navalbine. And the other option is participation in clinical trials for these patients. So what is a clinical trial? These are research studies to find better ways to prevent, diagnose, and treat diseases, including mesothelioma. These are carefully planned studies to develop safe and effective drugs and to bring new treatments to the clinic. And it is based on these clinical trials that we now have the approval of nivolumab plus ipilimumab for mesothelioma, because over the last 8 or 9 years, we and others have been doing trials, small studies of these drugs, and ultimately led to a bigger study and approval. So all the drugs that are approved have to go through the clinical trial process. And of course, the participation in clinical trials is voluntary. So why should I consider participating in a clinical trial? One is it allows patients to receive new treatments that could potentially benefit them. And I want to underline the word potentially, because even as investigators who are involved with these studies, we do not know how a particular patient will respond to that drug. So we hope patients benefit from the new treatment, but again, we don't know that ahead of time. And it improves our understanding of mesotheliomas and allows physicians and scientists to develop better therapies. All of us who do clinical trials and work in the lab, it is really, we learn a lot from one patient, then we'll learn from 1,000 mouse experiments in the lab, because this is how patients tolerate treatment. We do biopsies of blood specimen. That gives us a better understanding of how these treatments work. So it clearly improves our understanding of the disease. And although a particular patient may not benefit from that treatment, it clearly benefits future patients, and it helps advance science. And I do a lot of clinical trials, and many of the patients I see know that they may not benefit from this, but they do it for altruistic reason. They want the next generation of patients to benefit from things they have participated in or contributed their valuable biospecimens. So the key point in a clinical trial is patient protection, and that is the ultimate goal. So clinical trials follow a well-planned protocol. It is a protocol that takes more than a year to develop, and before that, the science on which a clinical protocol is based usually takes years and years of research in the lab before we even write a clinical protocol. The protocol is a document that we as physicians, research nurses, patient care coordinators follow very carefully, because it explains the treatment plan, what are the eligibility criteria for patients to enroll on the study, and what safety information do we know about that drug. And all patients signed informed consent, which is very detailed nowadays, which describes in key details what are the treatments involved. It describes what scans you will get, when you will get the blood test, and more importantly, it talks about possible side effects that we anticipate from such a treatment and how we'll manage them. And all protocols are reviewed by scientific committees at the institution level. These are scientists who have a broad experience. They just want to make sure if we're doing a clinical trial in patient that there is science to support it, and there is good information based on different animal models or based on prior knowledge, so that they have to make sure that it is scientifically valid. And then it is reviewed by what we call as institutional review boards. These are boards which are independent, and that includes not only physician scientists, it includes patient advocates, it includes lay people, just to make sure that this protocol is safe for patients. Safety is the key concern. And all protocols are FDA regulated, so you have to get approval from the FDA that it is reasonable to do it. So what I'm trying to point out is that a lot of thought goes into clinical protocols, not only by patient scientists, but by patient disease experts, by layperson, and by the scientific community. So the eligibility to participate in a trial varies by what type of a trial is it. Is it a surgical protocol, it's a radiation therapy protocol, or is it a drug trial? Being a medical oncologist, I will focus most of my discussion on new drugs or new therapies. And it is important that the patient should meet the eligibility for that protocol. And what I mean is that the eligibility depends on what type of drug you are evaluating. If it is a chemotherapy drug, the eligibility criteria may be different. If it is an immunotherapy trial, the criteria may be different. For example, in immunotherapy trials, we need to be very careful that if you activate the immune system, it could cause some adverse side effects. So we want to make sure whether the patients have history of autoimmune diseases or they have had other problems. For other trials, such as targeted therapy, we do a lot of studies with mesothelin-targeted therapies. We want to be sure that if we are treating someone with mesothelin-targeted therapies, that their tumor has the antigen mesothelin. So patients might need to have a biopsy, or we need to look at their prior biopsy to make sure that they have the relevant antigen. And all these criteria are to safeguard the participants in these studies. So there are different types of clinical trials, what we call as treatment studies, and that's what I'm going to focus on in the next 10 to 15 minutes. These are studies which look at interventions such as drugs, surgery, or devices for efficacy, and it may involve testing new drugs or combination of drugs. And then there are other trials, what we call as screening studies. These are screening of at-risk individuals for early detection or cancer prevention. And this is more important in the mesothelioma community. As we know, about 10% of mesothelioma patients have germline mutations in the DNA in the blood that can predispose them to mesothelioma because they have a mutation in a gene called BAP1. So these individuals are not only at risk for mesothelioma, but they could get other cancers such as kidney cancer, eye cancer, melanoma, as well as their family members who may be totally asymptomatic. They have no evidence of cancer, but they are at the risk of developing these cancers. So at the NCI, we have a clinical protocol for this group of patients who have a germline mutation in BAP1, where we follow these patients over the course of their lifespan, as well as their healthy family members, to make sure whether they're at risk of developing mesothelioma or other cancers. So those are called screening studies. The other type of clinical trials are what we call as natural history studies. And these are studies where we try to better understand the disease at a clinical level and at a scientific level. And majority of the patients that we see in my practice at NCI, they come for treatment studies, but almost all of them also want to participate in the natural history study because they want to contribute their blood, their tumor, so we can better understand the disease, develop new therapies, and benefit future patients. So when you hear about participation in clinical trial, I guess one of the first questions that you ask the physicians or the research nurses is, what type of trial is it? Is it a phase 1 trial, phase 2 trial, or a phase 3 trial? And that is important, and I will go a little bit detail so that you have a better understanding of why it matters. A phase 1 trial in general is a first-in-human study. That's the first time we are evaluating a new drug or combination of drug in patients. And the goal here is safety, find the right dose, and it usually involves a small number of patients. Then we move to phase 2, where we want to get a better sense of how effective the drug is. And lastly, the phase 3 is to see, is it better than the standard of care treatment? So let me go a little bit detail about these different phases of the clinical trials. So the big overall objective of a phase 1 clinical trial is the drug safe? I think that's the question we as physicians and scientists are trying to address. So it is usually a first-in-human trial. As I mentioned, before we go to patient, usually there's a lot of science behind it. Usually it takes a decade or so before a concept or a new drug moves to the clinic. There have to be a lot of preclinical studies that are done in mice and monkeys so we get a better understanding of how it works. And we have to show at least that it works in a different animal models. And the goal here is to determine what is the highest dose of drug that can be safely given to patients. And cohorts of patients will receive increasing dose of the drug. So we start with what we think is a reasonable dose, and if patients do well, we keep on going until we see side effects which we think are not desirable. Then we can scale back and come to what is the right dose to give. So the safety in a clinical trial is the primary objective. Usually involves, in my experience, 20 to 30 patients to get a better sense. It depends upon the type of the drug. And it provides some early signals of efficacy. Although we are trying to figure out the right dose, but if we start to see some patients who are responding, that makes us excited that this drug could potentially benefit patients. And then we move to the next stage of a clinical trial, a phase 2 trial, where the goal is, does the drug work? And for this we need larger number of patients to get a better sense whether it works. And we treat the patients at a dose that we found out in the phase 1 trial. So all the patients get a similar dose of the drug because we know that is an effective dose or that's a safe dose. And we get also a better sense of the side effects of the drug. Although we have some idea what the side effects may be in the phase 1 trial, once we go to phase 2 trial, treat more patients, we can get a better idea of the safety profile of the drug. And usually a phase 2 trial includes a homogeneous group of patients, so we can get a better sense of how do patients with epithelioid mesothelioma respond, how do patients with sarcomatoid mesothelioma respond. So that is the phase 2 trial. So if we treat patients and we see activity that patients are responding or they're living longer, then we move to the bigger trial, what is called as a phase 3 clinical trial. This is usually a trial that includes a lot more patients. And the goal here is to figure out, is this new drug or combination of drugs better than what is already out there? So typically it involves a lot of patients, about 500, 600 patients, and the patients are usually randomized. What randomized means is they get a treatment which is, say, FDA-approved pemetrexed cisplatin versus the new drug. So we can then compare head-to-head. And in phase 3 trials, we look at overall survival. We want to see whether the patients live longer with the new drug. And usually these studies are done at multiple centers and internationally because if we treat them at a single center, there could be some biases, depends on what type of patients you get. So this is more of a bigger picture where you treat patients at different centers, different physicians, different countries. So we really get a big, nice mix of patients with different profiles. And also, as we treat more patients, we can figure out less common side effects that we might have missed, and we can accordingly treat patients. And if this trial is effective, then it leads to the sponsors submitting it to the FDA for approval. And so multiple drugs, clinical trials have been done in mesothelioma, and it was in 2020 that the ipilimumab trial went to the FDA and ultimately got approval. So a lot of trials, do not reach the phase 3 because they may not show efficacy in the phase 2 studies, but there are trials that go to phase 3. But even phase 3 trials can be negative, meaning that the new drug is not any better. But that is useful information to have because we don't want to treat patients with drugs that do not really work. So the question is, when should I, as a patient, consider participating in a clinical trial? So typically, patients and their oncologists look for clinical trials when the patients have progressed on what we call as standard therapies. However, it may be better to start looking or thinking about a potential clinical trial that is right for you early on. So, you are newly diagnosed, say, with pleural mesothelioma, you go on immunotherapy and chemotherapy. We know that those drugs are going to work, but at some point, those drugs stop working. So it may be good to think about it early on. And for some studies, as trials are getting more complex, we need to make drugs which are very specific to the patients. These are trials, for example, the CAR-T trials or the TRUC trial, where we take the patient's own immune cells. What we call as we do leukapheresis, get your immune cells out, send them to the lab, modify these cells, and then freeze these cells. And if down the road your tumor progresses, then we can give the cells back. So this process can be complicated. It takes about 2 to 3 months or sometimes more to make a drug which is specific for you. So participating early on, have the drug made, have it frozen, it may be a good idea. And then if you are not responding to a particular treatment, then the drug is available to be infused. So how different is it to be in a clinical trial than getting standard therapy with your local oncologist or in your community? So these trials are closely monitored. So there is no doubt that there is increased time commitment from patients. There is more frequent tumor imaging and blood sampling, both for research and to monitor side effects. So there's a lot of commitment for the patient. And, for some drugs, you can go to your local oncologist, get the treatment, go home the same day. But for clinical trials, depending upon what type of a clinical trial it is, there's more time commitment, more imaging, more needles, more scans. And you can have side effects from the novel treatment, and these can be life-threatening and severe. And some of, I have been doing phase 1 clinical trials for a long time. And when we have trials, especially trials which are truly new or novel therapies, I just want to be sure that the patient and the family members are fully aware of the clinical trial. And usually I see the patient 2 to 3 times before, we'll sign them on to the clinical trial. Because the patient needs to have a good understanding, okay, if I'm committing to this trial, it may not benefit me. And on the other hand, I could get side effects that can be severe and life-threatening. So these are complex discussions, and I always, want to make sure that the patients, we give them the copy of the informed consent, but we want them to read it and to understand it, have multiple discussions with the physicians as well as with the research nurses, and so that there are no surprises and the patients anticipate some of the side effects. So if a protocol we have, and I tell the patients it's likely that you will go to the intensive care unit for a few days, you might get this side effect, then the patient is prepared that if they get those side effects, they are not as anxious. But again, participating in a clinical trial, especially phase 1 trial, has to be, very well-informed discussions with not only the patients, but also the caregivers, because that's important. Sometimes if the patient is in the ICU and sick, at least we have that relationship with the caregivers, their family members, their partner, their children that we can discuss. And clinical trials also involves travel to different institutions. The clinical trials may not be available in your local community. So that might involve going to a different city or different place and staying there for a few days or weeks, depending upon the nature of the trial. And there could be economic costs for patients. Many of the clinical trials are covered, but that still involves, and many institutions help with the costs. At the National Cancer Institute, we are very fortunate because it's a taxpayer-funded institution that we don't have any costs for any of the treatments that we do. We don't bill insurance companies. We pay for the patient's travel, but still it is a lot to live in Bethesda, although we try to subsidize that. So who is the main contact when you are in a clinical trial or considering a clinical trial? Obviously, the physician in charge of the study. So we call them the principal investigator. So principal investigator is ultimately responsible for the conduct of the study to make sure that the study is conducted in an ethical manner and overall responsible for patient safety. But from a practical purpose, I'll tell you the most important people for a patient is the research nurse and the patient care coordinator. So the research nurses are absolutely the life of a clinical study. They are the ones who are really very knowledgeable about the protocol. They are advocates for the patients. They make sure that all of us run the clinical trial the way it is written, and they are a great resource to patients. So in my practice, I see that all the patients will call or text my research nurses all the time for any question, and they are great resources. None of these studies would happen without them. And so I think it's also important, as I mentioned, to weigh the potential benefits of enrolling in a clinical trial with potential side effects. And of course, patients can stop participating in a clinical trial at any point for any reasons. We usually ask that if you decide to do so, talk to the research nurse or the physician, because there may be certain safety things we need to do. If you're in a trial, we might want to monitor your blood count if they are low. But of course, participation is voluntary and you can stop at any time for whatever reason. But it's better to have that discussion with the principal investigator and the research nurse. So in mesothelioma, there are a lot of clinical trials. I don't want to go into the specifics of each of them because every trial has different requirements for participation. But although mesothelioma is a rare disease, it has been a disease where we have had a lot of clinical trials, and they have gradually increased our understanding of the disease, led to better therapies. And I just want to point out to surgical therapies. Many of you have had peritoneal mesothelioma. It is just by this carefully conducted work, looking at HIPAC or other approaches, that peritoneal mesothelioma patients live longer. A lot of pioneering work by Paul Sugarbaker and Richard Alexander, Dr. Bartlett, and others about 2 decades ago have led to the stage where we now HIPAC and cytoreductive surgery is standard of care for peritoneal mesothelioma. So, but there are other drug therapy trials, for example, trials targeting mesothelin, including cell therapy, what we call as adaptive cell therapy trial. You've heard a lot about immune checkpoint blockade. These are drugs which make your immune cells more effective, and there are trials where you combine these with different agents, anti-angiogenesis agents, cancer vaccines, a lot of different trials. So, but all of these trials have different eligibility criteria to be on study. So lastly, how can you find a clinical trial that is right for you? I think the most important thing is to discuss with your treating oncologist. They're very knowledgeable about what's going on in the field and will be able to point you to trials at particular places or a particular type of trial that may be good for you. Cancer advocacy groups, for example, the Mesothelioma Foundation, they have got a pretty good idea of the scientific work in mesothelioma, what trials are going at different institutions. They have an overall sense of what may work for you, but of course, they would refer you to the principal investigator to figure out whether you are eligible for those studies. Clinicaltrials.gov is an excellent website for not only for mesothelioma but for clinical trials. So it's a very easy website. Even we as physicians, if I have a patient asking me, is there something else, I can go on. We just go to the site, put in mesothelioma, you'll get an updated information of the different trials that may be available. And on that website, they always have the name of a contact person. So feel free to call the research nurses or the investigators and figure out whether you are eligible. And that's how many of our patients that we see in our practice. And then there are many NCI-supported clinical trial network. So I think that is an overall sense of what the landscape there is for clinical trials and options, but for a specific trial, it is, you would have to check with the research nurses and the principal investigator, and usually they get a pretty good sense of whether it's a right trial for you, and if they think it's a right trial for you, they would like to look at your documents, review it in detail, and then schedule their consultation and provide you more information about the trial. Thank you. So happy to take any question.
Anybody? I have a question from the live stream. So one of our viewers from home would like to know if long-term mesothelioma survivors can ever be considered cured.
Sure. So that's, I would say so, but again, we in mesothelioma have been kind of, we haven't come to, so for some tumors, if someone is 5 years out, 10 years out, one would think that they're cured. Especially with peritoneal mesothelioma, we see a lot of patients, even in this room, who have had surgery 15 years. So I would say that probably cured, but we still need to follow them closely. It's a rare disease. So in breast cancer, you have lots of patients. You have enough data to say, okay, if patients are 10 years out, we know that 90% of them will never come back. But mesothelioma is a rare disease, so we are a little tempered in our discussion whether to call it cured. But I think every year the patient is doing well and the disease doesn't come back. That's a good sign. So.
Hi, you'd mentioned screening. I know there's a lot of newer screenings out there. Are there specific markers to look for if you're looking at getting a screening?
So that's a great question. So we do not have a great blood test or other tests for screening for recurrence of mesothelioma. We do the imaging. But the screening right now in mesothelioma, I think, is more relevant for the BAP1 mutation. If there is a germline mutation in the BAP1 gene, it is critical, I think, to be screened. Not only the patients, but also their family members who are apparently healthy. Because if we detect some cancers early on, we can cure them. For example, if you have a germline BAP1 mutation, then your family members could be at risk for developing kidney cancer. But if we screen them, we could remove the kidney cancer and cure them. Or if they develop melanoma, we screen them, remove the melanoma. So I think there is an enormous benefit of screening, especially in those with germline BAP1 mutation, because it can save patients' lives, but also save lives of healthy individuals who otherwise we would never test. So that's the scenario where I think it's going to have the most impact. But your question about whether we can screen patients with some other tests who have been many years out, we don't have a perfect test yet. We still rely on imaging.
Any other questions? Yes?
Given the rarity of mesothelioma, how many clinical trials actually make it to phase 3?
So question, how many phase 1s make it to phase 2?
How many get to phase 3?
Phase 3. I would say in general in oncology, not only in mesothelioma, I would say that going from a phase 2 to phase 3 is a higher burden, a higher bar. And I would guess, I don't have the numbers, probably 20% or so, 20%. Many of the trials stop at phase 2 because you do not see enough signal. So I think going from a phase to phase 3 is a high bar to cross because it's a bigger study and you have to be convinced that it is benefiting patients. And then you need to have the sponsor to conduct such a big study because these are very expensive studies. Unless the investigators and the sponsors are convinced that they're seeing good signs, going to a phase 3 doesn't happen. So I would say maybe about 20% go to phase 3 or less.
Trials in phase 3 now?
There are phase 3 trials which are looking at combination of drugs. We know that immunotherapy works. Combining immunotherapy with chemotherapy is another important avenue. So there are phase 3 trials which might combine immunotherapy alone versus immunotherapy plus chemotherapy or other agents.
So when would one decide they want to try to sign up for a clinical trial? Like when you're, going along with your stable scans, or when you are, kind of looking at there aren't a whole lot of options left?
Typically, it is the later when there are not a whole lot of medical options left. But if someone has had disease and if it is still stable disease, for some of the trials you might want to consider at that time if the trial involves making a personalized drug. As I mentioned, that if you need to get, for example, CAR T-cell therapy or others, which takes 3 to 2 months to make the drug, so it might be a good time to participate at that time. But for others, mostly patients, once they have progressed or it looks like they're not responding to the standard therapy, that would be a good time. Okay, very good. Thank you.
All right, you guys are stuck with me again for just a few minutes here. I just wanted to touch base a little bit on some treatment side effects. You guys have heard a lot today because the doctors that have talked before me have gone over these very well. But I just wanted to go over a few of them with you and just a few other things from the nursing point of view of what you can do and what you need to do to make yourself successful during treatment. So I think it's really good to understand why these side effects occur, and in order to do that, you have to understand what these drugs are doing. And so it was discussed earlier that chemotherapy is cytotoxic, and what it's meant to do is to destroy rapidly dividing cells throughout the body. It cannot differentiate between cancer cells and healthy cells. And we have a lot of rapidly or quickly dividing cells throughout our body, but the ones that we see most are things like blood cells. So it can make you anemic, which leads to fatigue, probably one of the biggest side effects that people get when they're on chemotherapy and long term. Neutropenia, which is our infection fighter, so it can lead to that. And thrombocytopenia, which is bleeding. We also have rapidly dividing cells in our digestive tract, and this is why we see things like mouth sores or mucositis, dry mouth, nausea, diarrhea. We have nerve cells that are impacted, and this is neuropathy, and also hair follicles are rapidly dividing as well. This is why a lot of people lose their hair when they're on chemotherapy. The platinum-based chemotherapies also come with some of their own subsets. We can see hearing loss as well as ringing in the ears. It's very important to let your physicians know if you have any of those because they can be long-term if you just keep letting it go on. It can get worse. We also see nephrotoxicity, so renal failure. Acute renal failure can happen, and a lot of patients complain of like a metallic taste. Alimta can cause radiation recall and rash. And you're given folic acid and B12 to help lessen some of the very harmful side effects with the Alimta, so it's very important to stay on that regimen. What we know about chemotherapy is that the side effects are often predictable and they're cumulative. So what we hear most from patients is that they usually happen around 24 to 48 hours after the infusion. They can last anywhere from 3 to 5 days. Your nadir, which is the lowest point where your blood counts are at, that usually happens somewhere between day 14 and 21. That's when you're most susceptible to infection. That's when you really want to watch that you're hand washing, you're doing good hygiene and things such as that. Doses of chemotherapy are usually based on what's called body surface area or your creatinine clearance. And these can be modified somewhat for better tolerability. So if somebody's having trouble with one of the platinum-based chemotherapies, a lot of times we can modify those for you to make them so that you do better, you don't have as many side effects. With chemotherapy, most side effects will subside once the chemotherapy ends. Now, there are some that are long-term, so neuropathy can be one that's long-term. Very important to tell your oncologist if you're having that. As well as, like I said, the hearing loss and the ringing in the ears. We have really come and made great strides for minimizing the side effects of chemotherapy, especially things like nausea. We have such great medications on board, so please keep your care team informed because they can help you through those. Don't feel like you have to power through them. It's not what we want you to do. We want you to ask for help. We want to help you so that we can get you through all those treatments as best as what we can. So we have the immunotherapy now, which is very exciting. And I believe it was Dr. Kindler who said, many people think that with immunotherapy you don't have as many side effects. That's not really true. It's just a different set of side effects. To understand these, you need to understand that what the immunotherapy is actually doing is that it's allowing your immune system to recognize these tumor cells and attack these tumor cells. So if you think of a brake pedal, your immune system normally is in checks and balances and has a brake pedal to it. So if you get an infection, it comes at full height, it gets rid of that infection, and then it goes back into a dormant state. When you're on immunotherapy, that doesn't happen. It keeps you heightened all of the time. And so what happens is that immune system then starts to attack healthy cells as well. And it can really cause inflammation anywhere within the body. And when I used to teach immunotherapy, what we used to always say is that these are the itises and the isms. And it's kind of an easy way to remember what can happen while you're on these. So colitis is one of the big ones. Colitis can be abdominal pain, diarrhea, mucus, blood. Hepatitis, the endocrinopathies, so hyper and hypothyroidism, diabetes, and something that's called hypophysitis, which most people have never heard of, but this is an inflammation of your pituitary gland. It can actually present like brain mets. So many people who were on the lung cancer forefront of the Opdivo and the Keytruda, we initially would think that it was brain metastasis because they would come in with confusion and headache and all of the classic symptoms of that, but it's actually an inflammation of the pituitary gland. Pneumonitis is really large, so this is inflammation in the lungs. Definitely something that needs to be caught and treated right away. Muscle and joint pain, I get a lot of this from patients, so definitely if you're having those arthralgias, you need to let your care team know. And pruritus or rash. Sometimes rash can itch, sometimes it doesn't. This is one of the ones that can wax and wane, so it's really good to take notice. Do you get it right after the infusion? Do you have it during the infusion? Does it come 2 weeks after the infusion? Does it get worse with each infusion that you have? Immunotherapy side effects are really different from chemotherapy because they're very unpredictable. They can occur at any time throughout treatment, as well as once treatment ceases. So the slides that Dr. Kindler was showing you, where we have seen where people who are even a year out from immunotherapy are still responding to it, that's amazing. But you're also still susceptible to getting those side effects at that year out as well. So we have seen people that have shown up with a hyperactive or a hypoactive thyroid or pneumonitis, and it didn't occur to them that it could be the immunotherapy because they haven't had it for so long, but it can be. Immunotherapy is given often with fixed doses. There's little flexibility in the dosing and the treatment schedule. The side effects of immunotherapy are graded. Chemotherapy are graded as well. Immunotherapy, it's just a little bit more strict to know these grades because they dictate how you can move on from these side effects. So it's graded from a 1 to 5 based upon severity of the adverse event. The earlier the event is reported, the more appropriately we can treat it, and the better the outcomes. So when you get to a grade 2 or a grade 3, we know that that warrants intervention. We want to intervene as soon as possible. When you get to a grade 3 and at a grade 4, it's recommended to permanently discontinue the immunotherapy. We don't really want you to get there. We want to keep you so that at a grade 2, if we have to withhold immunotherapy for a month or two and get somebody on steroids so that we can bring that inflammation down and get you restarted on the immunotherapy, that's best case scenario. So very, very important to, I tell people to keep a journal, tell your oncology team right away if any strange symptoms occur, even if it seems very minor to you, it could be very big in a short period of time. One of the really great things about Bristol Myers Squibb, who makes Opdivo and Yervoy, is that on their website they have a checklist, and your oncologist may have these as well. And it tells you to check off what you're feeling. Has anything changed from one treatment to another? Are you noticing something different? Another really, really big thing to know is that they also have wallet cards, and this is huge. And it was really big when these drugs first came out, because when patients show up at a ER with some sort of a side effect, and they tell the person they're on chemotherapy, because who can remember when you're in a situation where you're in an ER and it's acute and you're scared what you're really taking. But for chemotherapy, we don't treat the side effects the same. So it's really important to carry that wallet card or something on you that says what you're really getting, so that they know that they actually need to treat that appropriately. Hydration will do nothing for somebody that's on immunotherapy that has colitis or diarrhea, because you're not treating that underlying problem, you're just putting a Band-Aid on it. So very important, and their website is wonderful. It gives a lot of supplemental patient education materials, as well as materials to bring along with you if ever anything should happen. And then just briefly on the targeted therapies, so Avastin is something that we have seen that's been used in this space. Again, a lot of our research is looking at targeted therapies right now. The side effects with these targeted therapies are usually related to what that specific target is for that drug. So with Avastin, it's VEGF. We talked about this earlier, but it is blocking the growth of new blood cells, so new blood vessel cells. So it's cutting that blood supply off to that tumor. So with that, we see things like nose, gum, you can get rectal bleeding, high blood pressure is really big, stroke, pulmonary embolism, DVTs, and decreased wound healing. So most people who have had like a DVT or a PE in the past are not even eligible for to go on to Avastin. And somebody who has had surgery recently, they would withhold the Avastin for a while, and then they may start it down the line with the chemotherapy, or it would be a drug that they would stop so long before you were going to have surgery. So those are all the things that we're looking for. I hope that helps you guys a little bit. I want to introduce you to Dr. Monica Malec. She is from the University of Chicago. She is one of the palliative care doctors there, and she's going to talk a little bit about that with you guys.
Hi, good morning. Thank you everyone for coming out today. Thank you, Shannon, and thank you to the Mesothelioma Applied Research Foundation for the invitation to come here and talk to you all today. I'm going to be talking to you about the role of palliative care in cancer care, including mesothelioma. A little bit about me. I'm actually part of Dr. Kindler's mesothelioma team at the University of Chicago. So I am in the clinic with them. I see patients alongside them. I go to the tumor boards. I hear about the patients and how they're doing, and what kind of other symptoms they might be experiencing. So we work together as a team. So palliative care is specialized medical care for people who have a serious illness, like cancer. This type of care is focused on providing relief from the symptoms and stresses of serious illness. And the goal is to improve quality of life for both the patient and the family. We really acknowledge that a diagnosis of a serious illness upends your life. Early incorporation of palliative care into cancer care is recommended by an increasing number of professional organizations, including the American Society for Clinical Oncology, or ASCO, the American College of Surgeons Commission on Cancer, the National Comprehensive Cancer Network, and the National Academies of Science, Engineering, and Medicine, formerly the Institute of Medicine. Palliative care is appropriate for you if you're experiencing pain or other symptoms and stresses from your diagnosis, from your cancer, from the disease itself, or from the treatment. And palliative care can be provided at any point during an illness alongside your curative treatments. So you can see that in an ideal situation, you are starting from the moment that you have any symptoms or stress and continuing on through the course of your treatment from diagnosis through survivorship. The line, I can honestly say, is not usually that smooth. There's frequently ups and downs, and I think if you've been through treatment, you've experienced that. So, sometimes we're more involved and see patients more frequently, and sometimes we back off and we haven't seen people in, months and months because everything is going really well and they don't need too much from us. So it's just a high in the hallway at that point. So, let me see. Sorry. So as I said, we work together with your other doctors as an extra layer of support for you. And the team provides expert pain and symptom management and additional time for communicating about your goals, and both personal goals and illness goals and treatment options, to give you just more time to talk through how a different treatment might fit into your life and if it makes sense for you. As well as helping you navigate the medical system and ensuring that you have the kind of support that you need when you need it. What you can expect during a palliative care consult. So typically we start with the reason for the consultation, your understanding of your illness and the goals of the treatment and what you might expect from the treatment. And clarify the role of palliative care as part of your medical team and how we'll be communicating with your oncology team. And then review of the symptoms that are affecting your quality of life. And this can include pain, fatigue, shortness of breath, nausea, poor appetite, difficulty sleeping, many of which are very common in mesothelioma. I starred the ones that are most common in pleural mesothelioma. Often nausea, poor appetite, abdominal bloating are more common with peritoneal disease. But we have multiple means of managing these symptoms. And so it's important to share if initial lines of treatment are not working for you. And typically your oncology team will start treatment for symptoms and side effects. And often palliative medicine starts getting involved if those initial treatments aren't working the way we want them to. The goal is really to understand how this illness is affecting your day-to-day life and help you continue to live your day-to-day life and ensure that you have the kinds of supports and symptom management that you need to live as well as you can in the face of a serious illness and as you're going through the treatment. We assess your sources of support and coping and encourage you to partake of those and ensure that you're not withdrawing from all your supports and coping supports so that you have them in place So we don't want symptoms to be in the way of your ability to get out with your friends and do the things that help you feel better. And then provide a plan of care, which may include medications, referrals to other providers, including nutrition or physical therapy, sometimes our interventional pain services, and we coordinate with the oncology team. But again, the goal is to help you live well in your day-to-day life as you're going through your cancer treatment. Palliative care has many proven benefits. There's a growing body of literature of the benefits of palliative care, including improved symptom management, improved ability to tolerate treatments. It reduces caregiver stress and anxiety, improved quality of life, and it may prolong life. There are several studies that show a significant prolongation of life with palliative care implemented earlier in the course of care. Palliative care and hospice share a philosophy of care, but are not the same thing. Palliative care and hospice services both acknowledge the many stresses of serious illness and coordinate the support of an interdisciplinary team to promote the best possible quality of life. Often, the initial visit with me, people are scared. They're concerned that what is my doctor trying to tell me? And typically we're trying to say we're here to help you with this symptom that you've been experiencing. But that's usually the first part of the conversation. Hospice services provide palliative care in the final months of life. So if we think about palliative care as a focus on quality of life and symptom management and support throughout the course of your illness, hospice is this focus in the final months of your life. And hospice services are the gold standard model for quality, compassionate care in the final months of life. Hospice services are a wide range of services that surround the patient and family and support them during this time. This is most appropriate at a point in time where the decision has been made to shift the goals of care towards comfort and support, when further cancer-directed therapy is no longer desired or possible. And most of these services are done in the home. They come to you. So I am pleased to share this video about palliative care with you. This is something that was created by our regional therapies team of surgical oncology with Dr. Taraga. I don't know if Dr. Taraga is still here. Dr. Taraga's team made this video, and you are the first to see it outside of us. So this is a short patient education video about palliative care.
Palliative care is medical care that deals with symptom management and better quality of life for people with serious illnesses like cancer. People can see palliative care providers at any time during their treatments, along with their other medical teams, to get support for issues including pain, nausea, appetite, problems sleeping, and they can help you make a plan for who would make medical decisions for you should you not be able to, which is called advanced care plan. Palliative care specialists can also be part of the conversation you have with your medical teams. Your palliative care provider can help as you and your loved ones are trying to understand what your treatment options are and which treatment makes sense for you, your values, and your goals. Palliative care is not the same thing as hospice care. Hospice care is end-of-life care, while palliative care is medicine that helps keep you and your goals at the center of your treatment plan. Palliative care doctors and teams provide an extra layer of support for patients and families as they face the challenges of living with a serious illness.
So I think that very well summarized most of the major points that I wanted to make. But finally, I think it's important to know that often the best way to get palliative care is to ask your team for palliative care. Many academic centers have palliative care within the academic center. Many of them have palliative care embedded into their oncology clinics or very nearby their oncology clinics. So the services are available to you. I would encourage you to not be afraid to access those services, especially if you feel like I'm not doing as well as I would like to be doing in my day-to-day life. Thank you.
Do we have any questions for Dr. Malec?
Or Shannon.
Or Shannon? If not, we have encroached on your break, so please go ahead and do take a few minutes. We are going to be back here at 10:45. No, we won't, because it's 10:42. So we will be back here in about 10 minutes. So try to just grab your snacks, coffee, and then come back. Thank you. Yeah, could you say something like test or something of sort? He is kind enough to give his presentation via Zoom.
and to target it for you guys, patients, family, and caregivers. Whoops. Give me 1 second here. We got a technical. So I have no disclosures. I have no conflicts to report, and I've been to this meeting before, and I know there's food around, so I'm not going to put any surgical images in here. Give me 1 second here. Let's see. Okay. So what roles can surgery play with mesothelioma? And there's really three roles. It can be used for diagnosis, it can be used for palliation, or it can be used therapeutically. And I'll go through each of these. Diagnostic procedures. Now, this is not technically an operation, at least by surgical standards. It's more of what we would call a procedure, but a thoracentesis. And I thought I would just take a moment to explain some of this. This is something that my patients often ask about, where the fluid come from, how to come from, because the majority of patients with mesothelioma, pleural mesothelioma, present with shortness of breath, and it's related to the fluid accumulating. And if you look at this cartoon on the left here, can you guys see my arrow moving? Is that visible?
Yes, we can.
Great. So this cartoon shows the chest cavity, and basically humans have two separate spaces. So you have the way it's oriented, at least in this country, is that the patient is facing you. So this would be the right side. This is the left side. This is the left lung. This is the right lung. And this is a pleural effusion, just meaning that there's fluid in this pleural space. And in humans, these two sides are separate. I'm often asked, why didn't the fluid go from one side to the other? And it's just in the one side. Every day, a couple of cups of fluid come out of the lungs and get absorbed by the lining of the chest cavity, primarily along the diaphragm here, which is down at the bottom. And anything that throws that balance out, so at any given time, though, it's like a stream. At any given time, there's only maybe a few teaspoons of fluid in the pleural space. But if something throws that balance out of whack, it could be too much fluid to absorb. So the most common probably being congestive heart failure, or if you have a pneumonia and the lung is kind of weeping fluid, it's too much to absorb, you'll build up the effusion. That's kind of like the snow melting in the mountains. Your stream overflows, you end up with a lake. With mesothelioma, it's really the cancer kind of plugs up these little holes here where the fluid gets absorbed and that fluid accumulates. So it's like putting up a dam. Your stream overflows and you end up with a lake. So that's how you get these pleural effusions. This X-ray in the middle shows this. Again, patients facing you. So this is the right lung, and the X-rays go through the air easily, so it looks black. This is the left lung, is all squashed down here, and all this, the diaphragm should be down here. This should all be black, but that's all fluid. And so when you do a thoracentesis, you basically just put a needle in there and you suck that fluid out, and that's what you can see in this cartoon over here. That can give you a diagnosis. Now, what I'll tell you is interesting is that only about 60% of the time, so just a little better than a coin toss, if a cancer is causing the pleural effusion, only about 60% of the time do the cells actually end up in the fluid. So it's fairly common for patients to present saying, geez, they didn't see any cancer in the fluid. And that unfortunately is common up to 40% of the time. And so that's the diagnostic limitations. The other thing is that a thoracentesis, although it will provide initial relief, and that's absolutely the appropriate thing to do when someone presents with fluid and you send it off for all the tests, that fluid is going to reaccumulate in the overwhelming majority of the time. So it may only last a few days, it may last a week or two, but it's not a permanent solution because, like I said, it's like a stream and it keeps kind of overflowing and you'll build up this fluid here. The smallest thing that can be done, the smallest procedure that can be done to give a diagnosis, a real diagnosis, via core needle biopsy. This CT scan shows basically this is a lung nodule. The patient's actually lying face down. This is the spine in the back here. So this is their back is up, and they're putting, you can see on the CAT scanner, they're using that to guide the placement of this needle. And if you look over here, they're kind of these fancy needles. It's got this is the needle on the inside, and this is a sheath on the outside. So you put this needle through the nodule here, and then you close this down, and it gets a little sliver of tissue that you can actually look at. So it's not just what we call cytology, which is up here when you send that fluid. It's just the cells that are floating free in the fluid. Here you actually have a small sliver of tissue. So that's the smallest thing that can give you an actual diagnosis. And I'll tell you why that's important is that for surgery especially, there's several, as most of you probably know, there's several subtypes of mesothelioma. There's an epithelioid subtype, there's a sarcomatoid subtype, and there's what we call biphasic or mixed, which has elements of both. And whether or not, what subtype it is can guide whether or not surgery is appropriate. And I'll talk about that a little more later. But now it's also appearing that the subtype can influence the appropriate type of systemic therapy, whether you get immunotherapy or chemotherapy or a combination. So the subtype is important. And of those two types of cells, the epithelioid cells or the sarcomatoid cells, only the epithelioid cells actually shed into the fluid. So you can have a biphasic cancer, meaning that you have the sarcomatoid subtype, which could influence treatment options, but those cells don't show up in the fluid. So a biopsy is strongly encouraged the overwhelming majority of the time, and I would say is actually essential if you're considering surgery as a treatment. The next thing would be a video-assisted, now this I would call an operation, a video-assisted thoracoscopic biopsy, or VATS is a term that you'll hear. And what that is, now this is a picture I lifted off the internet. This is showing a lung cancer operation, but basically the patient's on their side. We put a video camera through one hole, and then we can put these instruments in through the others, and you can do an operation while you're watching on TV with specially designed instruments. When I do this for mesothelioma, the overwhelming majority of the time, you can do it through a 1/2 inch incision, and you can actually, so you can make a small incision, you can put a suction in alongside a video camera, you can drain all the fluid out, and then you can do your biopsies. And the other thing is that this can be combined with palliative procedures at the same time. And I'll talk about them on the next slide. And then the last thing is for an open surgical biopsy. And what I would tell you is that the ability to do a video procedure means that there's space in the chest cavity that you could put the video camera into and operate. But mesothelioma, although it can often present with a small rind of tumor lining the chest cavity, but there's still fluid, you can put a video camera in and have space. But sometimes you'll have a thick rind of tumor and there is no space. And in fact, the lung, it's like someone just poured cement into the chest cavity. It's coating the lung, and it's up against the chest wall. And in those cases, what you can do is you can make a small incision, and you basically just cut down between the ribs, and you can get some biopsies that way. So that's the other way to establish a diagnosis. I would tell you that if someone is talking to you about doing a major chest operation where they do a regular incision, which can be, 4-6 inches long, I would have trouble coming up for an indication to do that. This can almost always be done through a small incision because the lung is already stuck up to the chest cavity. There really is no chance of the lung collapsing. So you don't even have to put a tube in after the surgery. And this is almost always an outpatient procedure. If I do the video procedure and I'll typically leave a tube in there, patients can go home the same day, but often I'll leave them in overnight just for their own comfort and to kind of help get the drainage kick-started. So speaking of the drainage, the next role for surgery is palliation. And this can be performed as a separate procedure or, like I said, combined with the VATS procedure. So if you present with fluid in the chest cavity, like over here, then one of the ways that you can palliate this, you can help with that because you want to keep that lung expanded. What happens is that if the lung, that fluid in there has a lot of protein and other material in it, and if you leave the lung has the consistency of a sponge, the fluid is is not compressible. So if the fluid accumulates in the chest cavity, the lung gets compressed, and then the fluid can actually, like an onion peel, can layer on top of it. So even if you take the fluid out, the lung won't re-expand, and that's called entrapment of the lung. And you want to avoid that because it makes it harder to breathe. Even if you drain the fluid out, it can compromise your quality of life. It can actually make it harder to eat, because this fluid, if you think about it, this fluid can be up to 2 liters, even more. If you think of like a 2-liter bottle of Pepsi in the chest cavity, pressing down on the diaphragm, which is a pliable structure, that pressure can get transmitted to the stomach and actually squash the stomach down. So patients have a symptom we call early satiety, meaning they take a few bites and they feel full. And so draining this fluid out can also help with that. So that's another common presentation with mesothelioma, is patients losing weight. They'll say, I can't eat. It's because they feel full all the time. So draining the fluid, this is called a tunneled catheter. This is probably my preferred way to palliate someone with a pleural effusion. You can see this little cuff here. They're all pretty much the same. I think there's different brands. This part here is kind of like a soaker hose. It has a bunch of little holes in it. This is about, 2/3 the diameter of a pencil. A little bigger than a phone cord if people have phones with cords anymore. But it's pretty narrow. It's made out of a squishy material, silicone, so they're pretty comfortable. This part sits under the skin here. This is a little fuzzy cuff that prevents the bacteria from being able to migrate in, so it keeps us from getting infected, and it also anchors the tube. And then this part sits out here and gets curled up underneath the dressing. This is a valve, and so what happens is you put this tube in, it sits in here like this, and then you can see in this cartoon, you connect these two together. This is a vacuum bottle. It sucks the fluid out. So this gets sucked out, the lung can re-expand, and that can really help a lot with the fluid. And in fact, if the lung fully re-expands, typically over a few weeks, the lung will stick up to the lining of the chest cavity, the fluid stops draining it, and you can take these out. And to take these out, that's something you can do in the office. The other option to palliate the fluid is a pleurodesis. So at the time of surgery, which you can do, or even just through a tube, you can put in a material in here. You can see the lung over here, and it causes irritation and basically gets the lung to stick up to the lining of the chest cavity, basically gets cemented up there so that the fluid doesn't have any place to get into and it doesn't drain out. What I would tell you is that this can be a good option, but it really is predicated on the lung re-expanding, and it is a mistake to try and do a pleurodesis if the lung doesn't fully expand, because the most common, if the lung isn't pressing up against the lining of the chest cavity, it can't stick there. And the most common material that is used is, believe it or not, talc, which is talcum powder, which is a mineral, and that's a permanent foreign body. The chest is great at clearing infections as long as the lung is fully expanded. But if you have a space and you have this foreign body sitting in there, if that gets infected, that can be a really devastating and challenging problem. So I try and shy away from pleurodesis unless the lung fully expands. So let's move on to the last role of surgery, which is the therapeutic applications of surgery. And let me start with this, and I tell every patient this: surgery is not, I repeat, not the standard of care treatment for mesothelioma. The standard of care treatment for mesothelioma is systemic therapy. So until recently, it was just a combination chemotherapy, pemetrexed or Alimta is a trade name, and a platinum drug, cisplatin or carboplatin. Recently, there's been now the immunotherapies which have come into play, and those can be considered standard of care as well. Surgery is not the standard of care. It's an aggressive treatment which is only appropriate for select patients. Why is that? You can't cure anyone with surgery alone with mesothelioma, and I'll show you why, but let's start with cases where you can cure someone with surgery. So if this is a lung cancer sitting here in this lung, and it's completely encapsulated, it's surrounded by all this normal tissue. If you take this out and it has not already spread, then you can cure someone of that cancer. You haven't violated the plane of the tumor, there's no cells leaking out, and you have what we call a microscopically complete resection, or sometimes in surgery we call it an R0 resection. But basically, you can remove the tumor intact without spilling any cells. Surgery for mesothelioma is a totally different situation. The cancer for mesothelioma coats every surface in the chest cavity. It coats the lining of the chest cavity, it coats the lung, it goes into all the nooks and crannies between the different lobes of the lung, it coats the pericardium, which is the sac around the heart, the diaphragm, your breathing muscle. It's everywhere. And that operation is more analogous to like scraping paint. And so if you look over here, it's like, gosh, looks like the guy got everything. But if you look with a microscope at this board, you're going to find a paint chip somewhere. And if that paint chip is a live cancer cell, it's going to multiply and divide, and pretty soon that board's going to be repainted. So the best you can do with surgery for mesothelioma is to remove all of the detectable disease, anything you can see or feel, but there's always going to be microscopic or invisible disease that still remains. That said, there is compelling evidence that highly selected patients can benefit significantly from a surgery-based approach, not just from surgery, but from a surgery-based approach. And when you do surgery, you have to combine it with other treatments. And I will typically always combine it with the standard of care treatment, whether that's immunotherapy, chemotherapy, or both. And then we'll even do an intraoperative treatment. So once the cancer is out, we'll do an intraoperative treatment to try and kill the residual or microscopic disease that you know is still there. But you have to combine surgery with the other treatments. Highly selected patients is still a little bit more art than science, because who those patients are is not dictated. Most cancers, almost all cancers, are treated by what's called the staging system. And so, for instance, with this lung cancer, this would be a stage 1 lung cancer. We know black and white from hundreds of thousands of patients that surgery is the gold standard best treatment for that, because depending on the size and so forth, we could tell you there's a 70 or 80 or even 90% chance of cure rate. We don't have a staging system currently with mesotheliomas that predictive. And one of the reasons is, like I was saying before, the subtype is so important. And for instance, the epithelioid subtype is the type that is most responsive to a surgery-based approach. That subtype is not currently in the staging system. We're revising the staging system, and I hope we get this into it. But picking out the patients who are going to be most appropriate for surgery is still a bit of an art form. There are two ways. Again, the goal is to remove all of the detectable disease. And there's two ways you can do it. You can either take the lung out or you can spare the lung. So in this cartoon over here, you can see the mesothelioma coating all those surfaces. Here it is along the diaphragm. Here it is around the sac, around the heart. It's coating all the main blood vessels going in and out of the heart. It goes along the chest wall. You can see this cartoon shows it going between the lobes of the lung. And with this operation called an extrapleural pneumonectomy, you take all that stuff out, and most people take out the pericardium and the diaphragm, and then you have to reconstruct those with prosthetic patches. The other option is to do a lung sparing operation, where you take out all the detectable disease, but you spare the lung. I will say, you know, this is still an area of controversy. We were in the scientific session, and one of the other surgeons got on and says that he still does this sometimes. Close to 2 decades now, certainly at least 15 years. I still do this operation, but not for mesothelioma. For mesothelioma, I will always do a lung sparing operation. That's for a number of reasons I'd be happy to discuss during the questions if you want. So I tell my patients there's 3 things that I will need to know, that I'll need to be convinced of before offering surgery as a treatment. First and foremost, it has to make sense from a safety perspective. The patient has to be fit for a really big operation. If this, basically, I would consider this a colossal operation, and the patient has to be in good enough shape to tolerate that safely. So safety trumps everything else by a million miles. That's number 1. Number 2, it has to make sense from a cancer perspective. And that comes down to the disease, as best as we can humanly tell, is confined to the one chest cavity. And then again, ideally, it's going to be the epithelioid subtype. And then the bulk of the disease, whether or not lymph nodes are involved, these are all things that come into play. And again, it's still a bit of an art form, but those are the things that you need to sort out for it to make sense from a cancer perspective. And then the last thing is that I need to be convinced that the patient understands that this is not the standard of care. There is no definitive, what we call level 1 evidence that surgery is beneficial for this disease. If you go, there's different roles for surgery in the field of medicine, right? If you go to the emergency room and you have appendicitis, it's going to be a pretty short conversation. It's going to be, you can die of appendicitis or you can have surgery, because surgery is the only treatment. If you come in with that lung cancer I showed you, I could look you in the eye and tell you, well, we know black and white, if it's a safe option, surgery is your best option. For mesothelioma, we don't have either of those situations. It's still considered technically investigational, but there are patients who who do significantly better than you would anticipate without surgery. It's hard to imagine that some of the patients I have would have done as well with just the systemic therapy. But if you understand all that and you still want to do surgery, then sure, yeah, it's the right thing to do. So who has this operation? Well, this is who has this operation. This is the most famous. I've gotten away from it. My wife talked me up. I used to ride a motorcycle. This is the most famous picture, motorcycling. This is Raleigh Free, and he's on the Bonneville Salt Flats out in Utah. This is a dried up lake bed, and what they do is they draw this line here. It's 3 miles long, and this is where a lot of the world land speed records are set. And so this guy, Raleigh Free, and the way they do it is you get a 3-mile run, they clock you, then you turn around and you get one more try. You go back the other way. So this is a Vincent motorcycle, 150cc division. It's a little after World War II, I think. And he went out, he was wearing all of his leathers, all of his protective gear. And this is the way he would ride for wind resistance. That's a technique that he used. And he went out, and I think the world record at the time was a little over 150 miles an hour, and he missed it by like 2 miles an hour. And understanding that weight would slow him down, in order to achieve his goal, he took off all of his leathers. I don't know why he kept his helmet on and his sneakers, because he would have looked like a piece of hamburger if he crashed. But just in a Speedo and a helmet, he turned around, and sure enough, he set the world speed record. And that's kind of, the thing that moves me more than anything is courage. That's the human thing. And the patients who end up having this operation are just really courageous, because at least with me, they've heard all those things. And they say, this is something I still want to do. I'm willing to incur risk in an effort to achieve the goal of trying to live longer than I would anticipate without doing that. And where should it be done? Who should be doing it? Well, this is the team that you want, and it has to be a team. If you just got one person directing this, you're probably in the wrong place. You want to be in a place where mesothelioma is treated by a team of folks. And because again, surgery alone is not the correct modality for this. It has to be combined with other treatments, and you want all these folks involved. And also you want someone who's done a bunch of these, or at least is experienced with this, because this is, I've done pretty much all the operations in thoracic surgery, and I would say this is still the most challenging one. These operations rarely take me less than 6 hours, and they've taken me up to 14 hours. It takes about half as long to take the lung out as to spare it, but I think it's worth it. And frankly, our results have been better sparing the lung. So you really want someone who's experienced with this if you're going to have this done. So in summary, surgery has an accepted role in the diagnosis of mesothelioma. It can be useful for palliation, and especially if you have an effusion, it's been tapped, and you're going to need a tube placed. That is an ideal time. That's something that can be done through a 1/2-inch incision. You can go in, drain all the fluid out, get the biopsies, send them to pathology while the patient's asleep, make sure you have what you need to make a definitive diagnosis, and you can put a tube in a perfect position for the patient. And then surgery is not the standard care treatment for mesothelioma, but it certainly appears beneficial in some highly selected patients. And then the last thing I'd say is patients who undergo therapeutic surgery, they must have it done as part of a multimodal plan. There's got to be other treatments included with the surgery, and you want an experienced surgeon who's working with a team. So I'd just like to briefly say some thank yous. I'd like a special thank you to Melissa Culligan. She's the co-director with me of the Fox Chase Cancer Center and Temple Mesothelioma program, which we should be starting. We just started a couple of months ago. We should have that up and running in about a month or two, but we started the Penn Mesothelioma program, the one in Maryland together. We've been working together, God bless her, for about 20 years. And then there's literally dozens, if not hundreds of people who over the past 25 years have been helping me with the research and treatment of these patients. So, too many to put on a slide, but thank you to all of them. And then a special thanks to my cat, Kevin, who helped me put this talk together here. I was actually writing a grant, but he was a big help, as you can imagine. So these are, if you have any questions, you don't want to ask them, this is my email. Feel free to email me. I'm happy to answer any questions and help anyone in any way. So with that, I'd like to conclude. And if anyone has any questions, I can leave this up if people want to write that down, or you can pass it out, or I can stop sharing screen, whatever you want at this point.
Yeah, you can just leave this up. Let's see if anybody has any questions. Any questions in the room? No questions. Okay, there is a question.
Okie doke.
Earlier in your talk, Dr. Friedberg, you talked a little bit about sparing the lung as opposed to can you tell us a little bit about the benefits that you're talking about and why you won't take the lung anymore?
I don't think he could hear you.
So was the question, why did I switch to lung sparing?
Yes, that was the question.
So, yeah, here's the lung side. This is an extrapleural pneumonectomy, and that's when I did my training 25 years ago. That's the operation that we did. The lung sparing is something, frankly, the way I do it, I came up with on my own. The reason I did it was that, so this disease is primarily caused by asbestos, right? And I think the average is something like 30 years after exposure. So as most, if not all of you know, this is most commonly a disease in the geriatric population. Until recently, I was still seeing patients who were exposed in the military, World War II. So this is a cancer in older folks, and there is a tremendous difference in quality of life between having a lung and not having a lung. We're all born with basically enough reserve to live on one lung, but as you get older, all of your organs kind of, they get older with you. And so you have much less reserve. And so your ability to dance, to go on walks, to play golf, to do the things that you enjoy doing, go way down if you have one lung. It's just harder. Your breathing is just much harder. And even in a young person, I tell them, operate on a 30-year-old with a lung cancer, where the right thing to do is to take the lung out. And I'll tell them, you'll always notice this at this point. You could take out one part of the lung, one of the lobes, and you can pretty much get back to where you were. But if you take out a whole lung, it's a significant compromise in quality of life. So it was initially for quality of life that I started doing the same. And what I did, and this is in the 90s, early 2000s, we published this. We took about 30 patients, half of them, when I switched over, we compared the last, I think, 14 to the first 14, where I switched from lung sacrificing to lung sparing surgery. And what we found surprisingly was not only did they have a better quality of life, but they were actually living longer. Well, why is that? So the overwhelming likelihood is that you're going to have a recurrence of this cancer. It's a tough cancer, as everyone knows, and it's likely to recur after even the most aggressive operations. And your ability to tolerate those additional treatments that are going to extend your life and give you, frankly, a better quality of life are going to be better if you have two lungs. I think that's part of it. The other thing is that some of the treatments that we were doing, we think were probably inciting an immune response. We know that there's microscopic disease still remaining, And if you're doing something in the chest cavity at the time of surgery that's going to incite immune response, well, the lung is a very immunologic organ. If you think about it, you're breathing in dust and particles all the time. There's a lot of lymph nodes, which are part of the immune system inside the lung. And it was our hypothesis, we haven't proven this yet, but basically, if you're doing things to kill cancer cells, you're leaving them in the chest cavity, and the lung is there to process that information. We think that there may actually be a beneficial effect of the lung being able to help with the immune response to the cancer by virtue of still being there. So for quality of life, for the ability to tolerate additional treatments if there's a recurrence, and then potentially just for the body's ability to fight the cancer after surgery, all those things seem to be related to having the lung as beneficial compared to not having a lung. Like I said, the operation is more challenging for me to spare the lung, but that's why I've been committed to this, and it seems to have worked out. And I would just tell you internationally, the trend is to spare the lung. Not many places are doing that much in the way of lung sacrificing surgery, the extrapleural pneumonectomies anymore.
Any other questions from the room? All right. Thank you very much, Dr. Friedberg.
Oh, my pleasure. Have a good day, everyone.
I will multitask now because I'm just going to load up a couple of presentations, but our next presenters are Dr. Cara Haymaker and Dr. Muaiad Kittaneh. So I would like to invite you both to come up here and give me 1 second to load up your talks. Who's going first? Are you going first? Yes, he's going to go first, and he can lead it. It's good to meet you. He's going to provide a lovely lead in tonight. Okay. I'll try. This is your clicker. Thank you so much.
Ready? This is how I look. Yes, I can look at this. And this, you advance the slides like this. Good morning. Can you hear me? I feel like I'm speaking to myself. Good morning, everyone. Thank you all for coming here today. I want to start by thanking the Mesothelioma Applied Research Foundation for inviting me to give this talk here. This is almost my third time talking about the exact same subject. And I want to give a shout to my niece. Where did she go? She's a biology student. She's a biology student at the University of Chicago and wants to go into medical school, and trying to recruit her to the mesothelioma research. So thank you for coming. Anyways, my topic here today is about mesothelioma and genetics. I will try not to overwhelm you. By the end of the presentation, you will have my email and my cell phone number, and you can reach me on all sorts of social media for any questions. Of course, we do not use patient privacy and information on social media, but if you need to connect with me, please do. I am employed by ICON Clinical Research. ICON is a contract research organization, so what we do is manage clinical trials on behalf of pharmaceutical companies. I have no actual or potential conflict of interest in relation to this educational activity. I will discuss non-FDA approved medications in the context of clinical trials and what has been done in the field. My objectives today is to try to help you understand the medical use of genetic information. We as physicians and researchers, how we use this medical information. Understand the difference between somatic and germline mutations, something you may have heard during the course of this presentation or other ways of TV or social media or educational activities. And then the third thing, understand the implications of detecting a somatic or a germline mutation in cancer patients in general and how that applies to the mesothelioma patients. And then review the biomarker and targeted therapies in mesothelioma. So we as physicians or people in the medical community, how do we use the genetic information in the medical settings? The first thing is try to predict the disease risk based on individual genetic variations. What does it mean for somebody to carry a BRCA mutation or a BAP1 mutation? So trying to understand this risk on the basis of this mutation is important. The second thing, in trying to understand the interaction between this mutation and the environment. What does it mean for somebody who has BAP1 to get exposed to asbestos, for example? What is the mechanism of the disease? Is it different in patients who have, what we call sporadic mesothelioma with no risk factors, or somebody who has BAP1 mesothelioma? And there has been suggested differences. For example, in patients who have BAP1, we think that the prognosis or the outcome of these patients and the progression of the disease is slower in these patients in comparison to the others. Potential development of gene-based therapy, and that is the future of hopefully treating a lot of the genetic diseases. And the third thing is use of genetic information to guide biomarker selection for treatment, biomarker selection to predicting treatment outcome. There's something in medicine called pharmacogenetics that can help us understand how does the drug target the specific mutation or the specific alteration or the specific pathway, and also how do these drugs in terms of side effects behave in the human body, how are they metabolized. So that's the whole idea of understanding the pharmacogenomics and genetics of these drugs and mutations. So the first thing I think is start to go simple by understanding what is a mutation. A mutation is an alteration in the DNA that results in a protein that the protein is malfunctional. It doesn't do the job that it was designed to do. And then when we break this down into somatic versus germline mutations, it means on the left side, as an example, that the somatic mutation is something that develops specific in this cancer cell, and it is not something that you inherit from your parents. While on the other side of this slide, you see what does heritable mutation mean? It means it's a mutation that was in the sperm or the ovum and that was transmitted to the child, and it was transmitted to all the cells. Excuse me, the reason it's important to mention this here, because sometimes you may look at the pathology report of the mesothelioma patient and it reads, BAP1 testing was done and it's positive, or BAP1 testing was done and it's negative. I just want you to understand, if you read this, it does not necessarily mean that you have a germline mutation or a somatic mutation. It is just an indication of the protein presence or not presence in that specific pathology specimen, and whether you should be worried or you should be tested for germline mutation or not. That's something you need to discuss with your doctor. The most common genetic alterations that we have observed in mesothelioma include the BAP1, but there are other ones. There are the NF2 mutation, for example, which stands neurofibromatosis gene. There is, the CDKN2 or cyclin-dependent kinase 2, which affects two proteins called P16 and P14. These are the most common, but there are other ones. What does it mean to carry a BAP1 germline mutation? The first thing is that this has been associated with different types of cancer. Mesothelioma is one of them. It's probably the most common one of them. But there are other tumors that have been found to be associated with BAP1, including uveal melanoma, or they call it retinal melanoma, or eye melanoma is the same term. There's also cutaneous melanoma, skin melanoma, and the fourth or most important one is renal cell carcinoma, or the other easier term to use is kidney cancer. And there are others that the association is not 100% clear, and the field is still evolving to understand, how this interacts with the, with the phenotype, or what tumors the patients develop. These are the established relationships. And also there is another more challenging, topic is what do these mutations mean when they happen in the context of another mutation, because some person can have not only BAP1 plus something else. So what does that interaction mean for each individual patient? So who are the patients that we should suspect that they may have a BAP1 germline mutation? First of all, if you have a patient who is young, less than 55 years of age, those patients tend to likely have a germline mutation. If there is a woman with peritoneal mesothelioma, that's another thing to make you suspect that there may be a BAP1 mutation. Patients with relatives with mesothelioma or eye melanoma, what we said, the uveal melanoma, or kidney cancer, possibly can have a BAP1 mutation, or patients with a strong family history of any type of cancer. They're probably worth thinking along the line that this could be a BAP1 related disease, especially that we said earlier we don't understand all the diseases that can be encompassed under this BAP1 mutation. And of course, less frequently, other germline mutations can cause mesothelioma, like the big circles we put about the NF1, neurofibromatosis, and cyclin-dependent kinase 2. Now, what do we do with these mutations? I mean, are they actionable? That's the most important thing. Okay, you tested me, or you tested the tumor sample, you found a mutation, that is BAP1, what do I do with it? And this has been a subject of investigation, and we'll talk about this later. There are a lot of ongoing clinical trials, as well as, like, if you remember earlier, Dr. Hassan talked about the clinical trials that they have at the National Cancer Institute. And there are clinical trials that already concluded in terms of, what do we do with the BAP1 and how to treat these patients. Unfortunately, I'd have to say the clinical trials so far, and I think somebody asked a question here of how many clinical trials proceed to phase 3, and the answer was like 20%. And that's one of the reasons. You do a phase 1, you get the safety, you do a phase 2, and then you get a surprising result that means the study is not warrant moving further to a phase 3 clinical trial. So olaparib is an example of a BRCA, or a BRCA mutation inhibitor, used and approved in ovarian cancer, for example, used and approved in breast cancer, for example, and pancreatic cancer. And then we thought that may have some activity in BAP1 because of the interaction between BAP1 and another protein called BRCA protein. So it was tested. Dr. Hassan did the study, and unfortunately, especially for BAP1 germline mutation patients, it seems that for olaparib in particular, there are other classes or other drugs like olaparib in the same family that are still being tested, but at least for olaparib, the results were not encouraging. Another drug that has been tested, again, in phase 1 and moved to phase 2 is called tazemetostat, which is an EZH2 inhibitor. It has been approved in other diseases like lymphoma, but it has not proven to be effective in BAP1 mutated patients. What does this mean? At the end of the day, maybe the drug alone is not effective. Maybe other formulations of the drug, other ways of testing the drug, other combination may prove to be effective, or maybe a subset of patients may at the end of the day benefit from this therapy. But so far, the results are not encouraging either. There is another clinical trial at University of Leicester. I hope I said it correct. And then, this basically looking at multiple mutations or multiple targets in mesothelioma based on genetic alterations. Like in BAP1 or BRCA1 mutated patients, they're looking at another form of PAP inhibitor called rocaparib. Looking at patients with CDKN2, or what we said earlier, P16, INK4 mutations, to look at a drug called abemaciclib, which is a drug that targets a protein is called CDK4/6. And there is, of course, pembrolizumab, which is an immunotherapy combined with bimecitinib, in patients who did not have any mutations. And there is atezolizumab immunotherapy combined with bevacizumab, and that's what we talked about earlier, combination therapies, not me, my colleagues, of course, and what Dr. Haymaker will be talking about in terms of immunotherapy environment. This is a paper that we recently published earlier this year that talks about medical and surgical management of patients with BAP1 and their families. It took us about 2 years to publish this paper, but I suggest that you reference to this paper if you want to read further about the surgical management and medical management of BAP1 patients and their families. You have to remember that there are limitations or risk factors or things to consider when you want to do genetic testing. What is the benefit? What is the risk? What are the limitations? So the benefits, the first thing is that it may provide a more accurate cancer risk assessment, meaning you know the risk, you carry the gene, then you are at risk. You can personalize screening. Like Dr. Hassan said earlier, we can recommend certain recommendations because these patients are at a higher risk of developing kidney cancer, so you can try to screen them early to detect and cure those diseases. You facilitate decision making. What do you want to do? Lifestyle, smoking, asbestos exposure, early surgery or clinical trials to try understand the behavior of the disease. The risks. It is an emotional distress. It's not easy for somebody to tell them you carry a germline mutation that is still being investigated. We don't know much or a lot about what we need to do with these patients and what we do with it. The confidentiality concerns, like who's going to get this information? What am I going to do with it? Fear of genetic discrimination. Are you going to be discriminated against in terms of your health benefits? Are you going to be discriminated against in terms of your disability, life insurance? All of these are important things to consider. There is the Genetic Information Non-Discrimination Act. I'll talk about it briefly. Concern about your family and children. Guilt feeling. Did I pass this to my children? What do I do with it? Who should be tested? And it does not eliminate the cancer risk. Just knowing this, it does not eliminate your risk that you're going to get cancer. The limitations is that sometimes uninformative is negative, meaning if you test and you're negative, it doesn't mean you're not going to get mesothelioma. That's it. No, nobody knows. The second thing, there's sometimes variants, what we call of uncertain significance, which means you can find mutations in BAP1 or other forms of genes that we don't know what's the relation between these genes and the risk of mesothelioma. So what do I do with it, doc? I don't know. We just need to watch you. The positive results cannot predict cancer diagnosis. You have the results. When do I get this? Do I get it before 40, after 50? How do I plan my life? Testing minors is usually not recommended. This is what I said earlier, the Genetic Information Non-Discrimination Act. What you need to know is that, it protects you against discrimination from health insurance companies and employers. However, there are some limitations to that too, just like everything else in life. The employees of companies that are fewer than 15 employees, does not protect them. If you are a military or federal employee, it does not protect you. Specialized insurance companies like TRICARE, Indian Health Service, or life insurance. You can be denied life insurance on the basis of this information if they knew it. The second question is disability. The second thing, disability or long-term, care insurance. This is before I, of course, pass it over to Dr. Haymaker. Just shows, similar to the slide that was shown by Dr. Hassan about, the progress or the trials that have been done. In 2003, just a historical perspective, we used to only have cis and pemetrexed or cis alimta. Some of you know it in that name. Then in 2008, we started testing the alteration of neurofibromatosis too. Then mesothelin as a target came on the pathway of treating cancer. Then another marker called ASS. Then PD-L1 in 2016 became available to test in this context. Then we tested VEGF inhibitors like Avastin as a target. And then WT vaccine, which is Wilms tumor 1 vaccine pertinent to mesothelioma patients. Then in 2018, we started testing, BAP1, and what we said earlier, unfortunately, the results so far have been negative. Then we introduced other immune markers like, B7H3 and VESTA or CDK4 CDK4/6 inhibitors. And then until 2020, that's when immunotherapy combination became available using nivolumab and ipilimumab. Cisplatin and Alimta or cisplatin and pemetrexed remains available. And Right now, there are a lot of combination therapies that are being explored: immunotherapy plus chemotherapy, immunotherapy plus VEGF inhibitors, immunotherapy plus other targets, and the search continues for new therapies. Thank you.
And then we can do Q&A after.
Thank you so much. All right. Hi, everyone. Good morning still, just barely. I'd like to thank the organizers for the opportunity to present some of what we are doing to deconvolute the immune response in malignant pleural mesothelioma, and hopefully be able to answer any questions you guys might have as it relates to where we are going in terms of new therapeutic strategies based upon identifying actionable targets. So with the intent really being to look in a tumor and an individual's tumor and say, okay, that's a target that we know exists, and therefore that can guide therapeutic strategies. In terms of disclosures, I have nothing relevant to disclose pertaining to this talk, but I do receive funding for other studies from a few different pharmaceutical companies that are listed here. And also, I am on the scientific advisory board for the Mesothelioma Applied Research Foundation. So just as a brief outline of what I want to talk to you guys about today is really, does the immune system actually play a role in mesothelioma? Then how do we identify distinct immune signatures within the tumor microenvironment so we know what to target, right? And we're not just going in blind. And then how can we then use that information to really identify these targets, see if they are actionable or not, and then with the intent of reinvigorating the immune response to fight the tumor and help improve our patients. So this was an amazing seminal study that really demonstrated that, in fact, the immune system does play an active role in malignant pleural mesothelioma. This is the Lancet Oncology paper that compared nivolumab plus ipilimumab, so two immunotherapy combinations that are targeting two checkpoints that are found on T cells, versus chemotherapy. Now, what was amazing about this checkpoint 743 study is that it told us two major things, and I'm going to hopefully try to use. Okay. The first thing that it told us is that the immune system is playing an active role in mesothelioma. And we can see that because when we treat patients with this combination, we are able to improve their overall survival. And that is as compared to the chemotherapy alone group in red. Now, what was even more informative is a subgroup analysis based upon the type of tumor that these patients had. If it was an epithelioid malignant pleural mesothelioma, there was actually no benefit to this combination as compared to chemotherapy alone. However, if you had a non-epithelioid histology, so this could be a biphasic or a sarcomatoid, you saw a dramatic improvement, as you can see here in blue versus red, in terms of patient survival. Now, this told us another important point in terms of selection of patients and who should be treated with this combination, right? Because if you're going to have a non-epithelioid type of tumor, this is a great therapeutic option. If you have an epithelioid lesion, the search is still on in terms of improvement related to chemotherapy. Now, when we think about the immune system in a tumor, it is an amazingly complex microenvironment. There are numbers of different types of cells that can be present within every individual tumor. These can involve very good cytotoxic cells that are here to kill the tumor. These are called NK cells or CD8 positive T cells. And these cells are the cells that we are really trying to allow to kill the tumor and release brakes that the tumor is putting on those cells to shut them down. Because from the tumor perspective, it doesn't want to be killed, right? So it's going to throw up all of these barriers that are going to cause the immune system to not see it or to not effectively kill it. So that is the role that we have to understand, is what are those barriers that the tumor is actively using? And then that can allow us to know what can we block
to then allow those T cells or those immune cells to then be able to exert their function. Now, the way we are approaching this at MD Anderson is for every surgical case that we receive where a patient consents to allow us to use their tumor in this way, we are basically doing everything we can to deeply profile the immune system within that tumor. We are looking at how the cells interact with each other. Is a T cell trying to kill a tumor cell? We can actually see that. We can stain for those cells, and we can look at how close they are to each other and whether or not that T cell is really, giving it its best, but maybe the tumor cell is actually suppressing that. We are also able to understand what cells are even in the tumor. Do we have an immune response in this tumor? Not all patients have an active immune system response to a tumor. So that can tell us maybe there's ways we could try to promote that. Adoptive cell therapy strategies or giving cells that would actually be able to recognize a tumor. We can also, as was mentioned earlier, we can look at genetic components that can be good readouts for us to understand how that interplay occurs with the immune system. And then we can also even expand cells from tumors to then look at how they interact with the tumor itself. So that allows us to understand the immune function. Now, when we do this, I just want to show you guys kind of what the different ways this data comes out and what it looks like. When we look at tumor-associated tissue, so this is tissue that does not contain the tumor, but it's coming from the surgery at the same time, and then the tumor tissue itself. These are epithelioid patients, and what you can see here is that we have a lot of immune cells actually in the tumors from our patients with epithelioid malignant pleural mesothelioma. But you can see that's a wide variety. Each of these dots is an individual tumor. And so when we look at this, you can see some patients have a very, very, very high degree of immune infiltration, and some actually have what we call a cold tumor microenvironment, meaning that the immune system doesn't seem to see it yet. Now, when we look at those other types of cells that could be present, we can see very, very good T cells and very good cytotoxic cells. So again, these are the foot soldiers of the immune system that are really here to try to kill the tumor. And we can see that they are very present within these microenvironments. And then we have other types of cells that I'm going to just very, very briefly touch on that are called myeloid cells. These are the cells that actually will instruct the cytotoxic T cells to kill a tumor. And so these are very important targets for us to consider as well in terms of allowing the T cells and the cytotoxic cells to be able to kill the tumor itself. Now, when we look at other types of cells that could be in the microenvironment, we can see that there are also suppressive cells that are there. This is a cell type called a T regulatory cell. As you can imagine from the title being regulatory, it's actually there to suppress the good T cells that are trying to kill the tumor. And we can see that in some of these cases that we have a high frequency of these suppressive cells. So this kind of makes us think about different ways that we could shut these cells down to then not allow them to exert that regulatory function. On the good note, though, we do see that we also have a lot of actionable targets. As I mentioned before, there was exciting data related to the blockade of CTLA-4 and PD-1 in the CheckMate study, but those are not the only checkpoints that can be found on T cells. And we see that really clearly when we look at these cases here where you see a lot of PD-1. So this is the target for the nivolumab. We also see CTLA-4. This is the target for the ipilimumab. But there are other targets that we are still in the process of understanding if we can test if these are going to have good outcomes in our patients. LAG-3, for example. TIGIT is another one, and TIM-3. And so we actually have drugs that are allowing us to target all of these pathways that are in different stages of being tested to see if we can improve our patients' outcome and survival. And you can see that this is also true on on our cytotoxic T cells as well. So this would allow us to relieve those breaks and have a good outcome. Now, as I mentioned before, not only looking at phenotypes, we also want to understand who's actually talking to who in that microenvironment. This is really critical for us to understand if the immune system is engaged. Not just there because it's just passing by, but really engaged in trying to kill the tumor. And there's a physical interaction that we can assess using different types of pathology settings. This is called multiplex immunofluorescence, where we're staining for different cell types within fixed tissue, and we can look at how those cells interact with each other. So for example, when we look at, let me see if I can see here. When we look at, sorry, I've lost myself in this slide. Okay, when we look at our myeloid cells, you can see them here. We see that they are also interacting with tumor cells. They're right next to each other. And so that means those cells are actually talking to each other and giving each other feedback that could be important for us to understand how we might want to interrupt that and then allow a normal immune response to occur. We are also able to utilize other types of strategies like RNA sequencing. Using this type of strategy, at least in the patients that we have profiled so far in these tumor cases, we see two very clear colors, right? You see a red square and you see a blue square. These are epithelioid cases, and we find that we have two very specific, distinct buckets of immune responses that are found across these two different cases. And this allows us to understand then maybe patients that have this type of a expression pattern might benefit from one therapy versus patients that have this blue expression pattern might benefit from another therapy. So what we can see from our overall data that we're generating so far is that we have, again, these kind of two overarching immune buckets. We have some cases where we have a very, very, very active immune response with a lot of checkpoints and a lot of actionable targets that are very druggable. And so you can imagine that in this context, we can explore other types of ways to release that immune brake. And this can involve things like I mentioned earlier, such as TIM3 or TIGIT or LAG3. We can also target other axes that involve PD-1. We can actually target the ligand for PD-1 that can be found on the tumor cells and on the myeloid cells. And this could result in a good outcome. Now, for those cases that I mentioned that are the cold tumors or the blue tumors that I just showed, in that case, you know, it seems like there's not a very engaged immune system. So we need to really think about strategies to reinvigorate that. And that can involve scenarios where we're able to grow out cells that are able to recognize the tumor and then give them back to our patients, and thereby restoring that anti-tumor immune response through adoptive cell therapy strategies. And that way we're then able to push that system, right, and kind of restart that response. And so that's the way we're kind of thinking about this and how we're building this data to hopefully then have a really beneficial clinical outcome. So I just wanted to briefly thank everyone for their time and attention, and also the work that I just showed. It takes kind of a village to really delve deeply into understanding what is happening in this complex microenvironment, and then really think about what are we able to utilize to change our therapeutic strategies. We have a very active working group at MD Anderson that we call MIG. It's our Mesothelioma Immunogenomics group, and this is a multidisciplinary team that we are utilizing to really try to tackle some of these challenges that we face, and also being able to understand how we can apply these actionable targets that we identify into a clinical trial setting. And then, of course, all of the patients and their families without whom none of this could happen because of their generous contributions towards the research. So thank you all for your time and attention, and I'm sure my co-host and I would be happy to take any questions.
Thank you very much. We have time for one question, one very pressing question.
Okay. And you can also contact us if you.
Yes,
you can contact us with any other questions. Okay.
And if you come up with something down the line, email us. We can get you in touch with both of them. So thank you very much. I don't see any arms up, and I don't see anything on the live stream. So thank you.
Okay. Thank you. Thank you.
We have a couple of very dynamic speakers coming up. So we will be tackling radiation oncology. And so I'll multitask again. I'll bring you up here, Dr. Chuck Simone, and I'll bring up your presentation. Okay, and that's your clicker.
All right. Hi, everyone. Good morning, and I guess in 32 seconds, good afternoon. We're going to switch gears, talk about radiation. I'm going to partner with Keith Cengel, and I'll tackle part of radiation, and he'll do the rest. Disclosures, NIH funding, and varying medical systems. All right, so we recently, MARF actually was a leader along with the International Association for the Study of Lung Cancer and the NCI, developed a consensus on why we should use radiation, when we should use it, how effective it is for patients with mesothelioma. And we came up with kind of broad generalizations of why to use radiation. That's really going to be the focus of what we'll talk about today. First is for palliation to help symptoms. Second is after surgery. And we've just heard there are two main types of surgery. One is to take out the entire lung, an extrapleural pneumonectomy. After that type of surgery, we're generally giving radiation to all patients. And generally it's easy to do that. The lung's taken out, there's an empty cavity. We can essentially give radiation with immunity, not cause a lot of toxicity, but really help to sterilize any disease that could be left behind after surgery. Increasingly, though, we're doing lung-sparing surgeries, extended pleurectomy decortication. For those patients, we really need to assess how effective radiation is, and I'll spend more time during the talk about that. One group is looking at doing radiation in a big volume before surgery, I'll mention. And then we'll turn it over to Keith to talk about definitive radiation in people who are not surgical candidates, using radiation as salvage to essentially spot weld areas that have progressed or recurred after surgery, after chemo or immunotherapy, and to enhance the immune system for patients getting immunotherapy. All right, so first starting with palliation, there are several reasons you can use radiation. Many patients, as you know, present with pain or breathing challenges with pleural mesothelioma. The pain could be from invasion into the chest wall. They're very sensitive when you invade the ribs, the nerves, etc. Radiation is very effective at controlling that pain. Somewhere around 85 or 90% of patients, if we give radiation to an area that's causing pain, they have a pain response. The pain response could be dramatic, or it can be at least modest to get lower doses of narcotics or even off narcotics, but still needs to just be managed with Tylenol or something like that. About a third of patients, though, have a complete response from radiation, and the radiation's typically delivered in just 1 or up to about 10 days of treatment. So very, very quick to do, minimal to no side effects, which is nice, and typically we give a little bit higher dose per day specifically for mesothelioma to help symptoms. It also can be used, which you don't focus on here, but for breathing symptoms, if there's a bulky area of disease that's causing compromise of breathing, the radiation can help. Sometimes patients present with neurological problems from the tumor getting close to the spinal cord. Radiation can also help with that as well, and bleeding. All right, so moving to the combining radiation with surgery, one group in Toronto is really looking at doing radiation before surgery. Now, this is really specific to patients that have their entire lung taken out. And the reason is if we give radiation to a big area in a short amount of time, there can be some risk with that. Typically, radiation is given every day, Monday through Friday, for several weeks. This group has actually looked at just 5 days of radiation, essentially blasting the chest cavity to try to help make the surgery easier, more effective, and better outcomes after surgery. But as soon as they do that, they then take out the lung just a couple of days later. And the results are quite good. In people with early stage disease who they don't see have lymph nodes at the time of surgery, by giving radiation first, it looks like the outcomes are very, very good. Don't want to focus too much on numbers today, but this really kind of doubled or more what we would typically think of in a surgical population. So it's a very, very impressive result. Again, these patients are a little bit earlier stage, but a very nice number to see. More commonly, though, people are now getting lung-sparing surgeries, as Dr. Friedberg earlier mentioned. To do that, we can't just blast the radiation. There's too much risk that now the radiation itself can damage the lung. So we really need to come up with relatively complex ways to deliver radiation in people with an intact lung. We really want to, as Keith said when we worked together at Penn, you don't want to throw out the baby with the bathwater. We don't want to treat the entire lung. We want to treat the pleura and the lining of the lung. So how do we do that? Our team at MSK actually developed a technique that's now applied nationally where we can really spare the lung itself and certainly the normal healthy lung on the other side, but really focusing high doses of radiation to disease, particularly after surgery. So this is kind of a picture of what this looks like. It ends up being a big area, as you can imagine. The lining of the lung extends up above your collarbone and it extends down into the abdomen. You can feel below where your ribs are, you still have some lining of the lung. So we need to treat this whole area, but we can do it pretty safely now with more advanced technology. So this technique was born out at MSK and was conducted with a multi-center study, including MD Anderson, where we looked at giving radiation to the entire chest cavity. Of the patients that had this technique, 27 patients, only about 7% had an appreciable toxicity to the lung. So it's actually nice to see. Older versions of trying to treat an intact lung, that number would be many orders of magnitude higher. So it's really nice to see that we can do this. And in doing that, we can really mitigate or delay the time that the cancer takes to come back. How does that impact survival? Well, that's being tested in this trial. So this is a big trial. It's the first cooperative group trial in a surgical population, specifically looking at a radiation question. So we're excited about that. It's being run through Energy Oncology. And this is for all patients with either epithelioid or biphasic pleural mesothelioma who are surgical candidates. They would get a lung-sparing surgery with or without systemic therapy, a lung-sparing surgery and systemic therapy, and then they're randomized to receive or not receive radiation. Again, there are some risks with radiation as far as getting some inflammation of the lung that can lead to some breathing difficulties. So we really want to make sure that this type of treatment is improving survival before we do it routinely on all patients. So this trial is trying to answer a question and really see if radiation can double survival in patients who have already had surgery. All right, now this looks complicated. I don't want to go too much into a physics slide, but there is a new type of radiation. This will set the stage a little bit for some of the definitive radiation talks that Dr. Cengel will be talking about. Just if you kind of will humor me for a minute, if we want to treat a tumor with 100% of our radiation dose, this is the radiation dose, 100% here, and the tumor is deep in the chest, say at 20 centimeters, with traditional radiation, which is this line, we send the radiation in, it builds up, and we get our full dose a couple of centimeters into the skin, and then the radiation keeps going through and through the body. By the time it gets to the tumor, though, most of the radiation's actually been deposited in your normal lung and all your other organs, and that's why you can see side effects from radiation. Proton therapy is a newer type of radiation. It's been FDA approved for a little over 30 years, but there haven't been many centers until the last few years. Now there are about 40 centers in the country, including one here in Chicago. But what protons does, it allows you to have less radiation at the entrance. We send the radiation in. Because it's a heavy charged particle, we can tell it to give 100% of the radiation where we want, where the tumor is. And then we can actually have all the radiation completely stop. So now we get literally zero radiation beyond the tumor. So all the normal tissues beyond where we want to treat, the lining of the lung, are completely spared. What's beyond that, it's your heart, your esophagus, all these critical structures. So it's a safer way to deliver radiation for patients. This is a picture of what it looks like a patient we treated. You can see that they had a bulky kind of pleural area here sitting between the chest wall and the heart. This is the heart here. We're at the bottom of the chest, so you're starting to see a little sliver of the liver. To treat this, even with the most advanced types of radiation, we're really giving radiation to most of the chest cavity, but the whole heart gets treated. And you can see toxicity from that, as well as toxicity to the esophagus down here, trouble swallowing, or even breathing trouble from radiation to the lung. With proton therapy, you can conceptualize it. The radiation comes in, hits the area we want, and then it completely stops. So now a patient will never have trouble swallowing. They'll never have the same breathing or heart problems that you would have seen with traditional radiation. Why that's important for mesothelioma, I showed you the pictures that we need to treat a really large area in many patients, extending from the whole hemithorax essentially. In doing so high up, giving proton therapy, we send the radiation, we stop. Again, the heart is spared. The other lung gets literally zero radiation, and the other lung is actually a driver of toxicity. After having mesothelioma on one side and maybe having surgery and other treatments, the lung on your side that's affected is never perfect, but you really rely on the other lung. And so we really want to prevent any damage to that lung at all possible, and protons can do that. Lower down, where the lung keeps extending into the abdomen, we can really hollow out the area where protons is going and completely spare all your bowel, the liver, the kidney, unlike traditional radiation, where you see kind of radiation dose going everywhere in the abdomen. So you won't see the nausea and the other liver problems, et cetera. And we could even treat, which is really new to proton therapy, we can treat bulky tumors. We used to really only be able to treat with this technique in the post-op setting when there's very minimal to no disease left after surgery. But with proton therapy, because we're able to spare normal tissue, you can see how thick of a rind of disease this patient had, including disease in the fissure. And we're able to really just isolate the area we want to treat, completely spare the lung in between, completely avoid radiation to the heart and the other lung. So technology is really advanced over the last, really since 2016, where we're able to deliver what's called intensity modulated proton therapy to do this. So we had an experience at my former institution at the University of Maryland where we treated 16 patients, and just to focus on the bottom one, the patients really sailed through with very little toxicity despite being heavily treated. But just focusing on, I know these numbers are a little hard to conceptualize, but we generally say if we can keep the healthy lung to less than 7.5 gray, our unit of measurement, it's unlikely you'll get side effects. Even with the best of photon traditional radiation, we're barely under that number, 7 gray. With protons, we're essentially at 0.3 gray. So we really can completely eliminate the toxicities there. The heart's less and the liver's less as well. And then lastly, before I turn it over to Keith, just want to talk about another type of treatment in a radiation oncologist's armamentarium, and that's tumor treating fields. So these are electric fields that actually can disrupt cancer division. We know that all living cells, cancer and normal, contain ions, polar charges, etc. You can have those, and those charges we know can be influenced by electric fields. So tumor treating fields, which are low intensity, intermediate frequency, alternating electric fields, can actually be placed on the chest cavity and disrupt normal cells or cancer cells. The frequency is specifically picked to correlate with the size of a mesothelioma cell. So now the tumor cells are disrupted, but the normal cells are unaffected. And what that looks like, you essentially put a pad on and you put 2 on, so either front and back or side to side, and you have an electric current going through the chest. And this was tested in a phase 2 trial called the Stellar trial, where they looked at 80 patients with mesothelioma. Patients received standard of care chemotherapy with this device. And patients who wore the device, the survival seemed to be better than we've seen in standard chemotherapy trials. Now, this was done before immunotherapy. The numbers are even better, of course, now with immunotherapy. Of course, adding radiation and other things, we can have the numbers even better. But the nice thing to see is the survival was better than was really expected when this device was applied. And the really nice thing is that it didn't really add much in the way of toxicity. So, we think of systemic toxicities with chemotherapy. Despite this being systemically applied on the chest, we didn't see any added toxicity systemically. The only toxicity that was seen was actually some skin irritation. That was really from the adhesion of the device itself, the stickiness on the probes. And about 5% of patients had more than a nuisance. If you put a Band-Aid on and take it off, the skin's a little irritated. That's what had to happen for this device, and that's the same thing. There are a lot of ways to manage that, and so it's something that, as radiation oncologists, we can see skin effects and we can manage pretty well. So based on just an 80-patient trial, this device received FDA approval in 2019. So it's the first device in almost 2 decades to get FDA approval for mesothelioma. So it's a very good option for patients that are getting standard of care cytotoxic chemotherapy. So in summary, radiation is very good at palliating symptoms, especially pain. If patients are going to have a surgery where they take out the entire lung, they can be considered for radiation before the surgery in very select cases, especially if they're early stage and node negative. In patients that are having a lung sparing surgery, that extended pleurectomy decortication, we would generally use radiation after that. We know that it can help with preventing the cancer from coming back. Testing it on its impact on survival is currently being done in a large phase 3 trial, but we do think that there's a potential to significantly change the standard of care, and patients essentially uniformly, if they get that surgery, they should be getting radiation as well. Proton therapy is probably the best way to deliver that, or some of the radiation that you'll hear about in the next talk, because it can reduce side effects since we treat less normal tissues. And then tumor treating fields in patients that are getting standard chemotherapy can be a great addition without adding a lot of side effects for patients. So now you'll hear about definitive radiation, salvage radiation, and the effect of radiation on the immune system.
Thank you very much.
All right. So everything you always wanted to know, but were too afraid to ask in 7 minutes or less. Here are my disclosures. So there is an accurate self-portrait up at the top left of me doing radiation therapy. So I like to think about radiation in time and space, and so I sort of try to conceptualize what we're dealing with. We have a problem of space. We have a tumor that surrounds a lot of really important normal tissues as kind of a thin layer. And so we need to find ways to spatially fractionate the dose and then thinking about how do we adjust the time component. So traditionally, we've done this by giving a different amount of dose per day, what we call fractionation. And then I'll talk very much at the end a little bit about some of our dose rate modifications with flash radiation. So as Dr. Simone mentioned, you can see early on, we start with very simple sort of fields. You can come from multiple different directions. You can kind of do some shaping. You can see here, this is what a multi-leaf collimator actually looks like in action. So that's shaping the field from each side. And once we develop the ability to do that electronically in real time, we start to be able to do this, what we call intensity modulated radiotherapy. So the radiation therapy Dr. Simone was showing for the original imprint study is IMRT, which is pretty sophisticated stuff, except, and there's always a caveat on everything, you can see what ends up happening, which is to get that conformality in space, you're going to spread dose out. And so you smear dose out elsewhere. So it's not, and that's just the nature of the X-ray because it has exit dose. You can get really fancy with that, and for very small fields, this works extremely well. So a spinal metastasis, you can give very high dose, a lung metastasis, liver metastasis, things like that, you can do that. But again, if you look sort of back and forth, if you show just the 90% dose, it looks like this lovely little sort of spot, but when you kind of look at what it really does, it's actually spraying quite a bit of dose, which can have effects. So the idea of protons now in the modern era is we pencil beam scan. So you can see we're basically painting that volume layer by layer by layer by layer. Now, that looks, of course, extremely good. And if you were a block of wood made of perfectly homogeneous stuff that wasn't moving, that would always be better. And so to the extent that you don't resemble a block of wood, protons, we sort of are degraded in our ability to know where it stops. And that is what really causes us the trouble. So most important thing, if you get nothing else out of this, there is no best radiation. There's only where your tumor is, and sometimes you know, photons are great and sometimes protons are better. So how do we think about temporal fractionation? That's really the meat of this. So essentially cancer cells don't heal between treatments as well as normal cells. And so when we're treating very large areas, say, there we go. So we're treating the whole chest and like this imprint-like technology, we need to go slow and we need to give a little bit of radiation every day, 5 days a week, and let the normal tissue kind of keep up. When we're treating much smaller areas, we can go in a much bigger dose per fraction and get things done quite a bit quicker and potentially even with more efficacy. And you know, one of the things that's happening as we keep going in this field, as our ability to spatially fractionate the dose gets better, maybe we can start speeding things up. And we'll talk about that toward the very, very end. So you can see here, RT in the definitive setting. So this means treating people who have disease. You know, this is a patient where we're treating the entire pleura. And in this particular case, you know, you're boosting sites of gross disease, treating all the areas to a standard disease. This particular patient has one kidney on the side of the tumor. There is zero chance that I would do that with IMRT. And this is one of those magical moments where you go to your dosimetrist and you're like, can you get the dose really low? He's about, how about 0? And you're like, I'll take 0, that's fine. You know, this is that patient Dr. Simone showed with the anterior mediastinal mass. And again, you can see that ability to sculpt around the heart that really can totally change things. In the peritoneum, we sort of run into a lot more trouble. The peritoneum is a much more convoluted surface. The surface of the organs are much more difficult to treat. And surgery and reoperation play a much bigger role. So we had done some whole abdomen back in the old days, which is really pretty toxic, and we may be able to come back to that with flash. But mostly now what we do is we spot weld. So for example, a patient with peritoneal disease who had a recurrence up high that was eroding into the liver, progressing on immunotherapy, we're able to spot weld that pretty well. And that really sort of brings us into the topic of the oligometastatic paradigm, which is a big 50-cent word for treating sites that grow. So, you know, we don't need to treat every last cell. Maybe we could just treat little areas. This increasing ability to spatially conform the dose and do it in just a few treatments, so it's not terribly inconvenient for the patient, we can start spot welding. So, you know, this is our standard oligometastatic paradigm. don't see too many brain metastases in patients with mesothelioma, but you can do radiation all over the body and sort of think about this as almost a systemic approach. So for example, here's a patient that we treated many times over the years with either SBRT or proton radiation therapy. Actually had I think 5 separate courses of radiotherapy over the course of many years. This is pre-immunotherapy, and essentially kept this patient going and on to the next line of systemic therapy. The other sort of exciting thing, and we're not sure what to do with this, we've all seen this, it's almost a little bit of a rainbow unicorn. So you have patients on immunotherapy, they're cruising along, they might have one site of progression, or they might have multiple sites of progression, and you go ahead and you use one of these highly focal SBRT-like or proton modalities to treat one lesion, and you can see other lesions starting to shrink. So this is a patient we treated years ago with meso. She was actually progressing on immunotherapy all over, but had a painful metastasis. We treated that one, and you can see here an area outside the radiation field responding over time suddenly to the checkpoint inhibitor. Again, we've done some clinical trials trying to focus in on who's the best candidate, how to make this happen better and more on purpose, and we've struggled quite a bit, but certainly it's something that can happen when you add radiation therapy. And then, what's on the horizon? So I'm a huge Halo fan, obviously. So, I sort of split my on the horizon therapies to things that are ready for prime time. Here's Master Chief saying it's go time. And there's the wake me when you need me kind of things. Maybe we're playing with fire and we should be a little bit more careful. This flash radiation is more on that not ready for prime time, we're getting ready for it thing. So if you imagine standard dose rate, protons or photons or electrons being given, and the dose rate would be something the size of the solar system here on this. We can control the therapeutic index by modulating that space. We can modulate the fractionation, the time between doses, but we have this terrible paradox. The bigger the tumor, the lower the dose, and the longer the treatment course. So this crazy idea came up, which is with some fancy modifications to the proton beamline, we can up that dose rate about 10,000-fold. So now if you just do a relative size of the spot, it's something more like that size. And it turns out it seems to put an equal hurt on the tumor, but spare normal tissue. And we're really not sure at all why that works. It was not something predicted. It was sort of a serendipitous observation. So now with protons, we can do this spatial dose. We can do some fractionation potentially, but with flash, now we can treat very large areas potentially in a very small number of treatments, and we might be able to pump that dose up so a larger area would be able to be treated. So we're beginning to explore this. There's some technical limitations. So the initial beams that we've been working with for various technical reasons have to be very deeply penetrating. So we have to essentially, if you're a big Spinal Tap fan, we had to turn the cyclotron up to 11. And we're using a beam that is a 32 centimeter depth of penetration. So the initial patients we've treated are extremity tumors. At Penn, we've utilized the fact that I have a lot of veterinary collaborators, and so the veterinary oncologists across the street are happy to enroll dogs on our trials. We're able to bring them over to the human hospital and treat them. So I enrolled 32 dogs on a study of standard versus flash protons for dogs with osteosarcoma, which we're still analyzing the data, but it looks like they're equal in terms of tumor cure and probably less fibrosis signals, at least so far, that we're seeing. There's an initial trial at the University of Cincinnati in humans, looking at humans with extremity metastases, that it's a much lower dose, 8 gray in a single treatment, but it looks like at least it's feasible and it works about like you'd expect 8 gray to look. You don't see much toxicity with that. we're now just started a trial in dogs with head and neck. So the advantage of head and neck tumors in dogs is that you can see all the mucous membranes really well, and you can watch and analyze the toxicity, and you can look at the saliva and figure out all these different things about what's really happening on the ground. So we're treating dogs with head and neck, and in this case we're using 2 separate treatments and escalating that dose up to a very high dose. And they're about to begin in Cincinnati another bony metastasis trial, this time focusing on metastases over the sort of torso to sort of start seeing, again, a pretty low dose at just 8 gray times 1. But so we'll see where that goes. Very exciting, and it maybe gives potential. And what does that potential look like? So this is that patient with the anterior mediastinal tumor. So we treated him originally with double scattered protons. You can get a little better with more fancy pencil beam scanning protons. But this gentleman came from upstate New York, and he had to stay in Philadelphia for 7 weeks, which was kind of a drag. That same treatment, especially double scattered, was really slow. We're 45 minutes per treatment. He's laying on the table with his arms up like that. If you treat this same thing with flash protons, we're thinking potentially 3 fractions, 3 total treatments, Monday, Wednesday, Friday. Each beam on for that would be 20 milliseconds. So you'd still have, 3 minutes of aiming, but yeah, the beam on time goes from 45 minutes to 20 milliseconds. So pretty quick, and potentially equal efficacy with less side effects. And I think that is a potentially game changing if this goes forward. With that, I guess we can stop for questions. My daughter is 15 now. She hates that I show this slide, but I got to be me. So questions? I don't know if Dr. Simone wants to come on up too. Oh. I'm going to take that slide off before my daughter kills me.
This is kind of an academic question, but if people didn't get fatigued and resources and people's schedules weren't considered, would you do the radiation 7 days a week for 30 or 40 days?
So that's really interesting. So we did a lot with different fractionation regimens, mostly in head and neck, in the 80s and into the 90s. And one of the things we found was called the various well regimens, meaning weekendless. So you would 7 days a week, and it beat people up. Pretty, and in some of them, we really intensified treatment, and we actually saw significant, like, spinal cord toxicity. So it turns out probably that extra 2 days on the weekend really allows the normal tissues to recover fully. So I think it's, maybe thankfully for our profession and for patients that was the finding. But no, it's really interesting, and it's a sort of an important thing when we say once a day radiation. What we really mean is once a day with an every so often 2-day break, right? And that, I think it's really important.
Yeah, and it probably depends on tumor type too. So it's almost oncology lore that mesothelioma is radioresistant. That really comes from the fact that, as you saw, the big fields that we used to treat when the technology was very different and we couldn't adequately treat them. Now we have IMRT, we have protons. And what we see is actually mesothelioma is more radiosensitive than a lung cancer, for instance. And the only disease in the chest that we've seen potential benefit for doing weekendless treatment is a squamous cell, and those patients still had more toxicity. So we probably don't need to do it for mesothelioma, and it's easier on patients to get through.
Thank you very much. We're actually out of time. One more.
Sorry, just a quick question. Is there any research doing tumor treating fields in peritoneal or any consideration of that?
There's research in the body region. So there's a large ovarian trial being done, I believe a phase 3 trial that's pretty far along. So we'll have a good sense of the toxicity from it. We're not expecting much toxicity because it's been done in brain, it's been done in lung and mesothelioma. And we've only seen that skin toxicity, but we'll have an answer on at least the toxicity. As far as the efficacy, to my knowledge, I don't think there have been any studies done for peritoneal mesothelioma specifically. That's a great point, though. It's something that could be explored because, like Dr. Cengel said, we do have a tougher time with radiation, so that may be a nice way to treat those patients.
Thank you. And if anyone else has any other questions, I would encourage you to find Dr. Simone and Dr. Cengel during lunch and get those answers for you. Thank Thank you.
Thank you so much, Dr. Cengel and Dr. Simone for your presentation. And as per usual with the nonprofit world, we are running late. Kind of goes with the territory. We always serve hummus and we always are late. What? I've been doing this a long time. It is my privilege now to introduce our 2022 award winners. You gonna do the video first? Okay, fantastic. So I will, sorry, I saved it on my phone, and here we go. Fantastic. The first award that we are presenting today is called the Bruce Vento Hope Award. Bruce Vento was a 12-term congressman. Bruce was a tireless fighter for the environment, his beloved home state of Minnesota, and once he was diagnosed with mesothelioma, our community. I had the opportunity to speak to Bruce's widow, Sue Vento, who told me that he would be deeply honored to know that we still remember him and is humbled by the recognition that this award continues to be named after him. She went on to say that he would be delighted to know that we are still working together to bring hope and answers to everyone affected by this terrible disease. She also noted that during Bruce's all too brave but brief fight to beat meso, he relied on the wonderful care of mesothelioma professionals. To everyone who serves on the Community Advisory Board, you provide a unique and invaluable type of care as you mentor, advocate, listen, and care. We lose too many too soon to this terrible disease. We are inspired by all of you who show up every day to raise money for transformational research, who mentor newly diagnosed patients, and who hold up our bereaved during their hardest days. This year's Bruce Vento Hope Builder Award exemplifies the best of our community. From serving on the Community Advisory Board, volunteering as a mentor for recently bereaved community members, learning how to review research proposals, leading our annual community survey project, and co-leading our Symposium's bereaved programming. Maria Tao joined our community when her wife Chris was diagnosed with mesothelioma in 2017. After her death in 2019, Maria has devoted herself to modeling hope and service to others. I want to now introduce a previous award winner who has a message for Maria. And who couldn't be here because she's not traveling yet, but she's watching us virtually.
Hello, my name is Heather Bond St. James, and I am a 16-year mesothelioma survivor. I am also the 2021 recipient of the Bruce Vento Hope Builder Award. It is my honor to come to you today from my patio to introduce to you the 2022 recipient of the Bruce Vento Hope Builder Award, Maria Tao. Maria came to the foundation when her wife Chris was diagnosed with mesothelioma in 2017. Ever since then, and upon her wife's passing in 2019, Maria has lent her time and numerous talents to the foundation's work. Leaning on her background in public health, she was instrumental in the development, deployment, administration, and analysis of a large survey that was sent out to the foundation's community. Currently, Maria is a member of the organization's Community Advisory Board, which I am very proud to serve with her on, and she continues to contribute to the mission of the organization. Maria, it is my honor to give to you and present to you virtually the Bruce Vento Hope Builder Award. You've done so much for our community, and I'm so proud to know you. Thank you, and congratulations.
Thank you.
Let you go ahead, it's on.
Okay, maybe I can get through this. Thank you, Heather. I wish I could see your face right now. So thank you very much. I'm truly honored to receive this award. Over the past few years, I've done a lot of thinking about hope, and Brene Brown actually defines hope as a function of struggle, and that we develop hope not during the easy and comfortable times, but through adversity and discomfort, which I think actually really sums it up well for someone in my experience having to think about hope. I truly feel like I should be sharing this award with everyone in this room. because connecting with you all, everyone in this foundation, and I know Chris connected with many people Heather and Bill and other people, and hearing your stories and your struggles, your triumphs really gave Chris and me a lot of hope. And also not just hope that she could survive, but also the hope and inspiration on how to live life to its fullest, which I think she really strived to do every single day. And I really am still inspired by everyone in this room, here in this physical room, but also people in the virtual room, because I still get a lot of inspiration and hope from everyone here. And I think it's really important that we carry this hope, because we need this hope, and we have to believe to be able to continue to do the work we need to do to make change happen. So, thank you.
Congratulations.
Thank you.
Don't forget your pretty. You take this down. Maya's going to take this down, and I'm going to do this next one. Thank you so much. Today it is my honor to virtually present this year's Klaus Brosch Award, which recognizes an engaged and exemplary individual who invests time and talent to advance the Foundation's mission. This year's award recipient is Rich Mosca. Many of you know the Mosca family. It's Rich and Laura. They're a duo. They even share an email address. They are the backbone of the foundation. Rich was diagnosed with meso in 2008. He, along with his wife Laura, became instantly involved in the foundation's work, and he served on the board, and he's helped with numerous projects, and he served as a peer mentor for so many folks in our community. Several years ago, Rich became involved as a representative for the foundation to the Department of Defense's grant funding program called CDMRP. To our patient community, that doesn't necessarily mean all that much, but this is where there are big bucks to invest in research. And Rich not only represents us along with other meso patients from our community, but he also turned around and he wrote the protocol for our peer review for the foundation's grant. So he is our guiding light when it comes to the mesothelioma grant making process and working toward finding better treatments and a cure. Rich is also sort of the elder statesman and wise counsel who is always there to help me and give me support. I consider him part of my kitchen cabinet, and he has been more than generous. In addition to all of these things, Rich is also one of our advocacy warriors. We sort of take over virtual advocacy days these days. He and the rest of the New Jersey crew, they represent. But Rich is not able to be with us because he and his lovely wife are finally enjoying a vacation, a long postponed vacation, and they're in Yellowstone with no Wi-Fi or internet. So he recorded a little video for us.
Good afternoon, everyone. It is truly an honor that the staff and board of directors at the Meso Foundation, headed up by Julie Powers and Dr. Marjorie Zordera, have nominated me for the Klaus Brock Above and Beyond Award. Some of you may remember Klaus as one of the first patient volunteers at the foundation, so this award is appropriately named in his honor. 15 years ago, I was diagnosed with peritoneal mesothelioma. I've worn many hats for the foundation over those years, but in more recent years, I've settled in as a patient advocate, reviewing research grant proposals for the congressionally directed medical research program or for the foundation itself. Over that period of time, the foundation has funded close to $11 million in seed grant proposals. The results of some of those grants have gone on to receive additional funding to advance that research. Research was and still is the key to long-term survival. Looking at your morning topics today, I couldn't help but notice some of the key words that we used in describing those sessions. Multimodal therapies, immunotherapy, tumor microenvironment, genetics, checkpoint inhibitors. 15 years ago, these items were on the drawing board at best. But the breakthroughs in these new therapies is directly related to the research that is funded by the Foundation and other organizations. Are we there yet? Absolutely not. Are we going to get there? I believe so. Why do I believe that? Well, look at your speaker list today. Look at the members of the Science Advisory Board for this foundation. Every one of those doctors and researchers has dedicated their careers to finding better therapies and possibly cures. With that said, in honor of all of my meso brothers and sisters who have fought the valiant fight over the years, who are currently fighting that fight, I humbly accept the Klaus Brock Above and Beyond Award from the Meso Foundation. Thank you and enjoy your lunch.
We will be mailing that to Rich very soon. I'd like to invite Dr. Pikert to come forward and help me with this next presentation. I am actually going to turn the mic over, but this year's Pioneer Award recognizes individuals who are pioneering scientific advances in mesothelioma research and treatment. And so now Dr. Pikert, who is the head of our Science Advisory Board and acting also as a surrogate for Dr. Zotterer, who wasn't able to be with us today. Dr. Pikert.
Yes, thank you very much. First of all, it's an honor for me to be here, and it's also a great honor to actually present this very prestigious award to Dr. Hedy Kindler, who really exemplifies what this award is all about. It's pioneering in the space of mesothelioma, and she's actually dedicated her career for a very long time, over many years, to actually find new treatments and advance treatment options for patients with mesothelioma. She actually is a professor at the University of Chicago here, where she leads the multidisciplinary mesothelioma team. And in this capacity has actually led many clinical trials and has established herself as an excellent translational investigator. I think I counted over 100 publications that are related to mesothelioma alone. And most recently, she's actually advanced immunotherapy into the clinical practice for mesothelioma. She's been crucial to that. So with that, I really would like Hedy to come up here and present this award to you. You really are a pioneer of mesothelioma.
So I am genuinely humbled to receive this award, knowing all of those who have come before, Valerie Rouge, David Sugarbaker, my mentor, Nick Vogelsang, and also getting an award called a Pioneer Award makes me feel terribly old. But I could not have done this without my amazing team at the University of Chicago, some of whom are here today, Berkeley Opelecki, Girta Paroga, Monica Malec, Kieran Traga, and many more who are back home at the university. And of course, to all of the patients who I have enjoyed taking care of over the years. It's really been a wonderful partnership. I remember my very first Mesothelioma Foundation meeting. It was in Chicago. We had a party at the Contemporary Art Museum. I remember my very first grant that I received from the Mesothelioma Foundation that helped launch some of our early work in VEGF inhibitors. And so I'm very grateful to the foundation for helping get me started and keeping me going and keeping our patients going. So thank you very much. Again, I'm very humbled by this.
Thank you, Dr. Kindler. Okay, friends, I know everyone wants to go to lunch, but I'm going to take a personal moment of privilege as the executive director and leader of this motley crew. I have some thank yous to make today before we go and eat. I promise, fast, 2 minutes tops. Maya's over here timing me. First and foremost, I want to say a personal thank you to Jessica Blackford-Clayton, who was instrumental in helping us find venues for this event. She's a member of our board, a former member of our community advisory board, a patient, survivor, and warrior, mother of the two cutest little boys I have ever seen, and who personally drove around to make sure everything would work for everyone. She didn't explain to me the lower and upper thing, but we got here anyway. So I want to say thank you to Jessica, and I have a little thank you gift for you. Thank you, Jessica. Thank you. Okay, next up, I want to say thank you to Berkeley Opaleki. Berkeley is a nurse and is a member of our board of directors. Berkeley has been a guiding light for us. She's been an amazing mentor and supporter to our patient services director, Shannon, as she's gotten her feet underneath her. She's been a wonderful supporter to us. She's been an amazing resource for the conference, and I want to say thanks to Berkeley for helping us make this conference happen. So thank you, Berkeley. Next up, I want to say thank you to Dr. Amy Siston, who's out in the hallway hiding. Dr. Siston jumped in and she helped out, and she's leading our bereaved community today in a really facilitated and kind and uplifting way. Bringing hope and support and comfort to folks as they're navigating bereavement. And I want to say thank you so much to Dr. Siston for being with us. We have a little gift for you if you want to come up. And thank you, Dr. Siston. Standing right behind her is none other than a patient, survivor, warrior, none other than Katie Jameson, who works for us part-time and flew in to help us make the conference happen. So I want to say thank you so much to Katie for being with us. We got a little present for you. I told him he couldn't go sit down yet, so I want to say thank you also to Dr. Pikert for stepping up, stepping in, leaning in, whatever we say these days. I want to say thank you to Dr. Pikert for being the man on the ground and helping facilitate this entire conference, in particular leading the scientific meeting today. He's an amazing leader on the scientific advisory board. He wrangles all of the research grant process, helps us manage all of those grantees, and has been a wonderful thought partner and supporter. And he explains the multisyllabic words to me in 2 syllables. So I've been able to learn an awful lot about mesothelioma thanks to his support. So thank you, Dr. Pikert. And I don't know if Dr. Sterman may have already taken off. He had to catch a flight, and so the last person I want to give a thank you to is Keith Cengel. For as much of a hard time as I give Keith, he has stepped up and helped me out a lot with our conference. Keith jumped in to help facilitate a panel in person, and he has been absolutely a rock star, helping me understand this space, and we appreciate him so very much. So thank you, Keith. And with that, friends, it is time to eat lunch. We've got about 45 minutes, so eat fast. You are welcome to sit wherever you want. This room is open. The lunchroom's open. The scientific meeting room is available. The bereaved room is open, and you, of course, can go outside. And what do you need if you want to go outside? Your QR code. Thank you so much. Everybody, enjoy your lunch.
sessions. So the next one coming up is our ins and outs of asbestos litigation for patients and their families. And the first person I will bring up is our board member, Cheryl Bruner. She will be the moderator for this session, and she will make the further introduction.
Thank you, Maya. I'm glad to be here with all of you. I'll tell you briefly my story and my background. I am an attorney, but I don't practice mesothelioma litigation. I actually do estate planning and elder law in Kentucky. I'm also a bereaved. My mother was diagnosed with mesothelioma in 2014 and received treatment around the country at some of these great centers where you've met some of these healthcare providers here. And she passed away in 2016. And one of the fantastic things about being here and hearing all of this information and meeting all of you is to see how much progress has been made since 2016 in this space and will continue to be made. My mother was adamant that I volunteer or stay affiliated in some way with the Mesothelioma Foundation, and it has been my honor to do that in these years. So I'm delighted to meet all of you all and be here as well. So this topic about litigating your mesothelioma claims for patients and for families is a big one. And we at the foundation, we don't internally have the expertise on this topic, but we want to make sure and address this topic for patients and families and get you information about it. So that's why we're having this here today. So our first speaker, Dawn Besserman, is with the MRHFM law firm, and their firm has a large practice in asbestos litigation. Their firm has about 10 offices in a number of states with over 60 lawyers who practice in this area. Dawn decided to move south for sunnier weather and continue her law practice. So I enjoyed getting to know her and talking about that some. So Dawn is going to speak to you first and go through some slides. And after she finishes, I'll come back up and introduce you to the other members of the panel. And we'll go into the Q&A session at that time. So Dawn, thank you for being here.
Hi, good afternoon, everyone. As Cheryl said, my name is Dawn Besserman. I'm a partner at the law firm MRHFM. We are a litigation firm that specializes only in handling mesothelioma claims on behalf of mesothelioma patients and their family. I'm going to be talking to all of you today about a simple overview of the legal process. And like Cheryl said, when I get finished giving you all an overview of the legal process, my partner Neil and another attorney from the Gori law firm will be joining me to answer any questions that folks may have. So to get started, the first thing that patients always want to know when they reach out to us and have questions about the legal process is, what is the type of compensation that's available for me and my family? What are the sources of compensation and funds that are available to help victims and their families deal with medical bills and just to seek compensation for their losses, their damages, what they're going through in terms of their pain and suffering, lost wages if the victim is still working. The spouse also has what's called a loss of consortium claim. The law recognizes that spouses of injured parties suffer their own sort of damages, and the law provides that the spouses also have a right to recover when a spouse is injured. So there are really three different types of compensation that is available for victims and their families. And the first one is the one that most people think of when they think of mesothelioma claims, because it's often what we see on television commercials, and that is the trust funds that have been established for mesothelioma victims and their families. The second type of compensation that is available are what are called solvent claims, and these are claims that can be filed in civil court. So we refer to them either as solvent claims or civil claims, but these are claims that are filed at a civil courthouse against various companies and defendants. The third type of compensation that's commonly available to mesothelioma victims and their families is VA benefits for persons who were exposed to asbestos during the course of their military service. So I'm going to go through each type just generally and give you a little bit more information about the three different types of compensation. With respect to the trust claims, the trust claims are essentially trusts that have been established through the bankruptcy court system. When a company that has manufactured products that contained asbestos begins to face liability in the civil courts, and cases historically have been filed against a number of companies repeatedly because they had so many products on the market or their products were so prevalent, there are just hundreds of cases that are filed against these companies. Eventually, there are so many cases against particular companies that they become bankrupt. And what that means is that their liabilities exceed their assets. So these companies have gone to bankruptcy courts and petitioned for relief. And what that relief is they are no longer allowed to be sued in civil court. But in exchange for that, they have to put aside assets in a trust fund. So funds are set aside in a trust fund. Those funds are managed by an independent trustee, not the company. The company no longer has access to those funds. And those funds are managed for the benefit of mesothelioma victims and their families going forward. The trusts are established and set up and managed so as to hopefully compensate all of the projected victims who were exposed to that company's products. Trust claims are administrative claims. They're not associated with a court or a lawsuit. There is no court appearance required to pursue trust claims. Generally, the evidence that is used to support trust claims are affidavits, which are essentially sworn statements by either the victim who can discuss particular asbestos-containing products that they worked with throughout their lifetime. Sometimes when the victim himself or herself doesn't know those products, you can get evidence and affidavits supported by coworkers or family members who have that information. And there are some trusts that have been established where you don't even have to know the name of the product. You may qualify for a claim based solely on the fact that you worked at a facility or a site where their product is known to have been so prevalent that the trust recognizes if you worked there, you were likely exposed to that product. There have been over 40 national trust funds that have been established, and there are always more trusts that are being established. Right now, there are several companies that have filed for bankruptcy protection, and those bankruptcies are working their way through the bankruptcy court system. So there will likely be additional trusts that are established in the future as well. The second type of claims, like I mentioned, those are the solvent claims that are filed in civil courts. These claims are claims against companies that haven't sought bankruptcy protection and that are still in existence and can be sued as a corporation in our civil court system. These claims can be substantially more valuable than the trust claims. The solvent claims are typically more valuable because there is a lot more risk involved for the defendants. when you file a claim in civil court, there is ultimately the potential that you're going to have a civil jury sit and hear the evidence and make a decision. And if they decide in favor of the mesothelioma victim and their family, generally the damages that are going to be awarded can be substantial. And that is what causes the companies to value those claims more and potentially pay more. So it's a very different system in the civil court system as opposed to the trust claim system. In the trust claim system, there is not that threat of a civil jury. The claims are managed by a trustee, and the amounts are determined by the trust. The amounts that are paid out are not something that is generally negotiated, as is the case with solvent claims. Solvent cases are much more time intensive for the lawyers, and to a lesser degree for the mesothelioma victim. And these claims have to be proven by either deposition testimony or documentary evidence. So there's a lot more work that is involved in preparing those cases for trial. Generally, these types of cases also involve the hiring of experts and depositions of multiple witnesses, not just the victim, but often coworkers, family members, like I said, experts and other potential witnesses. The third type of recovery that may be available to patients and their families are VA disability benefits. These benefits are, again, available only for people who served in the military and were exposed to asbestos during the course of their military service. Disability benefits for mesothelioma get a rating of 100% disability through the VA. And those benefits, if they are granted, continue for the life of the mesothelioma victim. So once those benefits kick in, that is a monthly benefit that continues until the victim passes away. The evidence needed to support a claim with the VA can be either through deposition testimony that's taken during the civil case, and or affidavits from either the patient or from coworkers in the military who have evidence about the exposures that the person had. Current VA disability benefits are over $3,000 per month for a single veteran, over $3,500 a month for a married veteran. And then if the veteran passes away, the spouse will continue to get a benefit in the amount of currently over $1,400 per month, and that continues until either the spouse remarries or passes away. So the most common question that we get when we explain to patients these different types of compensation that are available is, well, how do I know which claims I qualify for? And what if I don't know how it was that I was exposed to asbestos? And that's where your law firm really comes into play in terms of developing the evidence and doing the investigation. Everyone's case is different, and every case requires a serious investigation. And the investigation is going to involve taking a complete history of the patient from birth all the way through, present day. So we try to uncover every potential source of exposure that someone had throughout their lifetime. And of course, that can be quite an undertaking, but we have tools that will allow us to piece together that information and make a determination as to where we think your case will fall within those three types of compensation that are available. Some patients will be able to have trust claims, solvent claims, and a disability claim. So they're not mutually exclusive. Some people have all three. Some people may have just solvent claims. They don't qualify for any of the bankruptcy claims for various reasons. Maybe that is a very young patient who isn't going to qualify for the trust because their exposures happened so recent in time that there is no trust fund available for them. and they may only be able to file a solvent claim. They may not have served in the military. Now, some folks will have, like I said, a combination of all three types of compensation available to them. Some folks may only have trust claims. Everyone is different, and we can't make a determination as to what a person is going to qualify for until we do a really complete and thorough investigation. And what we'll find is that every exposure matters. So with mesothelioma, we know that it is a disease that is a dose-response disease, and it is a product of a person's accumulation of exposures throughout their lifetime. So every exposure to asbestos is something that contributes to cause the disease, and every contributory exposure to asbestos is a potential source of recovery for a victim. Typically, someone who has mesothelioma has been exposed to asbestos in a myriad of ways and through different products. So there are a lot of options available in terms of compensation. That's not for everyone, but it's a very common situation. And for people who worked in an office setting, that's generally, or as a teacher, or as a nurse, they think to themselves, well, how did I get exposed? I didn't work in an industrial site. I wasn't an insulator. How could this have happened? Well, asbestos was so common and in so many products, you could have been exposed by patching a wall before painting. If you're a mom and you like to decorate and change up the house, but you've got 3 kids, 3 boys that, run through the house and they're constantly nicking up the walls, and you buy a joint compound to patch up those walls before painting the house, you've probably been exposed if you did that work prior to 1978. Changing brake pads on your car, or being present when your dad did that in the garage. There's a potential exposure there. So it's not just occupational. And as we've learned over the last several years, talc historically was contaminated with asbestos. So there are a myriad of products now that we know contained asbestos that several years ago we really didn't have an understanding as to how that exposure happened or how a person was exposed to asbestos. Now we look back and we see that there are women who've used cosmetic dusting powders on their body for 20 years, and that's their primary source of exposure. So it's really important that you speak to an attorney, even when you don't think that you were exposed to asbestos, or you can't figure out in your own head, how was I exposed? You need to talk to an attorney, someone who has the expertise and can take you through all these potential routes of exposure. Because if you were exposed, if we can figure out what that exposure is, there is a potential for financial recovery there. Literally thousands of products have contained asbestos over the years, so there are thousands of ways that people have been exposed to asbestos. One of the common concerns at the outset of our representation of clients is what kind of time commitment is required. People want to focus on their health and their medical treatment, as they should. This is a time in your life when you don't want to be dealing with lawyers. You want to be focusing on your medical care and your treatment. We respect that. We understand that. Your lawyer is going to work around your treatment schedule. Your treatment comes first. Your lawyer is going to come meet with you in your home where you're comfortable and at a time that works for you. Everyone has the ability to make that time commitment that works for them. So there may be situations where we have clients that don't want to spend a lot of time involved in a lawsuit. They don't want to give a deposition. They don't want to do that. Well, you do have options. You can just pursue bankruptcy trust claims if that's available to you. And that takes a lot less time, a lot less effort. But it's important to understand that there are different levels of time commitment, and everyone's different. And you can work with your lawyer to find that balance that works for you. A second concern often is people aren't, they're court averse, they're legal averse. They're intimidated by the legal process, and or they don't want to go inside of a courtroom. And Again, that's a decision that you can make. There are ways that you can obtain compensation that don't require you to sit through a courthouse to go through a lengthy court trial. There are certainly different options, so don't let that preclude you from at least pursuing what your options are and considering those. Another common question is, how long is this process going to take, right? It's going to vary. There are a myriad of factors that come into play. Trust claims, they generally take several weeks to several months to process after we've done our investigation and or gotten affidavits signed and submitted in support of those claims. Solvent claims is a completely different story. It can vary widely based on where your case is filed. Some jurisdictions, you can see your case go to trial within 9 months of filing. Others, depending on where that jurisdiction is and what the court backlog is, it can take up to 3 years. But again, even though that process may take a long time, there are generally multiple defendants in a case, and there will likely be settlements along the way. So the time is so variable. It can go from several weeks to a few years. VA claims generally take several months to process. You're dealing with the government, so it's really up to them and their timetable. But generally, those claims take several months to process. One of the important things to understand about the VA claims is once your lawyer knows that you were or believes that you were exposed in the military, the first step is to notify the VA that you intend to file a claim on behalf of your client. And that notice starts the clock ticking on the benefits, so that although you may not have all of the evidence needed to completely file that claim right now, we tell the VA right now, hey, we're going to file this claim on behalf of our client Joe. And then we're going to go back, we're going to work up Joe's case, develop all the evidence that we need, and then we fully file that case 6 months later on behalf of Joe. If the VA approves his claim, then the benefits start 6 months prior to when we first notified them. So with the VA, it's very important to get the clock going and to get the clock ticking as quickly as possible. So you want to notify them as soon as you can, because each month of benefits is over $3,000 a month. So that adds up very quickly. So you don't want to delay filing your VA claim. Medical insurance liens is another common concern among our clients. Generally, if you are able to obtain settlements, your medical insurance company, including Medicare, may have the right to try to seek reimbursement for a portion of what they paid as it relates to your medical care and treatment for mesothelioma. That is something that often causes concern for patients, but you should keep in mind that your attorney will handle the negotiation of those liens. They will work to reduce those liens to as little as possible and sometimes get them completely waived. And it's something that your law firm will handle for you. It's not something that the client necessarily needs to be concerned about personally. They don't have to deal with it. That's what the attorney is for. And another common question, an issue that comes about when we're talking to potential clients is, how do I know which law firm to choose? You know, I've talked to lawyers from various firms, and it's overwhelming. How do I make that decision as to why law firm A is better for me than law firm B? And, you know, what factors should I be looking for in a law firm to represent me? There are a number of objective factors that patients can look at when making that decision. And the first one, I think, is the most important, is experience. What is that firm's experience? You know, how long have they been around? Who are their lawyers? Get on their website, look at their attorneys, and see what their experience level is. the size of the law firm matters, right? Most of the companies that are sued in mesothelioma cases are large corporations. Corporations that we've all heard of, like General Electric, Honeywell, giant corporations, right, that have unlimited resources when it comes to defending legal claims. You don't want a small local firm with 1 or 2 attorneys handling that type of a case. And the reason why is because they're going to get buried in paper. They're going to get buried by the number of lawyers working on behalf of the corporation. You want a firm, you want an attorney that has the resources available to go up against giant corporations. And then there are also objective factors like the Better Business Bureau. You can inquire to see if that firm has a rating with the Better Business Bureau. You can go on state websites and look at the bar and see whether their attorneys have been disciplined. There are objective ways to look at the firm and make decisions based on those objective factors. There are also other factors that you should inquire about when interviewing law firms. One of the best things to ask a potential lawyer who wants to represent you in these types of claims is, does your firm handle other types of litigation? Are you specialized? Is the lawyer that is going to be working on my case somebody who only handles mesothelioma claims? Or are they going to be working on car accidents and medical malpractice and pharmaceutical claims and all of these other things? This is the type of specialized litigation where you want a specialized attorney, someone who knows the ins and outs of mesothelioma claims. You should also ask a potential law firm, who's going to be working on my case? Is it going to be a partner, a senior attorney? Is a partner going to be involved in my case from the very beginning? Or am I going to be working with a young associate with 1 or 2 years of experience and that isn't working under in a team situation with a partner that it knows what they're doing and is supervising and coordinating the litigation for you? You should also ask, if you are a military veteran, ask whether that firm will handle your VA claim for you. Not all law firms will handle VA claims. Our firm does, and a lot of them don't. So that's something, if you have a potential VA claim, you want your firm to be handling that claim because you want the evidence that's submitted as part of that VA claim to be consistent with your other claims that the law firm is pursuing for you. You don't want to file the VA claim on your own or work with a representative from the VA who may volunteer to help you with assisting in the filing of those claims. You really want a law firm that's going to handle all of the claims to make sure that everything is consistent. You should also ask a potential law firm whether they have handled cases involving the same work sites that you worked at, or if you were in the military, have you handled cases for people that served on the same naval ship that I did? Have you handled cases involving the same products that I was exposed to? You want someone that has experience with your particular exposures. In addition to that, you want someone who has the resources, who's handled those types of cases and has, for instance, prior documents from that site where you worked for 20 years. If I've already worked up a particular location and I've got all of the documents about where the different asbestos-containing products were located and where they were purchased and who the suppliers were, that's something that's going to benefit you in your case. Likewise, if I've worked up a case at a location where you worked for 20 years and I've got 5 prior depositions of workers from that location, all of that evidence can be used in your case and will help your case be more successful. That's it.
Thank you.
Thank you, Dawn. So we'll go ahead and have our other attorneys come up here now too. So joining Dawn is going to be Neil Maune. And Neil began the firm
MRHFM and is the managing partner, and so he's coming up right here. And then Greg Sandifer is coming as well, and he is with the Gori firm and works out of the St. Louis office. So all three of these attorneys are very experienced and welcome the questions that you have. I'm sure you understand that anything they tell you today is general information and, you know, not specific legal advice. There's a lot to know about what your case would be. But please go ahead. We've got microphones. There's a microphone here, and I'll walk around with one as well so we can make sure and hear folks. So what questions do you all have?
Oh, here I come.
Marissa?
First, thank you for coming today. I just had a question, again, about the medical liens and how that is affected once an asbestos exposure case becomes a wrongful death lawsuit, and how they are able to continue to pull those liens out.
Go ahead.
Sure. No, first question, I throw a tough one. No, that's okay.
Well, so you know, one interesting thing about things with medical liens, I'm older than these two, unfortunately, and I've been an attorney since 1989, and 20 years ago, we never dealt with medical liens, and this is something now, unfortunately, it's occurring all the time. But you want to go ahead and...
Sure. When there is a wrongful death case, there's also likely going to be a survival claim as well, which is going to involve the estate, so that when that person passes away, their medical bills are part of the estate, and that has to be paid back if there are or liens on that. So that's how that works. It's not a situation generally where if someone passes away, all of a sudden those medical liens are extinguished. They're still there. And if settlements have been reached on behalf of the victim during their lifetime, those are certainly subject to the liens, right? So you may have a situation too where you settle with a particular defendant while the patient is alive, and then they pass away before those funds are distributed, and those are also going to be subject to the lien. Does that answer your question?
So we actually have a medical liens department, and that's all they do is handle medical liens. And so it's really become a complex part of everyone's case now. And so it's just something we deal with. And if an insurance company's involved and they're paying for any of the medical bills, they're going to try to get paid 100 cents on the dollar. They always do now. And so it's just a part of every case now. Typically, it's a little better if Medicare is paying it or something like that, but the insurance companies are aggressive now in trying to get paid.
But there are also programs too. So the repayment of those medical liens, there are different programs that different law firms have negotiated with various insurance companies to keep those liens down, or to keep them at a minimum, or sometimes they'll even agree to waive them. So there are options, and hopefully, you know, the lawyer knows what they're doing and is negotiating those liens down as much as possible.
Okay.
But we have
Another question? All right, Maya will bring the microphone.
Again, thank you. Sorry. Thank you again for being here. I'm curious to know if you have any experience with any workman's comp settlements, any companies that want to settle as a workman's comp claim, and how far back that can go.
Yeah, work comp is going to vary by state. We certainly can settle in states that are favorable to that, a work comp claim in association with the asbestos claim. So, and that's going to vary by state. I think Neil can probably add to this. Some states are very favorable, and we aggressively pursue the comp claim if there's a premise or an employer to go against. But some states are not very favorable for that type of action. But I think most good firms will still get that worked out against that premise, against the target of that would have been the target of the work comp claim. So we will get it worked out. All good firms will still get that worked out. But I think very few states, Neil, you correct me if I'm wrong, but are still work comp favorable.
Yeah, I generally think that's true. Fortunately, there's some states where you can still sue your employers, and so that's an advantage, like Louisiana and Pennsylvania are a couple of examples. But yes, you had a follow-up?
Sorry about that. To be more clear, if the patient is no longer employed, if this would have been an exposure when employed, say, 20 years or more ago, I'm curious to know what that would look like if they come back, if it's a potential source of exposure, and they come back saying that they want to handle it as a workman's comp claim. I'm curious to know, is that possible? And if it is, what does that look like?
It can be under certain states' law if that was their last employer, okay? But it varies because some states have a specific statute of limitations that you're not going to be able to go back 20 years. And so sometimes that last employer won't be liable under workers' comp laws. But it just does depend, and that's one of those areas where every state kind of handles it somewhat differently, unfortunately. That's something you have to look into and get more information.
We have a number of questions coming from our live stream. One of them sort of along the line of conversation right now. How many years after the original filing can the independent medical company or Medicare keep asking for new reimbursements if the patient is still alive?
I don't think there's any limit on it, is there?
There's generally not a limit as if they're continuing to treat. I'm sorry.
Yeah.
Can you hear me now?
Yeah.
Okay. There's generally not a limit on that, but one of the things that we do for our clients when we can is negotiate that lien in full so that if, for instance, Medicare has a valid interest in seeking recovery, we will negotiate with Medicare to end the lien process. We're going to pay X amount of dollars and then it's over, right? They're not going to keep coming back to you. We can do the same thing with private insurance companies generally. We can't force them to do it, but a lot of the companies will negotiate those liens so that they have finality. But there is not necessarily a limit on future future medical liens.
Oh, you do? Okay. I have more questions from the live stream.
If you want to do that first.
Sure. I have a couple of questions about the statute of limitations. Is there a statute of limitations for meso claims? And another question is that wonders if that limit is 2 years from diagnosis.
So it's often 2 years, but it depends on the state again. California, for a personal injury case, it's a year. But then it's also a year from the date of death to bring a wrongful death case. And that's just one example. But there are some states with 3 years, a lot of states with 2 years, but it varies. And in some states, they'll allow that statute of limitations to begin to run at the date of death for a wrongful death case, too. But that's, again, it's going to vary from state to state.
Thank you. It's on. If this litigation process is, if we go forward with it and the person with mesothelioma dies, should the spouse continue to do that? Because in your payouts it said, possibly 3 years. Possibly 3 years. So if the process is started and that person passes away before,
before all the claims are paid out.
Right. Should they continue to do that, or is it just when that person dies, it's a dead duck?
They should continue to do that. Now, hopefully, if you have a specific example where someone's gone forward with something and filed claims, hopefully things like if they needed to get a deposition done of the plaintiff, or they needed to get affidavits prepared to file those for trust fund claims, hopefully that's already completed. And if it is done, then those claims can be filed and they can be settled and paid out, even though the person has passed away.
Maya?
Yes, ma'am.
There's another question over here.
Thank you.
Any comment
comments or update on the Johnson & Johnson situation?
So, all right. So that for people that don't know, Johnson & Johnson, which is a $460 billion corporation or something like that, has, in their infinite wisdom, claimed that they're bankrupt. And they filed, and what lawyers like us affectionately recall a Texas two-step. They filed, what they did is they moved the entire corporation from New Jersey to the state of Texas, and then in the course of less than a day, divided up into two corporations, one being LTL. They put all of their asbestos liabilities in LTL. Then they moved, and I think they put $500 million or something like that in LTL. Then moved Johnson & Johnson back to New Jersey, and then moved LTL to North Carolina, where they filed for bankruptcy protection, claiming that their asbestos liabilities of LTL exceeded the value of the company. So it's a maneuver that a number of companies have now tried. The latest is that our firm's been involved in this, and we've been fighting this aggressively, because if they can get away with it, then every corporation can get away with this type of maneuver. So the bankruptcy judge in New Jersey, the North Carolina action, we were successful in getting that transferred to New Jersey. The bankruptcy judge there unfortunately ruled against us, but the Third Circuit Court of Appeals, the United States Court of Appeals for the Third Circuit, has taken on the action, and they're going to hear an appeal, and now that appeal is going to be heard September 19th. We actually have reason to feel good, to feel positive about it. We think we can get that reversed. And if nothing else, there's currently an injunction in place that prevents us from suing Johnson & Johnson. If nothing else, if we can get the injunction reversed, where we can continue litigation against Johnson & Johnson, that'd be a big win for us. We take that. So that's the latest. I mean, stay tuned, September 19th, that's the hearing date. We'll probably have a better idea of what's going to go on after that. I believe they're also going to allow, it's the Department of Justice, they're allowing them to argue at that hearing also. And so I think the Department of Justice is also going to get 15 minutes to argue on our behalf. We're happy about, and so we'll see. We'll see what happens.
Other questions in the room? We have a few more from the live stream, so I'll go ahead on to those. Since asbestos is still out in the world, especially in older buildings, so exposure can continue to occur. Is there a reason why there's that 1978 cutoff when discussing claims?
Oh, that 1978 cutoff was just an example for one particular product, and that's drywall joint compound contained asbestos until it was banned in 1978. But we now know actually contained asbestos beyond that, because they substituted asbestos with talc at the time, which we now know contained asbestos. So that 1978 was particular to one particular product. No, exposures continue to happen today. Exposures have never stopped happening in the United States, even after particular products banned, or the use of asbestos was banned in particular products. And asbestos claims will unfortunately continue for many years to come.
So, you know, this is kind of funny, because we were sitting around chatting earlier, and when Dawn first got out of law school, now I'm dating you, 20 years ago, she interviewed with a firm, and she was told that asbestos litigation was going to end in the near future.
And so I should unfortunately go interview at an asbestos firm, because I wouldn't have job security.
Yeah, and unfortunately it hasn't gone away. You know, I think a lot of people read about Johnson & Johnson as an example. Their baby powder contained asbestos in it up until them taking it off the shelf. I guess it was 2 years ago?
2 or 3 years ago.
Yeah, FDA had them pull it off the shelf, but unfortunately products have continued to be sold in the U.S. that contain asbestos. And quite frankly, we import products from all over the world, Korea, China, everywhere else. I imagine all sorts of products still contain asbestos, and we'll see this litigation and unfortunately people getting this disease for a long time.
We'll take one last question. We're out of time. Just one more.
curious about the trusts, since they were established a while ago and the claims continue. Are the payouts from the trusts going down? Will they run out of money for patients that get diagnosed as we, go down in further in the years?
So they've gone down over time. And unfortunately, with investments, investment returns going down here in recent times, they'll probably go down even lower. And because, that's a lot of what they're paying the money out based on, what they're predicting over the course of the next 30, 40 years. And when investment returns aren't as good, then they lower their payouts. But I think almost every trust fund, I'm trying to think of any that hasn't, but I think they've almost all gone down over time. So they're paying less and less. Johns Manville, I think originally, because they thought the number of people getting mesothelioma was going to start to drop off, and I'm really dating myself here, but I think they were predicting that in 2005, the number of mesothelioma patients would drop off, and so they used to pay $26,250 to people that had claims against Johns Manville. Now they're paying $17,850, and their metrics that they used, I mean, they're off, and they haven't gone down, and so that's why they've decreased the amount of payments. So, and that'll probably continue.
Okay, I'd like to thank Neil and Greg and Dawn for presenting that information to us. Hope that it gave you some more insights into some of that legal process and answered some of your questions. And it is 3:45, so we are very shortly, or even immediately, going to be getting into our next session. Maya, are we having a break at all? Nope? Okay. All right, we are going to go right into our next session.
Thank you, Cheryl. Thanks so much. That was awesome. Hi, everybody. We're in the home stretch. Let's see. So we're back, and now we are zooming in Dr. Marjorie Zotterer, who is the chair of our board, and who will be giving a brief update on what we've been talking about over in the scientific meeting, and to help you understand the direction, some of the directions that our foundation will be going into from a lay perspective. For those of you who have not yet met Dr. Zotterer, she's the co-director of the Memorial Sloan Kettering Mesothelioma Program and is associate attending on the Thoracic Oncology Service in the Department of Medicine at Memorial Sloan Kettering Cancer Center. Dr. Zotterer, I turn it over to you. Thank you so much for joining us virtually.
To say hi to everyone and thank you so much for coming. I'm so sorry I'm not there in person to meet with all of you and to spend time together. But I just wanted to start by thanking Julie, Shannon, Maya, Megan, and the rest of the Meso staff for really pulling off an amazing conference. I know in the scientific session, we had a great time and really amazing discussions. And I've heard great things about the sessions that you guys have been engaged today. And it was no small feat to pull this off in the middle of a sort of quasi post still in it kind of pandemic moment. So I just want to take a moment and thank the team. So thank you very much. I did want to share with you some updates that we had from the scientific session. We had a lot of people in the room, as well as a bunch of people joining remotely on Zoom. And we started our day off talking about emerging therapeutics. And this conversation really focused on lots of folks weighing in on new treatments in study, under development, and which ones seem to be the most promising. There was a lot of talk in that conversation also about how we can most efficiently study new treatments and get them to the clinic and to patients and get them through the regulatory process if they are effective more efficiently and quickly. And a lot of those conversations focused on some of the T-cell clinical trials that have been going on at different centers around the country that some of you may have heard about or read about. We then moved on and we had a interesting conversation about initial therapies for mesothelioma. And we talked about how with the new approval of immunotherapy with the ipilimumab and the nivolumab medications, that the standard of care has changed, but that there are also other ongoing studies asking the question, should some people get chemotherapy with one immunotherapy drug? And is that actually a good or even better treatment approach for certain types of patients? And sort of where the field is going and how we think about what's going to be the standard, the new standard based on these ongoing studies. And it seemed like there was a lot of different opinions on how some of these studies might influence how people practice, but that ultimately, until we see those results, it's hard to really speculate. And there was also a lot of conversation about the role of surgery and when to do it. And certainly given that tumors that are sarcomatoid entirely or have a significant sarcomatoid component, that traditionally we haven't done as much surgery for folks with those types of tumors. But now with these amazing responses to immunotherapy, that it may be time to revisit how we think about that. And there were some conversations about some trials that are starting up at different institutions and one through a cooperative group about really looking at the role of surgery and the histologic subtype that we've always classically thought of as something that we shouldn't do surgery on, and that we have to reassess that. We then had a conversation about research priorities, and we had polled our scientific community to talk about the things that seemed most important to them and what those would be. And we had a good conversation around that. You know, the major areas of interest were around early diagnosis, non-invasive testing, better understanding the genetics and the quality of life. The second sort of bucket was around the role of surgery, when and how and who and what to combine it with. There was another sort of conversation and bucket around what about the people who don't respond to immunotherapy with their tumors, or tumors that respond but then stop responding, and really thinking about what comes next, as well as looking at the people who have amazing responses in their cancers to immunotherapy and what makes them different and why does that happen, and can we make that a reality for more people. And then the fourth sort of tranche was novel drugs, novel targets, what those targets are, how we advance the treatments around them. Then Shannon facilitated a discussion with the group around best practices and talked about some questions that come up from all of you as she talks to you about heated intraoperative chemotherapy, when to do surgery, if at all, in sarcomatoid disease, and some of the best approaches of thinking about surgery come first, should systemic therapy come first, and how to best sort of approach that. And it was interesting because it seemed like each institution did it a little differently. So at least for pleural disease, there were some places where they always do surgery first, some places where they always do chemo first, and some centers where it depends on the particular patient and disease circumstances. And so there was a lot of really great conversation about working towards standardizing these approaches so that we make the best decisions possible, and that it's more uniform across the different centers. And then finally, we closed up just now with a really vigorous discussion and a lot of enthusiasm around the foundation working to create designation for centers of excellence, both to help patients navigate where to go for treatment, but also to help community providers access expertise when they need it. So even if you can't make it to a center that has a very high volume, your local doctor at least can get you a consultation virtually with that place and really build up that network so that expertise is more distributed geographically, more accessible to people. And also ensuring that, we highlight the places where that expertise does exist for patients who are trying to navigate what can sometimes be a confusing process. So we left those sessions with a lot of things on our to-do list. We're going to have some small working groups that we build around the centers of excellence, around thinking about standardization of collecting research samples and making decisions about surgery. And if we can't have a consensus, then we're going to think about clinical trials to help answer those questions where there's still debate and uncertainty. And so all in all, I think it was a great meeting and a lot of really engaged practitioners spanning all the different specialties and surgery, pathology, medical oncology, people in the lab, people who do clinical trials. So it was a really great, diverse group focused on trying to improve treatments for mesothelioma. I think that's my summary. And with that, I would pass it back to you, Julie.
Well, thank you, Dr. Zotterer. Thanks for zooming back in. I know it's been a long day on camera yesterday and today, and we really appreciate you. So we're going to all say goodbye so you can get back to your family. So thank you for being with us. Thanks again, everyone. And in the energy, bandwidth, and the sheer exhaustion that comes from putting on a conference, I'm going to say this. On behalf of the foundation staff, board, our volunteers, thank you all for being here. Thank you to our generous sponsors for making today possible. And safe travels. Go home, go enjoy Chicago, whatever it is that you're going to do next. Thank you for being here, and we will see you again soon. Hopefully without masks, but even if not, we're going to try and get back together again in a year. Thanks, everybody, and have a great week. And